ఏంటంటే నైట్ వాళ్ళకి డీటెయిల్స్ పంపించినప్పుడు ట్రై చేశారు. అప్పుడు మీకు మళ్ళీ ఓటీపీ ఆ టైంలో ఇది ఇప్పుడు నేను చెప్పాను.
చూసుకో ఒకవేళ స్టార్టింగ్ అనుకో ట్రైపాడ్ పెట్టేసి ఫ్రేమ్ పెట్టి ఇక్కడ కొట్టు.
నువ్వు వెళ్ళొస్తావా డాక్టర్ ఒకటి ఒకటి 85 mm దగ్గర పెట్టుకోవాలి తీస్తా ఏది సి టైపా
ఏ సి
అంత హైటా
స్టార్ట్ చేస్తాను.
ఏంటి ఇట్లా స్క్రీన్
కరెక్ట్ పెట్టది డౌన్ అయింది కింద
చూడండి అది అంతేనా మొత్తం లాస్ట్ స్టార్ట్ చేసి
మాట్లాడాలా
Check one, check. వస్తుందా సబ్బు? Check one.
Very pleasant morning to all the delegates here. On behalf of Genesis, I welcome you all to Genesis Infertility Update 2022. I am Dr. Nafis. I have done my MBBS from Osmania Medical College and post-graduation from Jimmer. And I have done my postdoctoral fellowship in reproductive medicine from 49 Hospital. And I am truly blessed and honored to be working as junior consultant at Genesis Fertility Center. So now I request our Honorable Managing Director, Dr. Thank you.
Hello all. Welcome to Genesis Fertility Update. I hope I'm audible and visible. Yeah. So I'm Dr. Navita, Medical Director of Genesis Fertility and Laboratory Center. We just had our 5th anniversary yesterday. The gist of the conference, I want to combine all the peeled banana for all of us to understand how easy it is to decide what genetic evaluation a couple need. Next, we have a legend, Dr. TLN Praveen. He'll be talking about ultrasound dimensions in clinical enigma. Wherever we are confused, he'll just clarify what. I'm taking an opportunity to felicitate the teachers who made me what I am today. It won't interrupt the program. The coffee and the felicitation happen hand in hand. Followed by current management of concepts of fertility and endometriosis by Dr. Ruma Sinha, who is a very famous laparoscopic and robotic surgeon. Then I'll moderate a panel discussion with all the specialties I've said: radiologist, andrologist, geneticist, gynecologist, ART specialist, and embryologist team from Genesis. Followed by lunch, and then we have 3 more talks. The first one will be simplifying approach to recurrent pregnancy loss. We all see so many patients coming with 1, 2, 3 miscarriages and sometimes 8 miscarriages, and we don't know what to do. The word of recurrent pregnancy loss makes us panic, and then it will be simplified how you can approach them. And that talk will be by Professor Prashant from Manipal. The current concepts of male infertility by Dr. Rahul Reddy, and the closing talk will be by myself in dilemmas and discussions. All these cases are cases we saw in Genesis where there can be more than one answer how to treat them, and then followed by the final vote of thanks. So why am I doing this conference? Obviously every time we'll have desires and we want an outcome. What's my desire? I don't want a genie from Aladdin's lamp. One desire I have: share knowledge of the updates and minimum standards that we all should follow in gynecology. And the second one is truly understand there's more than one way to do the same thing right. If somebody has done, we don't need to say this could have been done differently, as long as the patient is safe and the outcome has been achieved. And the outcome I want, every conference, every talk I say that, take home message, at least one, to change your practice at the end of the day. Thank you. Enjoy the day. You all to put your mobiles in a switch off mode, and I'd like to tell you that the washrooms are on the right side. So first we'll go through a brief introduction of our first speaker, Dr. Anuradha Udumudi. She is the founder, GeneTech, Genetics and Genomic Labs, Hyderabad, India. She has done her PhD in human genetics. She's got a vast experience of 27 years in medical genetics. She has designed multiple novel, economic and application-oriented diagnostic tests. She has done postdoctoral work and experience in USA labs.
She in UMENJ Medical School, Waxman Institute, Integrated Lab Systems, and Laboratory Corporation of America. She is been awarded with Young Scientist Award of Environmental Intelligence Society, USA. She has got various publications in reputed journals. She's reviewer, author of medical book chapters and higher education courses. She has delivered over 350 plus CME lectures across state, national and international conferences. She has conducted more than 200 plus genetic awareness programs exclusively, at least in South India. She has designed world's first and most comprehensive NGS-based genomic panels for fertility practice that was presented at ACMG 2019, ISAR 2021, ASRM 2021, and other international platforms. Now I would request our esteemed speaker, Dr. Anuradha Udmudi, to give us valuable insights.
Thank you everyone for being present here morning on a weekend. And congratulations Dr. Narmada on your 5th anniversary, and I wish you all the best for all your future endeavors. So with that, and I'm also really happy that you've chosen to felicitate your teachers, and congratulations to you and to your teachers on your achievement. So let's start the lecture today on they're really good at trying to sell something. So this is Narmada requested me to talk about preconception genetic screening. So I will not be dealing a lot about the pregnancy and pregnancy related abnormalities, but mostly, of course, I will go into certain fetal development and recurrent pregnancy loss cases. But mostly, what would you do if there is a case of infertility, or all these cases for that matter, prolonged infertility, recurrent pregnancy losses, fetal ultrasound abnormalities, history of a child with mental retardation or autism, or a developmental problem, or a family history, extended family history, not your immediate family history, consanguinity related abnormal issues, and sometimes even including inherited cancer history, and then what do you actually do in your routine prenatal screening, etc. So let us cover all these things. And so this is my first slide, where I usually present this slide, so if some of you have already seen it, you should pardon me. But this is the basic idea that every obstetrician or a practicing doctor should have about genetics. We have 46 chromosomes, and within each of these chromosomes there is a long strand of DNA, and on that DNA we have what is called the genetic code, which expresses and performs its function to produce certain proteins which perform different functions in our body. So if you have a problem at chromosome level, it is like a biggest problem ever, in the sense a large part of DNA is involved here in chromosomal problems. Then the next problem is the DNA problem. So you can actually look at your genetic problems at the chromosome level, at the DNA level, or sometimes at the protein level. For example, if you are diagnosing something like a galactosemia, you're just looking at the protein and you're identifying that there is a genetic disorder. If you're looking at something like a thalassemia, you're just looking at the DNA, identifying the mutation. If you're looking at something like a Down syndrome, you're looking at the chromosomes and you're identifying whether it is a genetic disorder or not. So we have different technologies which will allow us to diagnose genetic disorders in the lab. I will not have lot of technical slides. This is the only slide, and I always insist that this slide should be understood very well by practicing physicians, so that they understand what tests to refer for their families or the cases. So here you can see that when you are looking at your complete chromosome, it's called karyotyping. Or this karyotyping is done by naked eye. We look through the microscope and we identify abnormalities. So whatever is visible through our naked eye is what we can identify. We cannot go beyond that. So sometimes structural abnormalities or bigger deletions, bigger duplications, translocations, all these things which are around 5 MB in size. Now that we all know MBs, KBs, 5 MB in size is recognized under microscope. That's karyotyping. But what if you want to see smaller deletions and duplications which you cannot actually see through your microscope? That is where your cytomicroarray comes into picture. So cytomicroarray will be able to look at 50 kb and more than 50 kb. So it's a very small piece and you cannot look through your microscope to identify this. But because cytomicroarray is a DNA test, it will allow you to look at all your chromosomes, of course aneuploidy, but also smaller deletions and duplications. But what if you really want to go beyond 50 kb, smaller than 50 kb? You want to sequence a gene, you want to see a single nucleotide change. For example, here what you see on the genetic code is TAT, but here you have in the patient PCT. So the A has become C. So if you see such a single nucleotide change, you need to look at sequencing. So that is where your NGS, Sanger sequencing, PCR tests, all these come into picture, where you are looking at a single nucleotide change at the gene level. So now with that background, we now know what to order. So I'll just go into cases now. So let's first look at prolonged infertility and recurrent pregnancy losses. Prolonged infertility or recurrent pregnancy losses, the first tier test everybody uses and must use is parental karyotyping. So you first do a parental karyotyping and you identify if there are any balanced translocations, because the parent will look perfectly normal, because a part of one chromosome is sitting on another chromosome, but all chromosomes are inside the cell. Therefore, a balanced translocation carrier will look perfectly normal but will present infertility or recurrent pregnancy losses. But how many times do we really see abnormal karyotypes in our practice? Less than 5% of the time. 90 to 95% of the time, we are seeing karyotypes which are normal, but the clinical presentation is prolonged infertility or recurrent pregnancy losses. Here is one case of balanced translocation that you can see. A part of 2 has moved to 4th chromosome and therefore the parent is normal, but the production of gametes will be disturbed and therefore there will be a bad obstetric history. So what about this 85 to 90% of cases where there is no diagnosis? Of course we do for infertility AZF gene deletions or maybe FSH mutations for stimulation purposes and all. But most of the time all these reports come out normal. So that's where we need to actually look into the genes which are associated with gametogenesis to implantation. Gametogenesis, maturation of the gamete, how the implantation happens, are there any thrombophilia related pregnancy loss risks or any immunology related pregnancy loss risks and things like that. That is where our NGS program, which allows us to look at multiple genes and multiple mutations, comes into picture. So we have developed certain things which are useful for Indian population with our AI program, and we do what is called gene andro for male, gene femina for female, and gene RPL for just the recurrent pregnancy losses, which looks at all these cases. I'll just quickly look at this and then we will go into bad obstetric history. This is AZF gene deletions. Every one of you know that male infertility, especially azoospermia and severe oligospermia, might be associated with AZF gene deletions. There are 3 regions of AZF gene, A, B, C. If the C is deleted, you will have a good prognosis. You can do TISA and go ahead. But if A and B are deleted, the regions of the gene, then we will have poor prognosis. And in such cases, we need not really waste time, and we could recommend donor sperm in those cases. I just wanted to present this because we always think that FSHR is only associated with female infertility, but FSHR is also associated with male infertility and impaired spermatogenesis. And those carriers of FSHR mutation, males with impaired spermatogenesis, respond well to recombinant FSH, and post recombinant FSH ART program or even normal conceptions are good prognosis is recorded. This is the paper that I have published with Dr. Narmada. I am very proud about this, and she was the first person to actually show a case where recombinant FSH has worked out, and we are now presenting 50 cases of the same very soon in an international journal. So this is just a glimpse of an example of how mutations can actually. So if you have a patient with a normal karyotype and you don't know what is going on, that is where we need to look into these cases. Here is a case where there is a TUBB8 gene mutation. It does not allow spindle fibers to separate properly, and therefore there are a lot of errors in gametogenesis, and it will lead to aneuploidy, and these patients inevitably will have infertility whatever you may do, and therefore a donor oocyte will be required in this case. This is a case, these are just 4 cases of recurrent pregnancy losses. I have shown you how all 4 cases have normal karyotype but with mutations at different levels. In first case, you see that there are 3 genes which are involved in thrombophilia: MTHFR, PROZ and VEGFA. People usually think it's prothrombin F2 or F5 that is involved in thrombophilia related pregnancy losses, but that is not the case in Indian population. So there are some other genes that are associated with thrombophilia, and if you know about them, you can do a preventive management by giving therapeutic anticoagulant dose and other things. If the aneuploidy risk is high because of the gene mutation, then also you can do preventive management. In this case, we found that this woman has immunology related dysregulated immunity, and therefore anti-inflammatory immune support could be provided to that person. Similarly, if you have RPL and preeclampsia risk, there are other genes that are associated. There are certain variations in certain genes where antioxidative supplementation will be extremely helpful, and these are the individuals where the anti-apoptosis response in placental trophoblasts is very poor because of certain gene mutations, and therefore we recognize these individuals and we do personalized treatment to them so that the success rate increases. So that's about the constitutional testing, where you are actually testing the parents. Either do a blood karyotyping. If the blood karyotyping is normal, then check your gene mutations, wide variety of gene mutations. But what about the cases where the fetal sample has to be tested? The pregnancy loss already occurred. So the first and the foremost test that is recommended for your fetal blood sample is cytomicroarray. There are n number of publications. This is an old slide. Every guideline now says the first year test for products of conception should be cytomicroarray if you have lost a pregnancy. Now many of us are used to karyotyping of the products of conception, but the problem with karyotyping is around 85% of them don't grow in culture. For a cell to be visualized under a microscope, it has to be in a dividing stage, and if the cells are already non-viable, or if the cells come with contamination, there is no way the lab can actually see a dividing cell under the microscope, and that is why you have culture failures. Therefore, the best test to be done on all products of conception is a cytomicroarray. Now that brings us to the question. Now I'm not going into these details, but cytomicroarray actually also gives you, not just the aneuploidy, but also smaller copy number variations, which are micro deletions and duplications of smaller size, like I said in my first slide, around 50 kb. So here you can see a wide variety of things that you can diagnose. You can diagnose a trisomy, you can diagnose a monosomy, which is full chromosome. You can diagnose micro duplications, which are deleted, or you can have a micro duplication is blue, deletion is in red, and you can. But the problem with this cytomicroarray or any DNA test for that matter is they will give you a result saying this is an uncertain significance, or this is likely pathogenic, or this is pathogenic, right? You've seen your reports. And when you say uncertain significance, what does it mean? I will quickly tell you from a lab perspective what is uncertain. Do I have time? Someone has to tell me, otherwise I. Okay, just 5 minutes before 10 minutes. Okay. So uncertain significance is where the lab thinks there is a correlation but no publication available. So that becomes uncertain significance because we cannot report that it is pathogenic unless there is a case that has been reported. So there are a lot of lab variations, and in those cases what we do is this. So here you see a case of 13 weeks pathogenic deletion found in the fetus, and 10 genes have been deleted because of the deletion, and it is usually sporadic and it is not inherited. Parental karyotyping was normal. Now please remember, don't do arrays on blood sample of the parents, because arrays are designed for unbalanced detection. In the sense, you have to either have a deletion or duplication or it will detect it. But because it is a DNA test, a balanced translocation will come out as normal in cytomicroarray. So if you are analyzing parents, you have to do blood karyotyping. So that's one message that you have to take. In this case, we have a microdeletion. It is a Cry-do-Chat syndrome. We did parental karyotyping and we found that the father is a balanced translocation. So because of the balanced translocation in the father, there is unbalanced gamete produced, and therefore it has resulted in Cry-do-Chat kind of problem in the baby. Here the risk is 15% for the patient. Sometimes you see ultrasound abnormalities. Here also you can see that there is, whenever we say that there is an uncertain significance, I think this is not, okay, that's fine. Whenever we see that there is an uncertain significance, we also do the father and mother array, only in these cases. And if the parent also carries the same variation, we say that it is non-pathogenic. Many of the ultrasound abnormalities also cytomicroarray will be recommended as the first tier test, especially if it is a syndromic presentation. So now after all this, you might have patients who will come and tell, we did not evaluate the previous pregnancy, now what to do? So that is a major problem. If we have the index case evaluated, then our counseling and your job also becomes very easy. We know what we are looking at, right? So in that case, you please request your families to at least store the DNA. If not do any test, that is fine. At least store the DNA so that when they plan for their next pregnancy, before planning, they will have some time to think about it and go for analysis. Consanguinity risk, you all know, we have for recessive disorders. We all share, you and I also share less than 1% of genes. But consanguinity, they share a lot of bad things, which are mutations. I mean, I shouldn't call bad, but they're just changes. So because it is shared, both the mutations can come together. There is 25% risk of giving birth to a child with recessive disorder. That's the risk that we have. So if you see that there are some other cases that I just thought I will present. Someone can come to you with spinal muscular atrophy, previous history, and these are the cases where we already know what gene is involved. And it is a small PCR test. For this you need not do exome or array, or you need not go for bigger tests. It's a small PCR test that will tell us whether there is a small deletion on that SMN gene or not. So there are some cases where the latest genomic technologies are not required. A small PCR test will be able to identify and give you results at a very, very economical price. This is a case of beta thalassemia. This is how your sequencing reports will look like. There are 4 colors, which means there are A, G, C, T, 4 bases. We look at those graphs and we tell you whether it is a homozygous or heterozygous mutation. If thalassemia is found in the proband, there is 25% in next pregnancy, and you can offer prenatal diagnosis or PGTA or PGTM for cases if you want to test on embryo. Just an interesting case of hearing loss. Whenever you see families with hearing loss, you please look at the baby and you identify whether the hearing loss is syndromic or non-syndromic. The simplest form of looking at the genetic problem is, if it is syndromic, you do an array. If it is non-syndromic, an isolated hearing loss, congenital isolated hearing loss, please go in for an exome sequencing, because there are multiple genes that are associated with isolated hearing loss. So these are some of the guidelines that you could look at, because 50% of hearing loss is genetic and 70% are non-syndromic. Out of those 70%, 75% are recessive forms. So we will see quite a bit of these in consanguineous marriages. A lot of you will see DMD cases. DMD cases, mother is a female carrier, unaffected, only males will be affected. So in these cases, when they come to us, we sequence the dystrophin gene and we identify whether the mother is a carrier or not. If the proband is available, it's well and good. Even if the proband is not available, we can test the female and we can tell you whether the female is a carrier or not. If she is a carrier, then male offspring will have 50% risk in X-linked disorders. This one case I just want to tell you quickly that autism is again very commonly seen. Developmental problem, ADHD, intellectual disability. Here also, like hearing loss, you can either use a cytomicroarray or you can use an exome sequencing. So how do you decide what is the best test to be done? So there are guidelines which clearly indicate that cytomicroarray is the first tier test for all autism spectrum disorders. So if the child is available, please do a cytomicroarray for all developmental or intellectual disability or autism spectrum related disorders. If the cytomicroarray comes normal, then you can go in for exome sequencing. In this case, a 3-year-old autism spectrum disorder, we found a pathogenic mutation in cytomicroarray and we have counseled them that it is a low recurrence risk. In second case, the cytomicroarray is normal, therefore we did exome sequencing and we found a recessive mutation on SHANK3 gene, and here we found that the parents are also carriers of this same mutation, and therefore we offered prenatal or pre-implantation programs. So another thing that you will anyway do as a preconceptional screening is your NIPT or a double marker test or a quadruple test. There are several ways of doing this. Most of them do double marker, which is the best screening method. Sometimes they repeat screening. I would request not to repeat screening because it just confuses which one is false positive, which one is false negative. Whenever double marker comes positive, you counsel the patients saying either go in for NIPT or wait till 16th week and get an amniocentesis or go to CVS. We just have to counsel them about this, and NIPT is the highest sensitive, 99%. Many people ask me, do you separate fetal DNA and then do NIPT? We don't separate any DNA. We just get the DNA from mother's blood, babies. We just quantify it, and then we know as per the statistics that a mother who does not carry a Down syndrome baby will have so many fragments of 21 chromosome, and a mother who has a baby with Down syndrome will have this much number of 21 fragments. Because we know that statistical information, we compare the patient DNA fragments with that statistics, and we will tell you that's why it is still screening. That's why it's not diagnostic, but it is 99% accurate. So if the double marker is high risk, you can ask for an NIPT, which will reduce the amniocentesis procedures. If the NIPT comes out positive, you have to go in for amniocentesis. Some of the patients are very insistent that I don't want to go through another, however high it is, we want to go for diagnosis. In that case, direct amniocentesis must be recommended or CVS program. So you can use NIPT as a primary screen. In India, probably that's not possible right away. Primary screen in the sense, don't offer double marker, just go ahead and offer NIPT. If that is not the case, NIPT, another good thing is it will cover 46 chromosomes. So you're not actually looking at trisomy 18, 13, 21, but you're looking at everything else. So that's the best thing to do, but due to financial constraint, if we can't do that, at least double marker has to be offered for aneuploidies. The last slide, for those who want to do pre-implantation testing, there are different options, there are different names, but it's really truly simple. We are looking at number of chromosomes, it's called PGTA, aneuploidy. So you send the embryos and then we do the test and we tell you that it has 46 chromosomes or it has partial aneuploidy or whatever. So if that happens, that is PGTA. And this is done either routinely or to increase implantation success, or if the parents have had a history of some aneuploidy. Then next thing is the PGT-SR. PGT-SR means it is a structural abnormality. You are looking at the translocation of the parent in the embryo. So that is called structural abnormality, very similar to aneuploidy, looking at the chromosomes. Then the third is called PGT-M. PGT-M is for single Mendelian disorders, single gene disorders. So if you are looking for one mutation, you are not interested in whole number of chromosomes, right? You are only looking at that mutation. That is PGT-M. So if you want to test for thalassemia, DMD, or for any other disorder that parents are carrier for, then you go in for baby. There's also a technology of NICS, which is called non-invasive chromosomal screening, which is done on embryo media, and this is also highly successful, but the sensitivity rates are slightly compromising at that point. So we tell patients that if you want to go in for a highly sensitive test, it is the embryo biopsy still, but NICS can be offered with slightly compromised sensitivity, and the labs are working really hard to improve the sensitivity, and once it reaches PGT-A sensitivity, then I don't think embryo testing will be required anymore in future. But yeah, I mean it all depends on the proof of sensitivity, which may take some time for the labs. So whatever may be the case for all these, we have to have what is called the genetic counseling session for parents. Many cases where I have seen, I've counseled patients and they come up with questions. For example, I counseled a couple saying you will have 1 in 4 risk. They go back, come back again with the baby with the recessive disorder, and when I ask them, they say, you said 1 in 4, we thought the 1 is already abnormal, the other 3 are going to be normal. This is possible, this has happened, and I always repeat because I realized that there could be communication error from our side also. So from then onwards, every counseling we will do a letter, and the letter goes to the doctor so that the patient, although they want to hear what they want to hear, the communication between the geneticist and the doctor has to be extremely clear, and that can be in a written format, which will help both the patients and also physicians. COVID has taught us how to do telephonic counseling also. So, yeah, thank you. Thank you very much. And if you have questions I can take, or maybe.
Good morning, ma'am.
Good morning.
If the patient is infertile, can we offer NIPT at the weeks of 10 weeks?
Yes.
Without,
After 10 weeks, anytime. We'll have sufficient DNA.
Okay.
So, if you offer before 10 weeks, the percentage of fetal DNA in the mother's blood will be very, very low. And therefore, we cannot offer. So, after 10 weeks, anytime you can offer NIPT.
Is there any difference, madam, NIPT doing at 10 weeks and NIPT doing about 20 weeks?
No, NIPT at 10 weeks to NIPT at 30 weeks also there is no difference, because the statistics will, the bioinformatics data that we have, which we use for analysis, we have for each gestation. So if you send us a 10-week, post 10 weeks, we'll compare it with 20 weeks. If it is 30 weeks, it is 30 weeks. So the data is all available for analysis. Wait for a week and send.
Okay. But and one more thing, madam, if NIPT comes negative at the weeks of 10 to 11 weeks, can we take it as 100%?
99%. 99% sensitive, but yes, 100% you can actually take, because the thing is, when we say positive, amniocentesis can come negative. 1% of the time. But then if the NIPT comes out positive, 100% of the time you will see that amniocentesis is also positive.
So no need to repeat after 20.
Double marker, quadruple marker, just do one screening. If that screening is positive, go ahead with amniocentesis.
Okay. Thank you.
Is there any cutoff for this NIPT?
There is nothing, sir. But the thing is, practically, it doesn't make sense.
The fact that the termination of pregnancy is gone beyond 20.
So then it doesn't make sense. But at 30 weeks also we can do NIPT. It's not a problem. 10 weeks is the lower limit. So yes, ma'am, that's a very highly sensitive test, and it is very, very likely that you will see an abnormality in amniocentesis. But as per guidelines, amniocentesis is still required, ma'am. Very, 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 very rare conditions, there can be something like a placental mosaicism. In such cases, we might have a positive NIPT and then a normal amniocentesis result. So it's always better to offer prenatal diagnosis counsel than for a amniocentesis procedure. But you will still reduce the number of amniocentesis procedures because of the very high sensitive NIPT. But I think amniocentesis should be recommended after NIPT positive.
So can we come to the conclusion? If NIPT is negative, there is no need to go for amniocentesis. If it is positive only, we should go.
Yes, 100%. That's the message.
Good morning, ma'am. Excellent presentation.
Thank you
and
so much.
very precise. I would like to share about a case. This was regarding she delivered, everything was normal, we did all the screens, and somewhere around 5th month of baby's age, baby developed a lot of diarrhea and all that. But then they went to Rainbow, and there it was picked up, and she was labeled, the baby was labeled as Viscott-Eldred syndrome.
Okay.
And now she, but then baby succumbed. After maybe 15 days of, so that's something to do with the primary immune disorder, it seems, Viscott-Eldred syndrome. Now she comes back to me asking how what do I counsel in that situation?
So definitely when they have diagnosed the syndrome, either it can be a clinical diagnosis based on the biochemistry or the clinical presentation, the phenotype, or it could have been based on a genetic test. Now NIPT, all said and done, is only looking at chromosomes, like a cytomicroarray. It's looking at your chromosomes, and it's looking also at the smaller deletions and duplications, partial deletion and duplications. But beyond that, if there is something, NIPT is not going to detect it. So in this case, we have to do a counseling and understand, was a genetic test done? If a genetic test was done, what is the gene that is involved? Is that a recessive gene or a dominant gene? If it is a dominant gene, there is not going to be a risk for next pregnancy. If it is a recessive gene, there will be 25% risk, or is it X-linked? In such case, only males will be affected. We also have to understand the family history, and based on that, we will have to give them guidance as to what to be done in next pregnancy, or is there consanguinity? This is a good question, because now this autoimmune disorder could be a recessive disorder, and maybe we might counsel them saying you have 25% risk, we now know the mutation, we will just check for that mutation in next pregnancy, everything will be okay. But then if they are consanguineous, you will have to go a step ahead and tell them that they might have risk for multiple disorders. So because of that 1/8 shared genes, a consanguineous couple can have 2, 3, 4 disorders risk. And in such case, we have to do a carrier screening for the couple to identify what all risks they have. If they have only one, that's very lucky. We can just go ahead testing for that. So it requires a holistic approach. We have to look at the cases, look at the genetic testing done in past, and then counsel them. If you can send me the report, I can give you more information. Thank you. Thank you.
Thank you very much, ma'am, for sharing profound knowledge on genetic screening. Now, I hope all of us have got a hang on what tests to order, when to order, and how to interpret and how to counsel the patients. It was very informative session, ma'am. Thank you very much. Now, I would request Dr. Aruna madam to present a token of memento to Dr. Anuradha madam. Please give a huge round of applause, please. Our next speaker would be Dr. T.L.N. Praveen sir. He's a professor of radiology, director at Abhishek's Institutes of Imageology. He's been practicing fetal medicine since past 35 years. He is passionate about fetus and performing invasive procedures. He takes special focus on teaching and training postdoctoral students. His other hobbies include running and hiking. He is a recipient of various awards. For the Center of Excellence for First Coronary Angioplasty in the country, Appreciation Award from Foxy, Dr. Ashok Mukherjee Gold Medal for Original Innovative Interventional Procedures, Indira Priyadarshini Award Year 2014 for Scientific Contributions in Medicine, Lifetime Achievement Award 2018 by TSIRIA. He has also published a chapter in Textbook of Radiology. He has published over 38 peer-reviewed articles. He has delivered lectures in various national and international forums. He is reviewer of American Journal of Sonography, Indian Journal of Radiology, and Journal of Fetal Medicine. He has held various posts in the past as Vice President National IRIA, President IFUMB, President Society of Fetal Medicine. Now I request our Honorable Speaker, Dr. T.L.N. Praveen sir, to give us insights on imageology, ultrasound dimensions in clinical enigma.
ఇది అది దగ్గర ఉంది.
Very good morning, and I would congratulate Dr. Katpam, Narmada for hosting this event, and that endeavor to excel at the same time to propagate knowledge is one of the most important things that one could achieve in life, and I think this is one of the best things that one could do in our professional lives. Now, as there was a lot of discussion about the NIPT, the present trend is that what we do is what is called as the pre-NIPT scans. The pre-NIPT scans are catching up. I mean, the reason why I wanted to talk about that is that NIPT, as Dr. Anuradha has told us, that it is about 10 weeks of gestation. But then the pre-NIPT one has been started because we can do a wonderful transvaginal examination of the pre-NIPT embryo, wherein most of the abnormalities, like some of the abnormalities which are easily detectable, can be easily identified at pre-NIPT scans. The reason why pre-NIPT scan has started is basically because in order to even avoid doing an NIPT, suppose you find an acronia or an anencephaly or you have a holoprosencephaly which can be diagnosed in the pre-NIPT scan, it doesn't make any sense in doing an NIPT again. So that is the trend that we have started now, and then I think there is a lot of literature coming up in this pre-NIPT scan, and a lot of abnormalities are being detected in the pre-NIPT scans. So with that, let me get back to the present day topic, that is dimensions in the diagnosis of clinical dilemmas. It's like 3 Ds. There is, we have the dimensions. The dimensions help us in diagnosing the problems and solving the clinical dilemmas. Now, as we all know, we have evolved over a period of time. In the sense, now the ultrasound has become a part and parcel of our day-to-day practice. Without ultrasound, I think it's very difficult to manage these problems such as the gynecological problems. So clinical history, digital examination, bimanual palpations, all these things have become complementary to the ultrasound examination. Now, most of the times, there is a lot of evolution that has taken place which has really revolutionized the imaging of gynecological problems. Particularly with the advent of, if you go into the history of ultrasound, particularly its application in gynecology, I think today we are not going to practice gynecology without ultrasound. Any one of you are practicing? No. And how many of you are doing their own ultrasounds? Handful. Little disappointed. Okay. Anyway, whoever is doing, how many of you are doing transabdominal? Only transabdominal? Transvaginal? Only transvaginal? Why not? Why only not transvaginal?
We might miss a huge fibroid.
Excellent. That's what I wanted to try. Yes, transvaginal is extremely useful and extremely important. But then there are certain clinical situations or scenarios where you definitely need a transabdominal examination. Now, how many of you are applying Fetal in your practice? Very few. Okay. How many of you are doing volume acquisitions? Only 2. Okay, so I can talk. Right. So, as I said, the ultrasound has become the third eye of a gynecologist. Now, when we talk about the ultrasound, basically, it was Ian Lenard who has introduced ultrasound in clinical practice in way back in 1958. Now, if you take into consideration the revolution that has taken place, which I have been asking you, is right from the transabdominal examination, we have evolved into transvaginal examination. Then we started using color. Then we started using transvaginal biplanar imaging. After the transvaginal biplanar imaging, now we are using what is called as the dimensions, that is the acquisition of volume data. What difference does it make? The acquisition of volume data, in which way is it going to help us, or which way is going to change our mode of approach or approach to the diagnosis of these clinical enigmas? I'll take you through some of the clinical scenarios. Would you like to answer my questions, or would you like a monotonous lecture? Fantastic. That's really encouraging. Okay, I'll take you from the first clinical scenario. Now, this lady is a 59-year-old lady who came to me presenting with postmenopausal bleed. This was the transfer. Is it clear? Very good. Okay, so this was the transvaginal examination. I'm sure you agree with me it's a sagittal scan. Yes, no? Fantastic. And what are the things that you are looking at? Very good. What do you find this one? This is a very thick endometrium. Is that the only thing that you would like to look for? You would like to look for the myometrium also. Not only that, you also would like to look for the endomyometrial junction, that is the junction also. Do you agree with me? Yes. So with this, how are you going to progress? Yes, this lady has come. So I have done the transvaginal. This is what the features are. So what are you going to do next? You want to put the color, isn't it? Naturally, whenever you have a thick endometrium, you definitely would like to know the vascularity of the lesion. So what do you call this? Now at this juncture, I will tell you a few things about color Doppler. Color Doppler can be subjectively or objectively evaluated. The subjective evaluation is color scores. If you take the color scores, when there is no color being updated by doing a color Doppler, you call it as color score 1. And henceforth, it will be color score 2, 3 and 4 when you have abundant vascularity. That is increased vascularity, which projects itself as an increased color Doppler or intense color Doppler. Okay, so here definitely we have an increased intensity of color Doppler. So obviously we are dealing with a color score 4, right? Now, then what will you do? I am not playing the video in order to make you commit. Pardon me? Next time, okay, agreed. Yeah, what is this? Okay, I'll run the video, sorry. Yes, so I have taken you through a conventional grayscale imaging of the endometrium, which was thick. Then I put the color Doppler on and I have confirmed that it is a vascular lesion. Then I did a saline infusion sonography. What is the saline infusion sonography? Saline infusion sonography is nothing but evaluating the cavity lesions. Whenever you find a cavity lesion, you would like to know what is the inner contour of that particular lesion. That's what we are interested in. So in this one, if you see carefully, I don't know whether I'm not very convinced whether you are seeing the image at all. You are seeing the image? Yes? Good. Now, you can see very nicely that when I put the saline inside, you find a large mass. Isn't it? You agree with me?
Yes.
Right. So this is a large mass which is there. Is there anything that you are able to make out from this large mass? What am I doing? I am trying to flush it. Why am I flushing it? I want to dissolve the clot because I want to be sure that it's only a mass, not a clot. Because the patient presented to me with a bleeding, postmenopausal bleed. So I would definitely like to know what is the size of the mass, what is the contour of the mass, is there an associated clot or not? Is it correct? Yes. Okay. Then with this, what did I do? Am I sure what I am dealing with now? So I have a thickened endometrium, which is vascular. On saline infusion sonography, I can tell that there is a mass which is there without the clot present, but then it got dissolved. But still there is a mass which has an irregular contour. You agree with me? Yes. So what am I going to do? Now I use the third dimension, that is the kernel section. This is what the kernel section is. What does it show? It shows that irregular polypoidal projections within the endometrium. So that is the place where the third dimension helps us in coming to a conclusion. Till now it was all a presumptive diagnosis, but now with this, we are very sure that it is a polypoidal growth which is occupying the endometrium. So this patient was subjected to hysteroscopy. This was the hysteroscopic image, and then we did a hysteroscopic biopsy which showed pleomorphism, and that is the specimen. That is the specimen which you have. So does the 3D specimen or does the 3D appearance, does it match the specimen? Yes. Yes, no? So that is the power of 3D. Okay? So now we realize that third dimension is going to be part and parcel of life. And then remember, gynec evaluation or gynec ultrasound without the third dimension is absolutely useless as of today. Previously they never thought of, but now without a third dimension, without doing a 3D acquisition of the volumes of the uterus or the ovaries or the adnexal region, it doesn't make any sense doing a gynec ultrasound. Okay. Now I'll take you through the second thing. Are you enjoying? Yes, sir. Very good. Fantastic. Okay. Now I have another lady who has come with a 49-year-old nulliparous postmenopausal woman presented with spotting. Okay. I did the transvaginal examination as usual. This is the sagittal section. What do you find here? Again, thickened endometrium, which is the normal finding or which is the usual finding. Is there anything else who is smart enough to tell me anything other than that?
Endometrial, myometrial junction.
Yes, what has happened?
Not clear.
Not clear is a vague dialogue. I don't agree. Now, can you see something here? What is this? This is a fluid. Isn't it? This is a fluid. And can you see the outline of the lesion? Yes, no? Okay. So that prompted me to directly put the color on. Anyway, whenever you do a transvaginal examination, you do an endometrial abnormality, you definitely put a color on. That's a practice. You have to do it. That's a protocol. Okay. Now I put the color doppler on. See the above, the vicinity of the lesion which we were thinking in terms of doing an endometrial thickness and the vascularity is absolutely not correlating with each other. It's a highly vascular lesion. Agreed?
Yes, sir.
Yes. So, what did I do? Again, I did a saline infusion sonography. Now see this. I put the catheter in, fill the cavity. I can see a long, linear, hyperechoic area filling the whole of the cavity. Can you see this? Yes. So, what do you think now? Fantastic. So, you will like to confirm or you don't directly go over hysteroscopy? So, I did a 3D rendering. This is saline infusion sonography associated with third dimension. That is the 3D. So, can you see this polyp so nicely delineated? And you can see the endomyometrial junction clearly delineated. And this is the polyp, the same polyp which you can see here. Agreed? So, would you agree that you are going to practice dimensions from tomorrow onwards?
Yes.
Very good. Right. So, this is the polyp. And this is the hysteroscopic image. Right? Do you like that? Very good. Okay. Then we go for the third case. Okay? Whenever you get bored, please tell me, I'll stop. Okay. Now, how about this? 39-year-old female presented with painful menstruation, intermenstrual spotting, passing clots. This is the transvaginal sagittal section of the uterus. And this is also a transvaginal sagittal section of the uterus. What do you find? Describe. If you start talking, then it becomes much more interactive. I can take you through more number of cases. Staring at the image will not give you a diagnosis. Okay. Now, as you said that it is definitely a sagittal section of the uterus. Do you find something abnormal here?
Heterogeneous.
Pardon?
Heterogeneous.
Ah, very good.
Well circumscribed.
Excellent.
Mass filling the whole uterine cavity.
How do you know that it's cavity?
Because
so that is where you want the third dimension. You need to know whether it is a submucous, intracavitary or subserosal lesion, whatever the lesion is. Okay? So with this, what did we do? We did the 3 dimension. So what are all the things that you are finding here? So basically this is the sagittal section. This is the volume that I have acquired. I am cutting through the uterus by taking what's called as the omni view. Well, once you do an omni view, see the amount of information that you are getting. You have a beautiful, well circumscribed heterogeneous area which is sitting right at the fundus, top of the fundus, which is in a submucous region, and it is distorting the cavity margin all along the fundal region. And then I put the color doppler on. What did I find?
So what is the lesion? Fibroid. So is it going to be helpful or not? So 3D is part and parcel of it. So I'm insisting again and again that please ask for 3D whenever you are asking for a pelvic scan. Don't accept anything less than 3D, because without 3D there are so many things that you are going to miss. And it's an ambiguous diagnosis that I'm going to give you. So if it is with 3D, I know I'm confident in giving you a diagnosis. Now, so whenever we have a fibroid, this is a format that we would follow reporting these fibroids. One, we would like to talk about the uterine corpus, that is the size, symmetry, asymmetry, hypogenicity of the myometrium. Not only that, with this 3D evaluation, I can tell you the number of fibroids, I can tell you the size of the fibroids, I can tell you the relationship of the fibroid with the submucous region, I can tell you the relationship with the serous, I can tell you additional information which I will show you. So this is what is the FIGO classification 0 to 8, where with 3D examination, I can do fibroid mapping, which is very, very important for all of you to manage these patients. Do you agree with me?
Yes, sir.
Very good. So what is it that I'm going to tell you? I'm going to tell you the number of fibroids that are there. I'm going to tell you the location of these fibroids. I'm going to tell you the size of these lesions. Okay? So that is the information that you are going to get by doing it. So not only that, when I put the saline into it and do a saline infusion sonography and reconstruct, remember this, now it has become a part and parcel that you not only do a saline infusion sonography, you take a sweep. It's a simple thing. You have a transvaginal probe which has a 3D volume acquisition, which can be used in order to take a sweep. Once you take a sweep, this is the only image you get. Would you not like it? Is it not as good as your hysteroscopic examination? Once if you have this one, I can do a rendering mode, I can tell you the outline of the lesion, size of the lesion, location of the lesion, not only that, the myometric thickness. All these things I can tell. Not only that, I can tell you how much of it is occupying the lumen. Is it only 100% of it is occupying? 50% of it is occupying? Less than 50% of it is occupying. So that it makes your life easier for planning the surgical management of this patient. So that is the information that we are able to give. Not only that, when we have large fibroids, when we have multiple fibroids, you need to take a call whether you want to do a hysteroscopic resection, you want to do a laparoscopic resection. So in that situation, whenever we have a large fibroid or fibroids which are more than 6 in numbers, in that situation, I can give you the volume of the fibroid or the volume of the uterus, which can help you in your management strategies. So this is what we can do with all this. This is what's called as a vocal. Vocal is nothing but the volume calculation by using the 3 dimension, that is the 3rd dimension data that has been acquired, and you can exactly see that it is almost 193 cc, and anything more than 122 cc is considered to be very difficult to manage either laparoscopically or what you call as laparoscopic assisted vaginal hysterectomies. So these are the things that we have to keep in mind and this is the information that you would like to have whenever you are dealing with these very common problem, that is the fibroid. Okay? Agreed? Yes. Now, not only that, in order to know the numbers, this is extremely useful because when once this is a sagittal section, a conventional grayscale sagittal section of the uterus, wherein I am not very sure about the number of fibroids, is the relationship. Once I do a 3D rendering, this is what is called as multiplanar imaging. Multiplanar imaging is not. I have got data or the information in the kernel plane. I have got data in the transverse plane. So in this way, I'm now very confident in the location of the fibroids, the number of fibroids that are there. So that sort of information can also be obtained. Now, can you spot the tiger? No. Where? Right corner, left corner, right lower, left lower. No. No. Shall I show you? No. No. Okay, that is different. Okay, how did I know? Fantastic. Tail. Right? Agreed. So this is the tail. It has also got stripes. So be careful. So you have to spot the diagnosis. I will give you a cluster of images. Tell me what is abnormal in that. I spot the tiger. which is well circumscribed. Agreed? This is again the same thing where we did the transvaginal examination and then did a omni view where you can see the fibroid very nicely. You have a very well circumscribed heterogeneous space occupying lesion, which is definitely a myometrial lesion, which has a very clear margins. It's a clear demarcation between normal and abnormal. And here you have what's called as the edge enhancement, which is very typical of a intracavitary fibroid. Then you have calcification. Then you have curvilinear vascularity, which is skirting vascularity. And you have a mass which is indenting the superior surface of the fundus. Here there is a fibroid which is causing obstruction to the cornea. What about this? Is this the same? Yes, no? No, it's not uniform, isn't it? It is. Can you define the lesion? You can't define the lesion. Do you find some cystic areas within it? So myometrial cyst. Is it causing distortion of the endomyometrial junction?
Yes.
Absolutely. So that is it? Fantastic. Great. So you spotted the tiger. That is the tiger. Okay. Now, what is your call in this? You have a sagittal section wherein you find that come on. Pardon me? No. You have this is uterus. I didn't go to the side mixer region at all. No. This is all the uterus. Can you see something here? Yes, no?
Yes.
What is that like? What is it fibroid? Can you say I have a definition? Adenomyoma. Then as you go through, what about this? What about this? So it's an adenomyoma associated with it fibroids. Okay, right. So case 4. Now, how do you describe this? So this is a classical vein in the forest appearance with asymmetric enlargement of the uterus. You can see that the anterior wall of the uterine wall, myometrium, is thinner than the posterior wall. You have vein in the forest appearance. You have multiple myometrial cysts. Okay, and then what about this? The endometrium is percolating into the myometrium. So the junctional zone is completely distorted. Which is the junctional zone disease? Endometriosis. So this diagnosis, was it easy to do it here or was it easy to do this here? That's it. So 3D has that ability to give you a diagnosis clearly. So these are all the various gimmicks that I can play with. That is, it's a nice toy to play. Where I know that this is the distorted that is the junctional zone, that is the endomyometrial interface. You can see a nice endomyometrial interface here. This is what's called as the inversion mode, wherein I can still demonstrate the beautiful endomyometrial junction here, and here you can see it is completely distorted, where you can see the endometrium percolating into the myometrium, which is very typical of adenomyosis. Agreed? So this is the advantage. Now you put the color doctor on. Usually the fibroids will have skirting vascularity, whereas the adenomyoma or adenomyomas, adenomyosis will have intra-lesional vessels. So this is the difficult. This is the way you are going to deal with it. So the features, I think you have already heard all these features. I'm not going to take you through. So okay, mullerian endometriosis. There is one area where without a 3D, there is no way that you are going to diagnose anything. You cannot differentiate one from the other. Grayscale imaging is no use. Now, some of you may say that I would get an MRI done. There are certain instances where MRI was not able to give you a diagnosis. The third dimension gives you the diagnosis. I'll show you one of these cases. Now, whenever you do an evaluation of mullerian abnormality, coronal section is the plane of choice. Without the coronal section, you will not be able to diagnose the mullerian abnormality. That's one. So, coronal section is obtained in the third dimension. Coronal section is nothing but the third dimension. Normally, what are the sections which you take when you do a transvaginal examination? You take a sagittal section, you take a transverse section. Getting a coronal section is extremely difficult. That is the reason why the third dimension is obtained by using the three-dimensional software, okay? Wherein you can nicely separate or differentiate between a septated and do you want to know whether it is the uterus is septate or biperitoneal management? Or you don't mind? Anything is okay? No, you definitely like. So this is how we are going to do it. So this is nothing but the Ishide classification, where The most important thing which you need to understand is the fundal contour. The fundal contour is the one which is extremely important. Fundal contour in a normal uterus is always convex upwards. Am I clear? And whenever there is a dip or whenever the fundal contour becomes concave or dips into the cavity, you know that there is something wrong. Agreed? So here what we have is that this is the thickness of the endometrium, the myometrium. ASRM classification. Now, what is the difference between the X-ray and ASRM? What classification do you all follow? ASRM? No. Which ASRM? There are two ASRMs. One is 2021 ASRM, which the reason why X-ray has become popular is because X-ray has dealt with the cervix as well as the vaginal abnormality. Whereas the ASRM was behind. It was the one which was first, like all of us learned the Tullerian abnormalities by taking into consideration of ASRM. But then they never dealt with the vaginal as well as the cervical abnormalities. But the major problem with X-ray is that you overdiagnose septate uterus. That is the major problem which we face. Well, so the X-ray has come out with what they said is that 1 centimeter thickness. Not only that, this angle is usually obtuse in a normal uterus. It becomes acute in septate as well as in the bicorporeal uterus. So, keeping that in mind, let us see this case 4. This is the conventional one. Okay, that is the sagittal section. Can you ever think in terms of a septate uterus by seeing this image? Yes, no? So, what did I do here? I took a volume from the 3D sagittal section and then I constructed the transverse section and then also the column section. Now with the transverse section, can you make out something? 2 cavities, fantastic. So the lesson here is that the message which I wanted to say is, whenever you do a transvaginal examination of the pelvic viscera, don't stop with sagittal section, please do transverse section because transverse section gives you a clue. But then, seeing this, I am not able to tell you whether it is a septate uterus or a bicornuate uterus, isn't it? So that is the reason why I would like to go with the third dimension, that is what is called as the coronal section. And you can see this multiplanar imaging nicely shows you here, and the render image shows you nicely a septum very clearly. How do I know that it is septum? Why did I say it is septum? Acute, one. Then the fundus. The fundus is the most important thing. Remember that fundal convexity is very, very important. If the convexity is maintained and you have a 2 corners, then you know that you are dealing with a septate. If it extends, one more minute. So that's all. I'm sorry. So shall I start here? No. I know this. I know you will say no. So what happens is, so this is this is how you have the convexity of the uterus is one of the most important, fundus is the most important thing to differentiate between a septate uterus and the bicorporeal uterus. Now, not only that, I will give you some more information. See this one. In this one, what do you find? You find, can you see something here? Is it concave or convex? Concave, isn't it? So this is such a subtle thing to really differentiate between a bicorporeal uterus and a septate uterus. Now here you can see a wide convex downwards and there's a very muscular thickness. And here, not only that there is convexity, but also a concavity, but also there is some thickness. So this is what is called as bicorporeal septate uterus. This is complete bicorporeal uterus. This is partial bicorporeal uterus. Am I clear? Very good. Right. So classification, I have already spoken to you. I don't want to go into it, and they are already in a hurry. So these are all the things now. Reporting format, again, same thing, not much of it. So use 3 dimension, it is rewarding. Okay, that is the message which I wanted to convey. Thank you very, very much. And before I end, I would like to invite you all for ADSM 2022, November 11th, 13th, which we are hosting in Hyderabad. It's an international congress. We have all modalities. We are getting real big names in the field of fetal medicine as well as gynecology. We have George Cornelius coming on. He is the master in Endometriosis. And we have Fred Bushkov, Ravi Choi, and all big names, Simon Mark, all of them are coming. So please take the advantage and please come to it. This is the website. You can just visit the website and have an idea what exactly is the magnitude of this markets. Thank you very, very much.
Thank you very much, sir, for this fantastic presentation. We wish we could go on, and also rendering the importance of 3D as an extended eye of obstetrician.
And he's not only a teacher but a mentor, and I'd like to felicitate him. Please.
I would request Dr. Venugopal sir to felicitate. Please, you are.
Ma'am.
Am I looking old?
Now I would request you all to break for a coffee session, quick break, and then we'll be back. Thank you.
Break. Coffee.
చెప్తాను ఆయనకి ఒకసారి వర్క్ ఇచ్చాము వాళ్ళ క్యాప్చర్ చేసింది అవి తీసుకొని నాకు
Dr. Swarajyalakshmi madam. Can I have a big round of applause, please? And you can think about all your teachers who taught you something while I am felicitating my teachers. Ambuja madam. Rajyalakshmi madam. Uma madam. And Shobha madam. Two of my other teachers, Dr. Chitralekha and Dr. Anita madam, on their way, and I'll take the opportunity a little later so that I don't delay the day. All of you might know them from different conferences, different meetings, but they are so close to my heart. The only person who can understand how I feel is Alivelu. Why Alivelu? Because Alivelu and I did MD together. We share the same fond and affection for our teachers and SPH, which was like a poultry farm with small buildings then, but it has multiple high-rise blocks now. And one person I'm really missing here is Sushilama madam, who was the superintendent and head of the unit, and unfortunately she couldn't come. If somebody can get the job done with no noise, just with a glance, was Dr. Sushilama madam. We all agree, isn't it? And if somebody can get the work done with noise, I'm not saying anything. So I hand over the mic to Alivelu and I'll carry on with paying respect to my teachers.
Good morning.
We are from 1997 to 2000. We are 2000 pass outs.
Good morning. Namaste to all. నిజంగానే భయంగా ఉంది మేడం మళ్ళీ మీ ముందు నిలబడి మాట్లాడడానికి. It's a 25 years association. Time has ఎంత తొందరగా మూవ్ అయిపోయిందంటే నిజంగానే SBH లో మాకు 3 అమ్మలు ఉండేవాళ్ళు. పెద్దమ్మ, అమ్మ, చిన్నమ్మ. పెద్దమ్మ నర్మదా చెప్పినట్లు అసలు ఏమీ మాట్లాడేది కాదు, ఏమీ అనేది కూడా కాదు. 9 o'clock జస్ట్ కోట్ జోబులో చేతులు పెట్టుకుని లేదు వెనక్కి చేతులు పెట్టుకుని అలా నిలబడి ఉండేది గేట్ దగ్గరే. సో 9:05 వచ్చే వాళ్ళకందరికీ మేడంని చూసేసరికి బాగా భయం వేసేది, అమ్మో 9:05 అయిపోయింది లేట్ వచ్చేసాము అని. బట్ సైలెన్స్ లో కూడా అంత డిసిప్లిన్ నేర్పించవచ్చు, పిల్లల్ని అంత పద్ధతిగా చెప్పొచ్చు, నేర్పించవచ్చు అని నేర్చుకునేది మాత్రం మా అమ్మ సుశీలమ్మ గారితోనే. రియల్లీ మీ మిస్ గారు చాలా అనుకున్నాం ఇవాళ సుశీలమ్మ గారు వస్తారని. అండ్ మా అమ్మ సత్యవతి అమ్మ అంటే మేడం బాగా గట్టిగా కోపడతారు, కానీ ఆమె గొంతుకు ఆమె మనసుకు అస్సలు సంబంధం లేదు. మాట ఎంత కరుకో మనసు అంత సున్నితం. ఎవరైనా ఇప్పుడున్న పీజీలు ఎవరైనా మీకు మీ ప్రొఫెసర్లు టిఫిన్లు తెచ్చి తినిపించే దాఖలాలు ఉన్నాయండి? నాకైతే మా మేడం పెట్టేది ప్రతిరోజు, ఎందుకంటే హాస్టల్లో టిఫిన్ బాగాలేదని తినకుండా వచ్చేదాన్ని. వెజనరీ డిస్ట్రక్టివ్కి అసిస్ట్ చేయడానికి వెళ్ళి ఒక 10 నిమిషాలుగా వర్టికల్ గా ఉన్నదాన్ని ట్రాన్స్ఫర్స్ గా ఉండేదాన్ని. ఈ పిల్లతో ఇంకా నేను ఏం చేస్తానని పాపం ఓపిక్గా మేడం టిఫిన్ తిని నాకు కూడా ఒక బాక్స్ తెచ్చి తినిపించేవాళ్ళు. అండ్ మా చిన్నమ్మ అసలు వీళ్ళందరికన్నా మాకు బాగా భయం అంటే మా చిన్నమ్మ. అసలు ఏమీ అనేది కాదు, కానీ స్టిల్ మేడంతో కాస్త భయము. అంటే సంగీతము, సాహిత్యము, ప్రొఫెషన్ తో పాటు కొంచెం మేము పర్సనల్ ఎథిక్స్ నేర్చుకున్నామంటే మాత్రం దట్ ఆల్ క్రెడిట్ గోస్ టు స్వరాజ్యలక్ష్మి మేడం. మేడం ఎప్పుడూ ఒక మనిషి గురించి నెగటివ్ గా మాట్లాడడం అంటే ఫర్గెట్ అబౌట్ వాళ్ళ కొలీగ్స్ అని కాదు, పీజీలతోని అక్కడ పనిచేసే హౌస్ సర్జన్స్ గురించి కానీ ఎంత పాజిటివ్ గా మాట్లాడే వాళ్ళంటే మామూలుగా ఆడవాళ్ళు దే విల్ టాక్ బ్యాక్ టాకింగ్ అని అంటారు. బట్ వీ నెవర్ హర్డ్ ఎనీథింగ్ లైక్ దట్. ఇదైతే మేము పిల్లలుగా ఉన్నప్పుడు మేము మేడంతో నేర్చుకునేది స్టిల్ వీఆర్ కంటిన్యూ. అండ్ అమృత మేడం అంటే అమృత మేడంని చిన్నమ్మ అని అనేవాళ్ళం కాదు, కానీ ఆల్మోస్ట్ చిన్నమ్మ. వీళ్ళంతా ఒక గ్రూప్ లో ఉండేవాళ్ళు, కళ్యాణి మేడం, అమృత మేడం. అంటే నిజంగా అప్పుడు బాగా సతాయించాం మేము వీళ్ళని, పని బాగా నేర్పించారు మేడం, బాగా ప్రేమగా చూసుకున్నారు. లైక్ వీఆర్ లైక్ వన్ ఫ్యామిలీ. అండ్ ఉమా మేడం అయితేనంటే నాకు చిన్నపిల్లగా ఉన్నప్పుడు తెలుసు, నేను మెడిసిన్ లో జాయిన్ అయినప్పుడు రత్న మేడం, ఉమా మేడం గాంధీ హాస్టల్లో ఉండేవాళ్ళం. మేమంతా చిన్నపిల్లలుగా తలుపు చాటు నుంచి చూసేవాళ్ళం. రత్న మేడం అబ్బాయి ఎంత అందంగా ఉన్నారు, సాయంత్రం అక్కడెక్కడో సినిమాలో లేదు ఇక్కడే ఉన్నారు, మన జమున అంటే ఉమా మేడం అనుకుని అలా చూసేవాళ్ళం. అంటే అలా చిన్నపిల్లలుగా చూసి ఎదిగా మేము కాస్త తీసుకోవాల్సిన చదువు కన్నా కాస్త ఎక్కువే తీసుకున్నాం. అండ్ కమ్స్ టు అవర్ డార్లింగ్ రాజలక్ష్మి మేడం. అసలు ఇప్పుడు వీళ్ళంతా కొంచెము స్క్రీన్ కి అవుట్ ఆఫ్ స్క్రీన్ అయిపోయారు, కానీ ఇప్పుడు ఆవిడ మాత్రం అసలు మహిష్మతి రమ్యకృష్ణ లాగా మమ్మల్ని ఆడిచేస్తుందండి. సర్వీస్ ఎప్పుడన్నా సర్వీస్లో ప్రాబ్లమ్స్ వచ్చినా ఏదన్నా ప్రొఫెషన్లో ప్రాబ్లం వచ్చినా మేడం అడిగితే ఆవిడ ఈ అన్ని రూల్స్ తీసేసుకున్నారు. ఆవిడ అక్కలాగా గడిపిస్తుంది, అమ్మలా ప్రేమిస్తుంది, అక్కలా గైడ్ చేస్తుంది, ఫ్రెండ్లా దగ్గర ఉంటుంది. అండ్ నిజంగానే చాలా సార్లు నేను సర్వీస్ మానేయాలనుకున్నప్పుడు, ఏదన్నా ప్రాబ్లమాటిక్ కేసు డీల్ చేయలేము అనుకున్నప్పుడు ఐ థింక్ రాజలక్ష్మి మేడం ఈస్ బిహైండ్ అవర్. అండ్ బాగా అంటే ఏదన్నా లైఫ్ లో వెన్ వీఆర్ ఇన్ డౌన్ ఏదన్నా కేసు మేము చేయలేము అనుకున్నప్పుడు ఒక్కసారి రాజలక్ష్మి మేడంకి ఫోన్ చేస్తే ఇంకా తిరిగే లేదు కట్టప్ప అనుకుని కట్టనుకుంటున్నాం. అండ్ నిజంగానే ఇంకా ఇవాళ మిస్ అయిన వాళ్ళలో చిత్రలేఖ మేడం వీళ్ళందరూ పాపం అంటే మమ్మల్ని పెద్ద చెల్లెల్లానో చిన్న చెల్లెల్లానో చూసేవాళ్ళు అనుకుంటా. దే ఆర్ ఆన్ అవర్ వే. అండ్ రియల్లీ మేడం వి మిస్ యూ. చాలా సార్లు మిమ్మల్ని ఎంత గుర్తు చేసుకుంటామంటే పొద్దున్నే లేచి మమ్మల్ని కన్న పేరెంట్స్ కి మేము ఎలా దండం పెట్టుకోవాలో, మమ్మల్ని ఇలా నిలబెట్టిన మీకు ఎన్నిసార్లు థ్యాంక్స్ చెప్పుకున్నా తప్పే. మీ వల్లే మేము ఇలా ఉన్నాం. మీరు నేర్పిన ఎథిక్స్, మీరు చెప్పిన పర్సనాలిటీ డెవలప్మెంట్ తోనే వీఆర్ లైక్ దిస్. అండ్ ఏదన్నా మేము ఇంకా తప్పు చేస్తున్నామంటే అది మీ తప్పు కాదు, మీరు నేర్పారు, మేము నేర్చుకోలేకపోయాం. బట్ స్టిల్ మేము ఇచ్చే గుర్తెక్షన్ ఏదన్నా ఉంది అంటే మీరు ఎప్పటికైనా సరే గర్వంగా వీళ్ళు మా పిల్లలు అని చెప్పుకునేటట్లు మీ పేరుకు చెడ్డ పేరు రాకుండా వీళ్ళు స్టాండ్ ఆన్ యూ. అండ్ ఎస్బీహెచ్ అండ్ ఎస్బీహెచ్ టీచర్స్ అండ్ నర్మదా ఇంత గొప్ప ఆపర్చునిటీ నాకు ఇచ్చింది. అంటే మామూలుగా పురాణాలు చదువుకునేటప్పుడు ఈయన శంకరాచార్యులు ఏదన్నా పద్యం రాసినప్పుడు చివరిలో ఎక్కడ ఆయన పేరు రాసుకోండి. అండ్ షీఈస్ లైక్ దట్. చేసేదంతా ఆయన చేసినా మా అందరికి కూడా దీంట్లో ఈ యాగంలో మాకు కూడా ఒక ఫలం ఇస్తున్నందుకు. అండ్ వీ లవ్ యూ యాజ్ అ పర్సన్, యాజ్ అ ఫ్రెండ్. లవ్ యూ నర్మదా. అండ్ వేణుగోపాల్ గారికి ప్లీజ్ వెళ్ళేటప్పుడు మా అందరికి కూడా రిటర్న్ గిఫ్ట్ ఇవ్వండి. థ్యాంక్ యూ వెరీ మచ్.
Thank you so much for your lovely words. And I just only want to say, I repeat everything I really said without repeating it. And సత్యవతి మేడం ఫోన్ చేస్తే మేమేం చేసామని ఎందుకు రావాలి అని అన్నారు. బొమ్మరిల్ డైలాగ్ గుర్తుంది అందరికీ, అంతా మీరే చేశారు. So we are what we are only because of the learnings we have, and we truly mean that. Thank you.
సారీ మేడం, శోభా మేడం గురించి చెప్పడం మర్చిపోయాను. రాజలక్ష్మి మేడం ప్రేమలు పడిపోయి మిమ్మల్ని మర్చిపోయాను, సారీ. అసలు మేడం ఎంత బాగా చూసుకునే వాళ్ళంటే స్కాన్ గురించి బాగా మేము కాస్త నేర్చుకోవడానికి ఇంట్రెస్ట్ రాగలిగినట్లు చేసింది. అప్పుడు మీరు ఇంకా అంటే మీరంటే చాలా భయం ప్రవేశారు. తిరుమల మేడం, శోభా మేడంతో మాకు కాస్త స్కాన్ మీద ఇంట్రెస్ట్ వచ్చింది.
అడ్డం ముగ్గురు ఉంటాం మరి. ఇటు నుంచే పెట్టేసి ఇటు తిరగమన్నా అదమ్మా. ఇక్కడ చూడమని మ్యామ్.
Thank you so much, madam, all of you.
అందరికీ నమస్కారం. 20 నిజంగా చాలా గర్వంగా ఉంది నాకు. మేము ఏం చేసామో ఆవిడ అన్నట్టు నాకు తెలియదు కానీ ఒకటే చెప్పేదాన్ని. నేను పోస్ట్ గ్రాడ్యుయేట్స్కి టీచ్ చేసేటప్పుడు 2 సంగతులు ఎప్పుడు అంటుండేదాన్ని. వాళ్ళు అన్నట్టు నేను కొంచెం చాలా స్ట్రిక్ట్, అంటే స్ట్రిక్ట్ కాదు, పేషెంట్ ఈజ్ ఫస్ట్ ఫర్ మీ. నాకంటే కూడా ఫస్ట్ పేషెంట్కి ఏమీ జరగకూడదు. పేషెంట్ మస్ట్ బి లుక్డ్ ఆఫ్టర్ లైక్. అందుకని వాళ్ళకి ఎప్పుడు నేను చెప్పేదాన్ని, ఇమాజిన్ ద పేషెంట్ ఈజ్ ఐదర్ యువర్ మదర్ ఆర్ సిస్టర్, దెన్ యూ డూ ద బెస్ట్ ఫర్ ద పేషెంట్. ఏ పేషెంట్ చూసినా ఫస్ట్ థింక్, ఇట్ ఇస్ ఓల్డ్ లేడీ థింక్, మా అమ్మ అయితే ఎంతమంది అడుగుతాం, ప్రవీణ్ సార్ బాగా చేస్తారా అల్ట్రాసోనోగ్రఫీ, ఇంకెవరు బాగా చేస్తారని అడిగి వెళ్తాం కదా. అట్లాగే చేయండి. లైక్ ప్రెగ్నెంట్ వస్తే థింక్ దట్ యువర్ సిస్టర్, దెన్ యూ విల్ డూ ద బెస్ట్ ఆబ్జర్వేషన్ ఎవరైనా అడిగి వెళ్తావు కదా. అట్లా చేయండి. రెండో సంగతి నేను ఎప్పుడు వీళ్ళకి చెప్పేది అంటే, అర్ధరాత్రి పేషెంట్ వస్తే విసుక్కోవద్దు. అప్పుడు నేను కొంచెం క్యాకులేసేదాన్ని పేషెంట్ ఏమన్నా అంటే వీళ్ళకి. అందుకే నేను ఎప్పుడు కొంచెం రాక్షసతో కనపడతాను. అంటే పేషెంట్ రాత్రి అర్ధరాత్రి 1 గంటకి ఇంట్లో లేచి ఒక ఆటోనో ఏదో పట్టుకొని మన హాస్పిటల్కి వచ్చిందంటే ఎంత కష్టంలో లేకపోతే వస్తుంది. సో ఎప్పుడు కూడా అటువంటి పేషెంట్స్లో సీ ఫర్ ద వెరీ బ్యాడ్ కాంప్లికేషన్. వాళ్ళు వచ్చారు అంటే అటువంటి పేషెంట్ మీద యూ హ్యావ్ టు బి వెరీ వెరీ కాన్సన్ట్రేషన్ చేసి చూసి. మనకి నిద్రపోవడానికి కాదు కదా నైట్ డ్యూటీ చేసింది, మనం పేషెంట్ చూడడానికి నైట్ డ్యూటీ చేస్తాం. అవి 2 చెప్పేదాన్ని. తర్వాత పేషెంట్కి ఏదైనా అయితే మటుకు కొంచెం క్యాకులేసేదాన్ని, అది మటుకు ఒప్పుకునేదాన్ని. బేబీ మటుకు డిస్ట్రెస్ రాకూడదు, అది వాళ్ళందరూ నాకు ఇప్పటికి గుర్తుపెట్టుకుంటే. అందుకే చూసారు అందరూ అలా చెప్తున్నారు, నేను పెద్దమ్మ అమ్మ అంటే చాలా భయం అని చెప్పి. అది ఒకటి. బట్ ఐఎమ్ వెరీ ప్రౌడ్ ఆఫ్ యూ నర్మదా, దట్ యూ హ్యావ్ కమ్ టు ఏ స్టేజ్ ఆఫ్ ఇన్ఫర్టిలిటీ బ్యాకప్ అండ్ యూ హ్యావ్ కమ్ అప్ లైక్ దిస్. Alivelu, you have become an administrator. I'm very happy and I'm very happy of my student. And I'm very proud that అట్లీస్ట్ కొంత కాదే కొంత మా ఇమేజ్ వాళ్ళ మీద పడిందని సంతోషంగా ఉంది. మళ్ళీ నేను 22 సంవత్సరాల తర్వాత వెనక్కి వెళ్ళి సుల్తాన్ బజార్లో ఉన్నట్టు ఫీల్ అయ్యాను. బికాజ్ వీళ్ళంతా నా కొలీగ్స్, నా అసిస్టెంట్స్. థ్యాంక్ యూ వన్స్ అగైన్ నర్మదా.
Thanks, Narmada, Alivelu, very much. I am very greatly honored that you people remembered us. Actually, we behaved the normal way. What we have learned from our teachers, great teachers, Sachibama Reddy, Prasanna Magar, they are epitome of principles. Those principles we have just imbibed. And the same thing we practiced, and you liked it and you followed that. There is nothing great in us. We just did our duty and you took some examples from that. And you got impressed and you just remembered us, that the love and affection. That's what I am very much concerned and honored. Because after 22 years, my madam ilaga alaga ani ma gurinchi cheptu unte, it's a proud moment for me. I am very very happy to be associated. And Sultan Bazar lo duty room, blood bank, మనం పరిగెత్తుకు వెళ్ళడం, ఆ చిన్న రూమ్స్ లోంచి అవన్నీ కూడా చాలా గుర్తొస్తున్నాయి ఇప్పుడు. Very, very happy about it. Thank you very much.
Just know it is good afternoon. I'm really, first of all, thankful to you all. All the students that are present, really, it's like a festival for me. And feeling proud to be amongst you all. The period what we spent in Sultan Bazar, I was there for 9 years. It was like a golden period in my life, I feel. And as you said, Susilamma, whenever she got one VIP, she used to tell, you stay with the patient and deliver and go. So that used to be there. So at 2 o'clock after dinner, I used to go home. My husband used to ask me, why your car is running on water, is it? Do you get anything extra for this? It was not the thing, it is the word. If a senior person says, yes, we have to apply. That used to be our thing. And it is like parampara, I'll tell you. What we learned from our teachers, we gave it to you. Still I can remember the first class teacher of mine, that is Subhamma teacher, where I went and sat with her. And the last teacher who gave me MD degree, that is Sundari Krishna. Everybody in that way.
it's only up to studies that happened up to that. Afterwards, everybody, talking to everybody, either with Satyavati Madam or Swaraja Lakshmi or anybody in that way, we learned every day. And I feel learning is a process that is there throughout. Even today we learn everything. And when you say acknowledging means, I feel we should acknowledge 4 people. One is our patients who are gods. Second is our institute, which gave us opportunity to do it, that is the Devalaya. And third is my students. Without students, where is the question of having the teacher? So I really feel honored for today because my students, remembering after 20 years and calling, of course in between people are meeting, that's a different thing, but honoring like this is a great thing. Thank you all. And making this to happen, Narmada, thank you very much.
Good afternoon, everyone. Actually, this is really a proud moment. Thank you, Narmada, because you recognized me as a teacher. I don't know what I taught you. Yeah. And all madams are also my teachers. All are my teachers, actually. So, what we are is all because of them. And including Praveen sir, your students, he was a budding radiologist, I mean sonologist. So we knew him like that. So thanks a lot, Namda, for all the things you have done. Right? Thank you.
What I learned from you is how to do things well, quick. You're very good at sections, that's what I learned.
Actually, so the number of surgeries were more in Sultan Bazaar. Usually they used to come around 1:30. So that time was, some people used to sleep and then we never used to get sleep like because of you. So either both ways. Either telling some harsh things or telling, Amagade, no chespove, tondara jastava. So I used to do a lot of surgeries, those sections, number of tubectomies, number of laparoscopic tubectomies, they were all more. So finally they used to be there and they used to assist me. So maybe in that way they learned more. Madam, please come. Thank you.
I invite Dr. Anita to join.
ఇక్కడికి వచ్చాక వేణుగోపాల్ చెప్పాడు, మేడం యు ఆర్ మై టీచర్ ఇన్ అండర్ గ్రాడ్యుయేట్. సో ఇట్స్ రియలీ వెరీ హ్యాపీ. మై డే ఈజ్ డన్, మై ఇయర్ ఈజ్ డన్, and my whole life is done because so many students, so many PGs that are there. We do remember PGs very well because we work together day and night. But undergraduates also coming and telling is something great. Really, I feel very happy this occasion. Thank you very much.
I thank Anita Madam joining me, even though she had some family emergency. She handled that and then joined us. Thank you, Madam.
Yeah.
Thank you so much. Any more SPHPG Kausalya? Okay, that's it.
Good morning, all of you, and the respected dignitaries on the dais and on the dais. Especially a great thanks to TL and Praveen sir, and all obstacle complications we had. We used to rush to Praveen sir. So that time we are in liberative age, And here, and mostly complications. Yeah, I used to have most of the complications. The first gynecologist and the beautiful and very loud voice gynecologist is Satyavati madam. So she used to shout and she used to guide me to TLN sir. So coming to that stage, so talking about Sultan Bazaar, I joined as junior most assistant and my teachers are the beloved Peddamma, Amma, Chinnamma. So Uma is my కొంచెం పెద్దవాడి మాకంటే గేటు దాటాలంటే పెద్ద చూస్తుందావే లేదు పెద్ద పెద్ద ఉంది అక్కడ వెనకకి వెళ్ళిపోవడమే మళ్ళీ పెద్ద పెద్ద ఎంత ఇదంటే బ్యాగ్ తీసేసి ముందు ఒకరి తర్వాత ఒకరు వెళ్ళేవాడు. ఐ డోంట్ నో ఫ్రమ్ వేర్ షీ విల్ గెట్ ది ఇన్ఫర్మేషన్. ఆమెకి కంప్యూటర్ కళ్ళు ఉన్నాయా అండ్ ఇప్పుడంటే హాస్పిటల్ పెద్దగా ఉంది, వీ కెన్ సీ ఫ్రమ్ విండోస్. అది చిన్న చిన్న హట్స్ లాగా ఉండేది. వెన్స్ ఒక్కసారి అట్లా లేబర్ నుంచి స్టెప్ అవుట్ పెట్టగానే ప్రభావతి అమ్మా మీకు పిలుస్తున్నారు అని ఇక అయిపోయినాం, చచ్చిపోయినాం, ఎందుకు పిలుస్తుంది ఏంటి వెళ్ళగానే ఎక్కడున్నావు ఇంత సౌండ్లెస్ గా మాట్లాడేదంటే ఆవిడ. షీఈ్ ఎ వెరీ గ్రేట్ గ్రేట్ అడ్మినిస్ట్రేటర్. ఆమె ఎప్పుడు మమ్మల్ని తిట్టలేదండి, చూస్తే చాలు భయం వచ్చేసింది మాకు. అండ్ వీ యూస్ టు హ్యావ్ ఇన్ఫెంట్ మార్టాలిటీ, పెరినేటల్ మార్టాలిటీ. ఎపిసియాటమీ 3rd degree అయ్యిందంటే లౌడ్ వాయిస్ ఎందుకు అయ్యింది, ఏం చేస్తున్నారు మీరు, నిద్రపోతున్నారా అంటే పోనీలేవే సత్యవతి బేబీ అయితే బాగుంది కదా ఊరుకో సుశీలమ్మ నువ్వు ఎప్పుడు ఇలా వాళ్ళని సౌండ్ మీరు సపోర్ట్ చేస్తామంటే వాళ్ళు ఎప్పుడు నేర్చుకుంటారండి, మేము చెప్పమండి వీళ్ళ క్లాసులు అంటే ఫోన్లే మీరు చెప్పొద్దు నేను చెప్తాను అనేది ఆవిడ. సో వన్ మోర్ గ్రేట్ థింగ్ అబౌట్ సరాజలక్ష్మి మేడం, పోస్ట్నేటల్ వార్డ్ రౌండ్స్ ఇప్పుడు ఎవరు చేస్తున్నారండి, అసిస్టెంట్ కూడా తెలియదు. షీఈస్ టు కమ్, ఆ వెనక మేము వెళ్ళేవాళ్ళం, డైపర్ తీసి ఇట్లా చూస్తే మేము కూడా చూడాలి. అక్కడ గేపింగ్ అయిందంటే మాకు గేపింగ్. ఎవరు వేసింది ఇది, ఎక్కడ వేసింది, ఎన్ని రోజులు అయింది, పేషెంట్ పట్టుకురా, ఏం వేసారు, 4 steps మిడ్లో వేసారా, అవుట్లెట్ వేసారు, అవుట్లెట్ వేస్తే మీకు తెలీదా ఎప్పుడు అప్లై చేయాలి. అంత డిసిప్లిన్ గా నేర్పించారండి. దట్ హాస్పిటల్ ఈజ్ లైక్ హెవెన్. అప్పుడు హెల్లా ఉండేది, ఇప్పుడు నౌ వి ఫీల్ ఇట్స్. బట్ తిట్టారు కానీ మళ్ళీ సాయంత్రం పిలిచి మాట్లాడేవాడు. సో వెన్ ఎవర్ వీ వర్ యాబ్సెంట్, ఏమైందని ఎందుకు రాలేదు, ఎక్కడ పోయింది. నైట్ టైం మాకు నైట్ మేర్, ఒక్క పేషెంట్ ఏదైనా షాక్లోకి వచ్చిందంటే ఫస్ట్ రింగ్ సూపరింటెండెంట్ మేడంకి వెళ్ళాలి, సెకండ్ రింగ్ హలో అనేది, నేను మేడం దానికి బీపీ పల్స్ డౌన్ అవుతుంది పెట్టేది ఇంతే. పెట్టే అనేది వెంటనే షీ యూస్ టు కాల్ సత్యవతి సరాజలక్ష్మి అండ్ పాపం మై డియర్ గ్రేట్ అంబుజా మేడం అండ్ బ్లడ్ బ్యాంక్ మెడికల్ ఆఫీసర్ తిరుమలదేవి. 15 నిమిషాల్లో వచ్చి మా వెనక వచ్చిన వాళ్ళు, మాకు చూడండి ఎలా ఉంటుంది మా పరిస్థితి, చెప్పలేము ఏం జరిగింది ఏం లేదు. లే ఇవిడేమో చంపేసావా లే ఇంకా ఏం చేస్తున్నావు అని దే షుడ్ టేక్ ఓవర్ ది కేస్. బట్ బ్యూటీ ఆఫ్ దట్, వాళ్ళు టేక్ ఓవర్ చేసిన తర్వాత వాళ్ళు తిట్టారు, వీ యూస్ టు ఫీల్ వెరీ రిలాక్స్ అండి. బయటకు వచ్చిన తర్వాత దే యూస్ టు కౌన్సిల్ ది పేషెంట్ అటెండర్స్. ఈవెన్ డెత్ డిక్లరేషన్ వరకు కూడా వాళ్ళు ముగ్గురు కూర్చొని చక్కగా చెప్పి గొడవ లేకుండా పంపించేవాళ్ళు. దాట్ వాజ్ ద బ్యూటీ, వి నెవర్ ఫర్గెట్ దాట్. ఇప్పుడు సినారియో కేసు రాగానే అసిస్టెంట్ చూసి పీజీ మీద దోసేస్తుంది, పీజీ చూసి నెక్స్ట్ డే అసిస్టెంట్ మీద దోసేస్తుంది. సో మార్నింగ్ 8:30కి రౌండ్స్ ఖచ్చితంగా పార్టిషన్ చూసేవాళ్ళు. దే టు కాల్ దట్ అసిస్టెంట్ వాట్ మిస్టేక్. అసలు తప్పించుకునే పరిస్థితే లేదండి, అది దొంగతనం నేర్చుకోలేదండి మేము అక్కడ. సో దట్స్ వాట్ ఐఎమ్ ప్రాక్టీసింగ్. భయంకరం కాదు అంటే 24 hours డోస్ మీద ఉన్నారు. ఈ రోజున నేను ఒక అసిస్టెంట్ ప్రొఫెసర్ గా నౌ ఐ హావ్ గాన్ టు, అప్పుడు అనుకునేదాన్ని వాళ్ళ పచ్చర్లు కట్టుకొని వస్తారు వీళ్ళు, నిజంగా చెప్తున్నాను. సుశీలమ్మ గారిని చూసినప్పుడు ఆ వెనక ఇలా నడిస్తే మెల్లగా నడిచేవారు, ఎక్కడికైనా పోవాలనుకో దా అనేది అంతే, ఎక్కడికి ఏంటి ఏమీ తెలియదు, ఎలా వచ్చింది. శోభ మేడం చాలాసార్లు అనేది ఏంటి నేను రమ్మంటుంది ఏదో ఉంది టు టీజ్ మీ. ఆమె ఎక్కడికి వెళ్ళినా ఎక్కువ అనేది, మళ్ళీ ఎప్పుడు వస్తామో తెలియదు. అండ్ రిగార్డింగ్ పల్స్ పోలియో మీకు బ్యూటీ చెప్పాలి. ఇప్పుడు పల్స్ పోలియో అంటే ఏం చేస్తున్నామండి, ఇంటింటికి తిరిగి సాయంత్రం 6 గంటలకు రిపోర్ట్ ఇస్తున్నాం. అప్పుడు సుల్తాన్ బజార్ ఇది సెంట్రల్ జోన్, ముగ్గురు అక్కడ కూర్చుంటే రాత్రి 2 o'clock వరకు ప్రతి బండి రావాలి, డయాలసిస్ పంపించాలా, మాకు వేడి ఉప్మా 9 గంటలకు వండించేవాడు. ఈ తొక్కలో ఉప్మా తింటూ మేము ఇంటికి ఎప్పుడు పోవాలనుకున్నాము. సో దాట్ వాజ్ ది డెడికేటెడ్ వర్క్. ఇప్పుడు చేసే ఇవన్నీ కూడా వీళ్ళు చేసేసారు. మనం చేసే కంప్యూటర్ రిపోర్టింగ్ ఇవన్నీ వాళ్ళు మాన్యువల్గా అప్పుడే చేశారండి. నౌ దట్ ఈస్ ది పయనీర్ అండ్ పిల్లర్ ఫర్ మీ వేర్ ఐఎమ్ ప్రాక్టీసింగ్ ది సేమ్. ఇప్పుడు నేను అప్పుడు అనుకున్నాను సుశీలం గారిని చూసి, ఈ వెనక నన్ను భలే తిప్పుకుంటా ఉంటుంది, ఈలాగా ఎప్పుడవుతానో అనుకున్నాను. కానీ అయ్యా సినారియో వేరేగా ఉంది. ఇప్పుడు సినారియో ఇస్ డిఫరెంట్. ఇది తప్పు చేసినా సూపరింటెండెంట్కి తిట్లు, అసిస్టెంట్ తప్పు చేసినా వీడియో కాన్ఫరెన్స్ లో నువ్వేం చేస్తున్నావు మమ్మల్ని తిడుతున్నారు. అప్పుడు బ్యూటీ కలెక్టర్లు వచ్చిన, చీఫ్ సెక్రటరీ రాని సూపరింటెండెంట్ రూమ్ లో కూర్చొని నో షీఈస్ బిజీ లెట్ హర్ కమ్ అని 2 గంటలు వెయిట్ చేసి వాళ్ళని కన్సల్ట్ రోజులండి రివర్సెడ్ అయినాయి. సో వీఆర్ రిగ్రెట్ బట్ స్టిల్ మేడం మీరు అన్నారు ఇందాక ఎందుకు మేము ఏం చేసాం గుర్తుపెట్టాం. ఎవ్రీ డే ఎవ్రీ మినిట్ మేము ఖచ్చితంగా మిమ్మల్ని గుర్తు చేసుకోని రోజు లేదు. ఎస్పెషల్లీ మీకు నేను బాగా తిట్లు తిన్నానండి వీళ్ళందరూ. ఎందుకంటే చిన్నదాన్ని తప్పులు కూడా ఎక్కువ నాకే జరిగేది. సో ప్రతిదానికి తిట్టేవాళ్ళు. రోజు ఏడ్చుకుంటూ వెళ్ళేవాళ్ళు. ఏడ్చుకొని ఎట్లా అంటే మాకు కామన్ డిఎంఓ రూమ్ ఉంది, అక్కడ పోగానే ఏమే రాజ్యం అనేది ఉమా శైలజ మేడం ఉండేది, శైలజ ప్రసాద్. ఆవిడ రాజ్యం పట్టించుకోకే ఏం చేస్తాం, ఎప్పుడో పాపం చేస్తుంటాం, సాయిబాబా చూసుకుంటాడు. తిట్టి మేము తెచ్చుకుని వస్తే ఇప్పుడు సాయిబాబా అనేది. సో తిరుమల మేడం ఉండేవాడు పాపం. ఆవిడ వెరీ సాఫ్ట్ లేడీ, గుడ్ లేడీ, బ్లడ్ బ్యాంక్. ఆమె కేసు బ్యాడ్ అంటే ఆవిడ వచ్చేది, స్కాన్ చేసేది. రాజీ ఊరుకో రాజీ ఏమైతుంది, చిన్నపిల్లలు కదా, పెద్దోళ్ళే కదా, మళ్ళీ అలా అందరూ తిట్లు తిన్నామండి. తినలేదు ఒక్కరు వీళ్ళు వాళ్ళని ఏం లేదు. బట్ వీ యూస్ టు హ్యావ్ ఎ గ్రూప్. సాయంత్రం 2 గంటల నుంచి 4 గంటలు. ఇప్పుడు 9 to 4 వర్క్ చేయమంటే 8 చేస్తున్నాం. అప్పుడు 3 గంటల వరకు ఉండి 4 గంటల వరకు వీళ్ళు తిని అన్ని మాట్లాడుకొని కన్సోల్ చేసుకొని 4 o'clock అన్నం తిని 5 o'clock వెళ్ళేవాళ్ళు. మళ్ళీ డ్యూటీ డిఎంఓ 10 సెక్షన్లు 10 సెక్షన్లు ఉన్నాయి. డిఎంఓ కంటే తల ఒక 2 days వెళ్ళేవాళ్ళం, చేసి చెడిపోయేవాళ్ళం. మళ్ళీ మార్నింగ్ 9కి ఆవిడ ఇలా ఉండేది బయట. ఆమెను తప్పించి గుడ్ మార్నింగ్ అంటే వెళ్ళు వచ్చేవలే అని. గుడ్ మార్నింగ్ చెప్తే తప్పు చెప్పకూడదు. అక్కడ పోయి రేషన్ ఇట్లా ముట్టుకుంటే ఇట్లా పెట్టు. అది నా ముందు కళ్యాణి మేడం, అంబుజా మేడం వీళ్ళందరూ సీనియర్లు ఉన్నారని లైవ్ లో ఉండాలి అక్కడ. వాళ్ళు వచ్చేసరికి 9:05 అవుతుంది కదండి నాకు. లేట్లో పెట్టు, వెళ్ళు లేట్లో పెట్టు అనేది. తర్వాత నవంబర్ నెలలో అటెండెన్స్ తీసుకొని హైయెస్ట్ లేట్స్ డాక్టర్ సుహాసిని క్లాప్స్ కొట్టండి. సుహాసిని మేడం ఇస్ మిస్సింగ్ దిస్. నెక్స్ట్ లేట్ రాజ్యలక్ష్మి. అట్లా గ్రేడింగ్ ఇచ్చేవాళ్ళు. సో ఆ భయానికి చాలా నేర్చుకున్నాం. కానీ వాడు ఒకరోజు చూడకపోతే ఉండేవాళ్ళం కూడా కాదు. సో వీ యూస్ టు లైక్ దట్. స్టిల్ దే ఆర్ ఇన్ అవర్ హార్ట్స్ as long as we live. That is the pioneership of their professors. And regarding Narmada and Alvelu, they are my PGs. సో ఏజ్ గ్యాప్ కొంచెం తక్కువ ఉంటుంది కాబట్టి జూనియర్ మోస్ట్ కాబట్టి అందరు నా దగ్గరే పనిచేసేవాళ్ళు. వాళ్ళని తిట్టినా కూడా నన్ను తిట్టినా కొన్ని వేరు తిట్టారు. రేపు పొద్దున మాత్రం ఒక్కడు కూడా బేబీ పోకూడదు, సెక్షన్ కాదు సార్. పొగడటం ఎట్లా పొగడేవాళ్ళు అంటే అది అమ్మ లక్షణం. పిల్లల్ని ఎదురుకుండా ఎప్పుడు పొగడలేదండి వాళ్ళు. నేను చెప్తున్నాను, వాళ్ళ ముగ్గురు కూర్చొని లేదా ఇవాళ బాగా పనిచేసింది, ఇవాళ 10 సెక్షన్లు చేసింది, పాపం అది మాత్రం ఏం చేసిందని వాళ్ళు పోయారు. కానీ మేడం రియల్లీ మీరు ఎప్పుడు మా ఎదురుకుండా పోగలేదు. అండ్ మై గ్రేట్ 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 ఫ్రెండ్ అంబుజా నా డ్యూటీలోనే పాపం ఏపీలో వచ్చేది. ఆమె రాగానే ఏంటి ఏం చేస్తావు నువ్వు, రాత్రి నిద్రపోతా ఉంటావా ఏంటి, నన్ను చంపిస్తున్నారు మీరు. ఆవిడేమో సుశీలం గారేమో అంబుజా నువ్వు చేసే వెళ్ళాలి. ఒక రోజు నాకు కర్మగాలి ఈవిడ బడి చెవుడు వెళ్ళారు పాపం 4:30కో 5:30కో. ఆవిడ అప్పుడే ఫోన్ చేశారు, మేడం అంబుజ ఎక్కడ ఉంది మేడం, ఇప్పుడే బయటకు వెళ్ళారు. ఎక్కడికి వెళ్ళిందండి, లేదు మేడం ఇప్పుడే కిందకి వెళ్ళారు. అంతే చెప్పాను నేను. ఆవిడ అంబుజాన్ని పిలిచేశారు. ఎక్కడికి వెళ్ళామంటే పాపం ఆవిడేమనుకున్నారు నేను చెప్పేశాను అనుకున్నాను. నేను ఇప్పుడే ఇట్లా బజార్కి వెళ్ళాను. బజార్కి వెళ్ళాను అనగానే ఆవిడేమో అనేసి ఆవిడ ఏం అనలేదు. నన్ను పిలిచి అంబుజ ఎక్కడికి వెళ్ళిందంటే ఇక్కడే అంటావేంటి, నిజం చెప్పొచ్చు కదా. ఈవిడొచ్చి నేను వెళ్ళానని నీకే కదా చెప్పాను, నువ్వు ఆవిడకి చెప్పాను, నువ్వు ఆవిడకి చెప్పాల్సిన అవసరం ఉందా నీకు అని ఈవిడ తిట్టాను. పాపం ఆల్మోస్ట్ ఎవ్రీ నైట్ వచ్చానండి ఆవిడ. నిజంగా వెరీ బ్యాడ్ ఫర్ హర్. 2 గంటల దాకా ఉండి 8 సెక్షన్లు అయిన బస్ మళ్ళీ మార్నింగ్ 9కి ఖచ్చితంగా రావాలి.
9కి ఖచ్చితంగా రావాల్సింది ఎవరైనా. సో దోస్ వర్ ది డిసిప్లిన్ అండ్ వీ ఫెల్ట్ దోస్ డేస్, నాట్ నౌ. పెద్దమ్మ ఈజ్ హెడ్, సెకండ్ అమ్మ ఈజ్ హార్ట్, and the spinal cord and hands are Swarajyalakshmi, and legs are Ambuja madam, Tirumala madam, and Kalyani madam. So వాళ్ళు వెళ్తున్నారు కదా, వాళ్ళు వెంట మనం వెళ్ళటమే అనుకున్నాం. So those are the very beautiful days. What we are today, even a PG, from my PG, and these are all some of my teachers also, because I graduated and undergraduated from Gandhi. Now అవన్నీ ఎక్స్పీరియన్స్ పెట్టుకొని నాకు కుర్చీలో కూర్చొని ఫస్ట్ తలుచుకునేది ఇక్కడ ముగ్గురిని తలుచుకుని మాట్లాడతాను. ఈవెన్ ఇన్ మై క్లాసెస్ ఐ విల్ నరేట్ వన్ ఆఫ్ దీస్ క్లాసెస్. Love you, madam. Thank you so much.
Thank you so much, madam. I'm sure you all must have remembered some of your teachers during your undergrad days listening to all this. And madam, తిట్టకపోవడం కాదు, మీరు సానబెట్టారు మమ్మల్ని, అది అవుట్కమ్ డైమండ్స్ లాగా.
Thank you, Narmada. Thank you. Indeed, a proud moment for all of us. We enjoyed a lot, and you were really dynamic and focused during your PG days also. So you know what to do in the future. You have decided then only. Yeah, really, I wish you very good luck in your future endeavors.
Thank you, madam. SPH PGs, Kausalya, Pavani. Any more SPH PGs just come for a moment.
Okay, ready, ma'am.
3, 2.
Ma'am, madam.
Location.
Thank you, ma'am, for this heartwarming session. The reverence towards the teachers and the mutual respect it takes, I'm sure, all the audience back to our PG days, and they're really the pulse of wisdom. So now we'll proceed on to the next session. So the next speaker would be Dr. Roma Sinha. She is a renowned gynecologist, minimal access and robotic surgeon, Apollo Health City, Jubilee Hills, Hyderabad. She is also founding president, Association of Gynae Robotic Surgeons of India. She is honorary professor, AHERF, associate professor at Macquarie University, Australia. She is a fellowship director at MARS Apollo. She is also a professor, Asian Society of Gynecological Robotic Surgeons. She is an editorial board member of GLGRS, Gynecological Robotic Surgery Journal. She has been felicitated with various awards such as FIGO Fellowship 2000, AOFOG Young Gynecologist Award 2002, Kamini Rao Yuva Oration 2004, Vasant Shabin Scholarship 2005 Melbourne, Legend in Gynecology 2017 Times Healthcare Achievers, Distinguished Clinician 2021 and Clinical Tutor 2018 Apollo Hospitals, Nari of the Decade 2010 to 2020 and the Best Robotic Surgeon 2019 and 2019. She has done her, so it's but obvious that she is an MD with 7 distinctions and gold medal from Varanasi BHU, and she is the DUX of School St. Xavier's, Bocaro Steel City. Please, I would extend a warm welcome to Dr. Roma Sinha, and she would be throwing light on the current updates of management in endometriosis. Please welcome.
Thank you, Nafiz, for your wonderful words. Thank you so much. I must start by thanking Narmada for organizing this beautiful CME, and I think it is such a focused CME that probably everybody who have come today will really enjoy. Thank you so much for involving me in your program, Narmada. So great. As he's fixing, I'd just like to say something. Over the last 26 years that I have been in Hyderabad, it has been actually quite a lot of years here, I have learned vicariously from all the professors that you today. Although I have not been so many points to learn from them, and it was really great. So only one thing to all the postgraduates sitting here, the teacher who cares, just remember that. It's a tough time when you are in the graduation time, but that's the time when somebody will hold your hand and teach. Once you're out of it, nobody teaches, and you are on your own. So better learn from all your teachers whatever you could in those few years that you are with them. Anyhow, so we will start with the so as Narmada had requested, I have made it video intensive. That's what she had requested to talk about on endometriosis. So I will start by saying what best can be done, and of course it will be on fertility enhancement because that's the focus of the CME today. We know that 25 to 50% of infertile women have endometriosis, and about 50% of endometriosis patients are infertile. So 1/3 of patients of chronic pelvic pain, whom we don't understand what's happening, end up having a diagnosis of endometriosis. Eradicating endometriosis is the first step that you can do, or stop its progression to improve the fertility in these patients. And for that, you of course have to diagnose it early. Poor correlation between the symptoms of this disease with the treatment, and that makes it very difficult. So what are the reasons for having infertility? I wouldn't go into all the details, but basic headings are few. One, distorted pelvic anatomy. We all understand. So the ovarian anatomy is distorted because of the presence of endometriosis, endometrioma, tubal pathology, and so on. But there is also abnormal peritoneal function. There is endocrine and ovulatory abnormalities in these patients. Implantation is impaired, abnormal transport in the tubes, and of course endometrial receptivity is also affected. So it's a multi-pronged effect of this disease in the pelvis that makes these patients infertile. So I'm going to make it more simple for you. What should you do if you either think the patient is infertile? So you need to first make a diagnosis, and that also an early diagnosis. I'll come to a small topic and discussion of what we call as clinical endometriosis today. To be or not to be is the good question, because many people who are surgeons and endoscopic surgeons like me may think, okay, the minute you see a patient of endometriosis, surgical. To be or not to be? Do you need to do that at that point of time or not? And what do you do? So that's a very big question that you need to ask yourself. And of course, you have to deal with 3 diseases or 3 parts of endometriosis. One is the peritoneal disease, the other is the classical endometrioma, and the last but not the least is the deep infiltrating endometriosis, which we often neglect to diagnose and treat when we are doing this. So this is a very interesting paper that you should all go through about effectiveness of laparoscopic surgery in treating infertility-related endometriosis. If you go to the literature, you'll also find multiple guidelines by all societies which talk about. The reason that there are so many multiple guidelines is because we have not reached any consensus. It's very difficult to do randomized controlled trial in patients who are suffering from infertility and say, okay, half I'll do this, half I'll do that. Very difficult. So we basically go about good clinical practice, evidence-based practice, observational studies, sometimes RCTs, and of course, systemic review and meta-analysis to derive to a conclusion as to what to do in patients of endometriosis at what stage they are presenting. You have to also remember that when we are talking about surgical management of endometriosis, it's on a seesaw. So you need to remember 2 things. One, if you are dealing with a young woman with endometriosis, remember to be very prudent in your surgery. You need to reserve her ovarian reserve. But what is the hand side? Is that you must counsel that there are chances of recurrence. On a ballpark figure, you must say that if the patient is not compliant to your medical therapy post-op, then there is a 20% chance of her recurrence of endometriosis by 2 years and 50% chance by 5 years, which is pretty high in 5 years' time for a young woman. So that goes back to the question whether you should operate her at the age of 19 and 20 or not. But if you're dealing with endometriosis, an older woman, which either has completed her family or probably has tried all kinds of infertility treatment, has come to a point that she's not dealing with anymore, at that point, if you're dealing with your surgery, it should be a more aggressive surgery, decrease the recurrence rate by excising all the tissues, and that's where you should counsel them again. So what happens if you don't miss an early endometriosis? Now, increased visits to the physicians. Why do we miss? We miss the diagnosis. Patients come with pain or some other problem, we never think it could be endometriosis. Or if we miss, we give that lady or that girl a lifelong profound influence of this untreated disease. It increases the economic burden, and focusing the CME, it increases the burden of infertility in these women. So why do we miss? Remember, there's a word called anamnesis, and I always teach this to everybody when I'm teaching endometriosis. Anamnesis is nothing but you patiently listening to the woman or that girl who has walked in. It is a recollection or remembrance of her past, especially starting from the time of menarche. So when a patient comes, don't look into a file or don't look at the diagnosis somebody else has made. Put the file across. Just tell the patient 5 minutes, you tell me a story from menarche to the day you have arrived in my office. What is your story? What has happened? And then you will understand that she has so much to tell. Her expression, the way she feels, the way she talks, you will almost make a diagnosis. What is the omnipresent symptom? Is pain. Remember that all of them will have pain. The degree may differ. It may not even match the severity of disease, but pain is omnipresent, which could be of any type. It could be dysmenorrhea. Only dysmenorrhea is not endometriosis. It could be periovulatory pain. It could be a chronic pain in the pelvis. It could be dyspareunia, dysgenesia, dysuria. So many pains can be there, but pain is almost omnipresent. So what is your red flag in the history to be able to diagnose? Pain, as I said, fertility, infertility, subfertility, menstrual cycle abnormality, heavy menstrual bleeding is associated. If an adenomyosis gets associated, not responding to medication, absenteeism from school, family history, and associated bowel movements. Remember to look for the unusual pain, and they are right shoulder pain, could be rectal pain, can be because of radiating pain to the legs, sciatic nerve involvement. Menstrual headache is one of the reasons you should ask. Bloating around the time of periods is another thing you should ask in these patients, which will give you the physical exam becomes your tool to examine these patients. How do you do the physical exam? You must look at the cervix. Is the cervix moving? Is the cervix stable? Is the cervix painful? Then you look at the paracervical area, at neck management. Can I feel something there? Is there pain there? And then you go and palpate the levator and eyes to understand if you have endometriosis, deep infiltrating endometriosis, almost like a CS cervix. Like you look for the parameter, right? In endometriosis, you should look for the parameter. You can't understand, girl is young, virgin, to a PR. You will get to know whether there is endometriosis or not at that point. You will find the cervix is deviated to one side. And believe me, maximum are deviated to the left side, because deviated towards the left. And when you examine, you'll find cicatrization in the left fornix and not on the right one so much. value of pelvic pain is also important because these women or girls sometimes don't visit you. They visit your colleagues, and they could be gastroenterologists, orthopedicians, urologists, even psychiatrists, and pain exacerbate during menstrual cycle. And if the patient says yes, please send them to a gynecologist for evaluation as well. Should we rely completely on imaging? That if we find something on imaging, there is, I'm sure Dr. Praveen must have, sorry missed your lecture sir, but must have spoken these facts about. So there is scan is very, very sensitive to pick up, especially in good hands, but a negative scan does not mean that there is no endometriosis. So some of the clues in endometriosis for scan, there will be hard markers, like there is endometrioma, there is a hydrosalpinx. But there could be soft markers like ovarian mobility is not there. Or there could be some site-specific pelvic tenderness when you put a transvaginal probe. So these are things that you should look. But also remember, this is a video of a patient, 35-year-old, secondary infertility, being managed for secondary infertility, thinking there is a right ovarian endometrioma for almost 6 to 8 months. I don't know why she came to us. Probably somebody told her you need a surgery. I looked at her and I said, probably it doesn't look like endometrioma. On my hunch, I got an MRI done. MRI did not give me the suggestion that it was endometrioma. Actually, if you can see the picture, it's not a typical endometrioma. It was actually adenocarcinoma. And I, to my benefit, I had gone in with the consent of oophorectomy, and I straight away did a oophorectomy for this patient. So you have to understand that you have to take the whole larger picture into consideration before you proceed. Visual diagnosis. So is something that you see on your laparoscopy always confirms? Probably yes, probably not. So you need to prove it by histopathology, and at least 1, 2 of these signs should be present when the pathologist looks at the tissue that you have sent. There should be endometrial gland, there should be endometrial stroma, or hemocyte-related macrophages. Weight less than 50% of tissues actually confirm this. Should we completely rely on laparoscopy? You could, but you need to have a keen eye. You need to have that experience to be able to pick up. These small hemorrhagic spots in the ovarian fossa can be a reason for early endometriosis. So if you have done a laparoscopy for chronic pelvic pain, you will find all these lesions, red inflamed lesions in the ovarian fossa. Lift up the ovarian fossa properly and check. They are the first places where you will find endometriotic nodules or endometrial disease starting up. Then you have to look at the posterior. Turn your 30-degree lens upside down. Go deep into the uterosacral area and see. Allen-Masters defect. We've sometimes seen it's just a peritoneal pocket. No, it's not. Allen-Masters defect, 90% of the time, if you do the biopsy from the base, you will find that there is endometriosis there. So this kind of, or powder brown lesions in the laparoscopy. So all these things, you can have a small endometriotic spot on the bladder base. May get missed if you have not looked into very, very correct in detail. So these are small things you should pick up. These kind of vesicular lesions are also early endometriosis. So this is something that you should pick up when you do a laparoscopy in these patients. So then comes the diagnosis of clinical endometriosis. Do we always need to put a laparoscope in to diagnose these lesions that I just showed, or on your clinical impression, could you treat them? Remember, if you as a clinician diagnose the patients in clinical endometriosis stage, and even if you have done the good thing of starting them on oral contraceptive pills, then Narmada will not have so much difficulty in making a content. She will thank you, because endometriosis will not be that bad, and her success rates also will increase. So if you look at the recommendations by many of these societies, they all today say that empirical treatment by either oral contraceptive pills or Dynogest or some progesterone can be started if you clinically suspect these patients to be endometriosis. So please don't hesitate, and don't say that unless I do laparoscopy, I can't do anything. Again, do you have that in this kind of patient where there is a small nodule on the right uterosacral ligament, but mainly it's a peritoneal disease. Peritoneal disease can give rise to pain, can give rise to infertility. But excising that, like a peritonectomy, will give improved spontaneous pregnancy rate as well as ART. So you must remove all the peritoneal lesions, because removing that reduces the biochemical defect, biochemical abnormality into the pelvis, improves implantation, improves the success rate and carry home baby rate in these patients. So you can see these are all lesions in the peritoneal cavity. That lesion is removed. There's a lesion in the ovarian fossa. When you are doing this peritonectomy, remember to keep one eye on the ureter, whichever side you are in, and then first you, maybe if you have nodules, remove the nodules, then go ahead and remove the whole peritoneum like we have done in this particular patient. So that's the nodule that has come out. And then you pick up the peritoneum, posterior peritoneum, dissect it away from the vital structures, At this stage, remember only two things. One is you need to know where your internal iliac artery and your ureter. These two you have to diagnose. Remember, identify them, push them across, and then remove the whole peritoneum as it is. You can use any energy device. You can use harmonic as we are using here, or you can use a monopolar scissors or a hook or a spatula if you are used to using monopolar devices. So you can use anything, and that's the peritoneum that comes out. So prevalence of visually amenorrhea, and almost 50% of patients with chronic pelvic pain is not necessarily resistant to treatment, will show you these lesions when you do a laparoscopy. So laparoscopy, then you should refer the patient to a clinician who can do a good job, because sometimes you may think, oh, nothing, I'll find, but there could be a deep infiltrating endometriosis in these particular patients. So next step that you need to manage in patients of endometriosis is endometrioma. And we all love endometrioma because it gets diagnosed on scan, you find a cyst, patient is ready for surgery, old girl who has only pain. What is the hindsight if you don't operate? If you don't operate, we also understand that endometrioma, presence of endometrioma itself can cause. So it's a very tricky situation. And you know disease by medical therapy. Given pain, why gynecologist will be doing a operate on the patient. So better, all of you should learn the tricks and trade of what you should do when you have an endometrioma. So you have to remember a few things. Endometrioma, the damage that you will have, long-standing endometrioma, there will be more damage. Full cystectomy, or should you do a Donet's method? Of course, does the magnification and vision matter? And should you use vasopressin in this dissection is something that you should think. Now, I'll just run one video for you to just show you how we identify 3 zones of endometrioma. Okay? Zone 1 is the punctum. Is the place where you actually will the uterus, a good support at the vagina will make or break your surgery in endometriosis. Some people always, but somebody can elevate. So that's the punctum, and you drain the endometrioma. That's the first step you need to do. And then is the zone 2 is where you strip the endometrioma wall from the normal ovary. That is the most reducer ovarian reserve. The last thing that you can do in reducing the ovarian reserve is to use unnecessary. Use plain saline, gives you the right plane. Second, near the infundibulopelvic, near the base of your ovary, don't try to remove or use bipolar. Near the infundibulopelvic ligament, the more you have actually done the damage to the supply itself, other than just the ovarian. Regular laparoscopy and robotics is few things. One is the vision. So vision is not just we are talking about 2D or 3D, but the vision is stereoscopic. So it's a rock solid vision, which is actually the best energy for dissection. We have moved from monopolar to. But with robotics, I have actually done my reverse learning. Over 10 years of doing robotics, I have done reverse learning, and I realized that monopolar energy has the beauty to dissect of monopolar energy, will go into the fiber and peels off without having any residual bleeding from the ovaries that you have saved. So you don't have to come back and do any more bipolar coagulation. So these are some, but where possible, we try to use. Uterus is properly incised, fibroids are removed, reconstructed well, give them 3 to 6 months time depending upon what is your protocol. Because that's the biggest problem that occurs, and I've found so many of them come back to us with recurrent, operate them again, but you don't know how to help them with fertility. So this is, sometimes you can have a different coexisting endometriosis. So this is some people with the placement that we do for robotics. You can see these are two, because type 1 endometrioma is very difficult to peel. Type 2s are better. We put a bag in the beginning because we know now that we'll have multiple specimens to be derived from this patient, and then we keep collecting them in the bag as we do. So that's the punctum of the endometrioma. That's the dissection that is taking place with the surrounding progress to the uterus. Another one tip of endometrioma, don't be hesitant to open up. Cut the whole endometriotic tissue or the cyst completely open. Gives you an advantage of getting the right plane, or also inspecting inside the cyst wall that you are not missing something else or some other cyst, adenomyoma. We also, at least in robotics I try, or even in lab now, is to keep, if there are multiple fibroids, we keep on suturing. Otherwise, that's what makes the oozing and the blood loss more. Anterior wall fibroid tackled, then this is the adenomyoma that we are tackling at the fundus, and then we'll come back to the posterior wall and remove the rest of the fibroids. To also be careful, where you have opened up endometrial cavity, make sure you make that note in the discharge summary so that the patient is aware that the endometrial cavity was breached. So that's the adenomyoma removed and the uterus being reconstructed, and then finally we'll come back posteriorly to remove. That you might have to deal with is deep infiltrating endometriosis. But extensive excision of deep infiltrating endometriosis is also correlated with improved pregnancy outcomes and take-home baby rate. So deep infiltrating endometriosis, it may not be possible for everybody to do deep infiltrating but sometimes we get this request back from the infertility specialist that the ovaries are not accessible. Ovaries are buried deep in or very high up because of the presence of nodules there. So then we need to go and operate on deep infiltrating endometriosis. But always the knowledge that you are going to tackle or you are going to face a deep infiltrating endometriosis pre-operatively is most important, because you have to go in with proper consent and counseling. You can't operate a patient of deep infiltrating endometriosis because behind the scenes is the main disease. And if you have not really thought about it, you have not counseled the patient, you can't operate because she has not given you consent to do all that, right? She has not given you consent for doing rectal dissection. You might open up her rectum. So you have to counsel and tell her that this is what you will do and this is what will happen. This is most common. Always you have to do ureterolysis, you need special skills, and you need to actually do extensive dissection. But remember, you can become a surgical multiplier by doing a teamwork. In deep infiltrating endometriosis, always have 2 people around you and make sure that they know before you take the patient in the theatre. One is a colorectal surgeon and the other is a urologist. In case you need, we almost always show our patients to these people when we deal with deep infiltrating pre-operatively in their outpatient. 2 reasons. The surgeon needs to be prepared what they need to do, and the second, the patient needs to know who's going to come in. Don't do a ghost surgery that you've taken the patient in and call somebody from behind, and that's not right to the patient or even to your reputation. So don't do that. When the surgical strategies for deep infiltrating endometriosis, we say there are 5. One is follow the ureter, follow your heart. You have to identify both the ureters and follow them into the deep pelvic spaces. Second, endometriosis, isolation of lifting the ovaries from the lateral pelvic wall and doing the ovarian cystectomy if the endometrioma is present. Third is isolation of both uterosacral ligaments. When you identify the uterosacral ligaments, you'll find the pararectal space, both medial and lateral, the Okabayashi space, and then you can go ahead and do the rectovaginal septum excision by freeing the rectum from there. And then, in the end, you got to do what you got to do. Had complete hydroureteronephrosis. This is one more thing which is your responsibility. If you think a patient is of deep infiltrating endometriosis, do an upper abdomen scan also. Because we many times stop by doing just a pelvic scan. We miss this diagnosis. So you have to identify which are those patients. Again, left side more disease, look for the left side kidney. If it is hydronephrosis, you need to actually do very extensive dissection. This is the same patient, right side it's going on, but then you have to actually, that's the left side, which is extensive endometriosis of the you can see this is almost feels like a knotted structure here of the left ureter getting into this. But you need to dissect all that to be able to do that. You can also have the same thing with robotic surgery, where of course movement is like a painting. So you go very slow, or you can just move your hand with monopolar. That's what I've learned with robotics, how much monopolar is good in deflecting abnormal tissue from normal tissue. It really, it's like butter to knife. So it really can move and you can get the right place. But both technologies are good, and we must make sure that we give the best to our women who are suffering from endometriosis. Then of course you have pouch of Douglas, which will be completely obliterated. with endometrioma both sides, rectum is adherent, and you need to identify the rectum to be able to reach where you want to reach. Then comes the identification of uterosacral ligaments and the pararectal space. This is something which you need to actually find out very, very understand. This is the point where we often take help of colorectal surgeons, and that's important because they are the people who understand that space and they're able to do it. So that's for 10 minutes. We'll get the colorectal surgeon in our theatre, and they can actually help us getting the rectum off the rectovaginal space. Once that is done, then we take over and identify all the lesions and excise all the lesions. So it's a teamwork. You must understand that it's a teamwork. And you should know what you need to do, what you need to tell him to do, because other than you, they don't understand the disease. They may understand the technicality of doing the dissection, but they don't understand the disease. Since you are the captain of the ship, you must make the decisions of what has to be done. But then you can see that now here, almost the rectum is off the rectovaginal septum. You will see in the end that we have put a finger in the rectum is intact, but that space is completely open up. And once we do that, then we look for nodules in the uterosacral or on the surface of the rectum and dissect them and remove them. So this is very, very important that this step has to be done in patients of rectovaginal septum. If you don't do this, you've probably done out the surgery. And the patient will come back with recurrent. You can see that's the rectum. The rectum is completely free now, and that's the vaginal fornix that you have seen. Again, you can have the same thing in a different. You can also have a similar patient where you have, this is the MRI picture of these patients where there was deep infiltrating endometriosis at this level. You can do your PR examination and make this out. Most of these patients actually doing a sigmoidoscopy does not make a difference because transluminal involvement is in less than 2% of patients. It's mainly either the serosal involvement or sometimes the muscularic involvement of the rectum. So you could do a sigmoidoscopy if you have the option, but it's not really always necessary. Again, there's a similar thing going on where you are dissecting the rectum off. The last, if you are in deep infiltrating, you have got to do what you've got to do. So what do? If you have a focal adenomyosis of outer myometrium, now you can see this, an infertility patient, focal adenomyosis of outer myometrium, you can see you can also see the chocolate material coming out and the sigmoid adherent to it. So you dissect it off, the sigmoid, and then remove this nodule of the sigmoid as well. So this is called a focal adenomyosis of outer myometrium. Again, not an uncommon problem if you look for it, and you will find that these are the patients who actually end up getting the deep infiltrating endometriosis, and then that nodule is getting excised off the rectal wall. Then you can have a laparoscope, and once you get the rectum off, then you actually dissect and shave off the rectal nodules from the anterior wall of the rectum. There's another picture of focal adenomyosis of outer myometrium. These are so typical. There are cystic lesions, very, very precise, excising all these little cysts that are there. Reducing the burden of adenomyosis in these patients is very important for their reproductive organ. You can see these are all nodules that are present in this patient. So almost like outpouching from the myometrium. And when you cut them, they are all filled with chocolate material. So we know that in MRI, when you look, you will find those cystic spaces. But the outer myometrium, when they are present, excision is important. You can actually also then excise tissues from the bladder base. You can see there is a small nodule in the bladder base there, and then excision of that nodule is again very, very important. Otherwise, they will progress as you leave them in the postoperative period. And sometimes they can also be the reason for their pain. Excising a nodule from the surface of the tube. These small nodules can also cause tubal dysfunction. So make sure that at this time you don't have too much bleeding. If there's too much of bleeding and you've used too much of energy, then you've actually damaged the tube. There were vesicular lesions all over a small bowel. So we had to go step by step, excise most of these lesions from the small bowel also. So make sure that you move your laparoscope around the patient before you start your focus in the pelvis. You can also have a vaginal nodule. In this particular patient, you can see there's a left ureter which is dilated. That's a vaginal nodule in this particular patient. It's right here. So you start excising. This is a robotic surgery that we were doing in this particular patient. Excision of this nodule right from the rectovaginal septum, opening up the vagina as well. So this patient underwent a deep infiltrating endometriosis surgery. We had to actually open up the vagina. She was actually an unmarried girl. Opened up the vagina and then excised the whole thing because there was so much of dyschezia and pain for this particular patient. But she was smart. She went to a center and got her eggs frozen before she came for this surgery. So I think she's good that way. When she gets married, probably they'll come back for the embryo transfer. You can also have extragenital endometriosis in the diaphragm. This is another one patient who had shoulder pain all the time. And you can see there are multiple lesions on her diaphragm just above the liver. Again, excision is important. You need to do a thorough excision. And in this particular patient, we actually had to do through and through diaphragmatic excision. We even opened up the pleural cavity. But the excision, you can see when you are making a cut, the endometriotic tissue is just dripping from there. And this patient now is better for shoulder pain. I think still continuing, not a very old video, this one, probably 6 months time, still continuing with her infertility treatment. So I would actually just end here. Hopefully I made some sense to all of you. But of course, an invitation to a very, very exclusive meeting which is happening in Hyderabad in just 10 days time, which is a robotic surgery in gynecology, which has never happened in this country because everybody has multi-specialty meetings. But we thought time was ripe to have this. We have 4 international faculty who are flying in just for any one of you who wants to join us. And they are actually the stalwarts in robotic surgery all over the world. We are discussing both benign and malignant. Even if you think you are not doing or don't have a robot, remember that in 5 years' time, whichever hospital you'll be working will have some type of robot available. Because there are 5 platforms already in India. It's not just the Da Vinci. We also have started an association for people who want to join us and learn on this field. It will be an academic body, and I welcome all of you. If any one of you want to come for this, please ping me, and we will take you for the early bird registration, which was already over, but I'm sure today if I have met you, we'll do that. Thank you so much for your patience.
Thank you so much, ma'am, for sharing your profound clinical acumen and showing us how to tackle the challenging situations which we face in endometriosis. We are really grateful for that. And now I request Dr. Satyavati madam to present a token of memento to Dr. Ruma Sinha ma'am. Please give a huge round of applause.
So we'll be discussing 4 cases and then break for lunch. All the 4 cases, I have a disclaimer. Everything I'm talking are the cases we have seen at Genesis. But if I put them in one case, it didn't happen to same couple or same patient. It's from different couples, but everything we've heard at Genesis. And I was thinking, this will be a very useful platform for the gynecologists who practice infertility to know what they can do in their clinics and understand and gain more knowledge. Case 1, twin.
Yeah,
All the panelists should be able to see on that screen. So she's a 28-year-old, married last year, consanguineous wedding. She's referred for a pelvic scan. So you all know who the question is going to. She also gives a history of oligomenorrhea. She gets period every 3 months. Her BMI is 30. Her AMH is 7.2 nanograms per ml. And we all agree, even before I say the last line, that she's possibly a polycystic ovaries. So my question to sir, sir, how do you diagnose polycystic ovarian morphology?
Yeah, basically when we have a clinical scenario where we have presentation with all these features of polycystic ovarian disease, basically we have to take One is the volume of the ovary, the second one is the antral follicle count. These are the two most important factors that we consider before we call it as a polycystic ovarian morphology. The minor criteria are the increased stromal thickness and echogenicity, increased stromal vascularity, and peripherally placed follicles. These are the factors that again, so these are all the ultrasound features which will prompt us to think in terms of a polycystic ovarian morphology. These are the typical images where you can see that the volume is very clearly demonstrated at the bottom corner on the right side, and which is almost about 50 cc or 55 cc. Normally anything more than 10 cc is considered to be an increased volume, and this is one tool which again is going to be of great help, particularly what's called as the vocal software, where you can trace the ovary, because see, when you try to calculate manually, you try to take the diameter, length, width and breadth and then multiply it with 0.57 and then you get the volume, but then that's not accurate. This is this one which you trace the ovary at almost about 6 slices and then calculate the volume, and which gives you an accurate size and volume of the ovary. Because basically, as I said, there are two major criteria which you depend upon to call it as a polycystic ovarian morphology. So one of the criteria being increased volume, so you have to be very accurate in identifying the volume. The second one is the antral follicle count. Now, basically when you see that first image on the right upper corner, how many of you can manually count the follicles? I don't think it is possible. Not only that, you are taking only one plane. So there are multiple planes which you need to evaluate, and then there are multiple follicles which are there. And when you are really depending upon the number of follicles, anything more than 24 is considered to be a polycystic ovarian morphology. So that one can be easily done with what you call it as antral follicle count, AFC, and wherein we can use the software where we can usually it takes various slices and identifies the various follicles, and then it also gives you not only the size of the follicle but also the volume of the follicle and the distribution of the follicle. That makes it very convenient for us to identify the number of follicles. Anything more than 24, anything more than 10 cc is definitely two major criteria which are fulfilled to call them as ovarian polycystic ovarian morphology. And the second important thing is the vascularity of the stroma. As you can see, you can even have, as I said, it is not only the subjective parameter, but you can have an objective parameter where you identify vascular index, which tells you the exact amount of vascularity which each of these voxels have got. So based on that, you can identify the vascular stroma thickness, vascularity, as well as the echogenicity of the stroma. So these are the factors which will definitely help us to come to a diagnosis of the polycystic ovarian morphology.
Thank you, sir. So once she had the diagnosis of polycystic ovaries, Dr. Uma Sinha, she presents to you with this scan report where sir said the volume is 50 cc, which is 10 times more than the expected, and say 60 follicles on each side, and somebody advised. We all know that the patient trusts the doctor close by than the specialist she goes to. So she went to the doctor and the doctor said, go to Dr. Uma Sinha and get a laparoscopy done. So she comes to you for ovarian review.
I missed out, Narmada, what was the age and presentation of this patient? Because
married, 28-year-old, married for 1 year.
Okay.
Not regular cycles.
Mm-hmm. So,
and slightly on a healthier side.
Good. So on the bottom line, I would say ovarian drilling is the last resort, right? So this particular patient who has come to me with 1 year of married life, with high BMI high, I want to understand why has she come to me. I mean, I understand somebody is referred to go and get it done, but then I almost never will take that. I'll take it with a pinch of salt and try and understand what's the patient's problem. In PCOD, again, first thing you have to make patient understand, that's a lifelong problem. It's a condition of your body. I cannot treat it by one hormone test or one drill. Once you drill that, then they become receptive. Okay, if it's a condition of my body, what do I do? So at this stage, if she's looking for pregnancy, then obviously there will be lifestyle modification, but I think this patient doesn't require drilling, it requires an ovulation induction for her to get pregnant. But if her idea is not to get pregnant and she wants only regular cycles, I'll put her on contraceptive pills, because she will then have regular cycles, she will have conception, her androgen levels will come down, and everything else also will improve. So I think I will have to do a reverse counseling for her, that I'm not doing laparoscopy for you. I'm not doing any ovarian drilling for you, but maybe 20 minutes of my time will go and try to make her understand what to do. Yeah, it takes that much time.
Golden words. And then don't do something because somebody asked you, do what is right for the patient. So she's put on oral contraceptive that she wants to other gynecologist gets ovulation induction done back to you. She says she's not ovulating, she's lost weight, her BMI is 25. Still asking, then you also agreed that she needs drilling now. If you agree and proceed, is there any guidance on ovarian drilling?
If you have to do the drilling, which I'll tell you in my 26 years of practice, I can actually count and tell you how many patients will drill. We don't, really don't, because I think it damages the ovary more. And we have also seen such patients come back with ovulation or ovary additions to the other pelvic organs. It's really very bad. But if you have to do, take the antimesenteric border, divert the ovary above, and with a very, very fine needle, do not more than 4 or 5 punches. That's all. One shot. With a 30 watt monopolar current. That also you remember, don't use very high current. So the damage, the thermal damage you do by using the electrosurgical equipment depends upon the wattage that you use, the point of contact that is there to the tissue, and how long you use. So all three will increase the damage. So minimum wattage, thinnest needle, less point. So just do wonder and come out. Don't keep on making a big hole there.
So that's what we wanted to know. And anything you would do to prevent additions because you'll be using monopolar?
I'm not a very big fan of anti-adhesiolysis. In fact, in our endometriosis and myomectomy, we don't. We do believe that good surgical techniques will prevent adhesion. So remember that, see, you can't become a good surgeon by just using different things or using the best tool. Again, if you don't know surgery sitting on robot, again, you cannot do surgery. So a tool who doesn't, a person without a knowledge, just having a tool will not make you a better surgeon. So remember, very fine needle, 1 or 2 incisions and leave the patient. But one thing you could do is, you could actually cool the tissues by putting water there at that time.
Simple. Cool them so that they don't get stuck with the heat.
Let me just add one more point.
Yeah, please.
There is something called as the rule of 4.
Yes.
4 punches, 4 seconds is the
duration
of this one. And then 4 millimeters, and Madam said 30, 40 easy to remember.
Okay, it's the rule of 4 seconds, 4 spots, 40 watts, and 4 millimeters if the needle can be thin. Then you know what happens. Everybody who's advised surgery to get it done where they are supposed to be done, we all know that. So what she did is, she didn't go to room. She went somewhere else. Who could do it for cheaper alternative. And we all know how cheaper alternatives are. So she got a laparoscopy and ovarian drilling done. She attends to you after 6 cycles of ovulation induction. She was ovulating but not getting pregnant. And then you thought you should repeat her AMH. People can guess what could be. AMH was 2.6, originally it was 7.2. Any guesses why this happened? Or can you advise on the reasons behind significant drop in the AMH?
Yeah, as rightly pointed by Dr. Sinha, that whenever you do ovarian drilling, there will be a drop in the ovarian reserve. I'm not sure if the doctor there has used the precautions. First of all, it was not indicated, I guess. And second thing is whether she has used the correct methodology, which might have resulted in the drop in the AMH level.
It's quite common. I think heart-wrenching for the fertility specialist to see 2 MH results, which is significantly dropped. And in your lecture, you said so many times, use the word ovarian reserve so many times in surgery. What fertility options would you recommend?
The fact that I would, as you have already mentioned, that she has had 6 cycles of ovulation induction, and then the ovulation has been documented. So the fact that you have tried all these, procedures, these methods, probably the next option would be to go for a assisted reproductive technique, for the simple reason that these patients' AMH has dropped from 7.2 to 2.61. Secondly is that we have attempted 6 cycles of ovulation induction, and we have documented ovulation. In spite of that, she is not conceiving. So there is no point in trying the same thing again and again. And we all know that even the recommendation says you can't go beyond maximum of 6 to 8 cycles of ovulation induction. With this background, probably I would advise her to go for in vitro, ART techniques probably. That is where I would like to counsel her.
Okay. So no point in repeating the same procedure.
No point in repeating the
which is not working.
pause again. Yeah.
Okay. And then at that point, they tell us, now the wife says, he has premature ejaculation. So I've sent her, we'll send them to you to advise on what can be done. Fertility she was not taken probably because initially she was coming for gynae and PCO, and when fertility was opted, this is what you know. What history are you supposed to take to confirm the same premature ejaculation?
First of all, premature ejaculation has nothing to do with fertility, unless male is ejaculating before penetration. So there is a myth in most of the people thinking that the duration of intercourse is directly proportional to fertility.
Potential.
So that is a myth. And regarding this premature ejaculation, only that will add to their sexual life and body. So regarding premature ejaculation, if it is important, then history is whether this premature ejaculation is there from the beginning of his life, that means from his teenage, or recently which has started, that is what we have to find out. So here, what is important in fertility point of view is, if it is secondary premature ejaculation, it is more likely because of hormonal imbalance or prostatitis. If it is prostatitis or seminal vasculitis, then it is going to affect their fertility levels. That is where we have to concentrate. So how we see is whether this is psychological, that means whether it is related to performance anxiety or hormonal imbalance or infection related. So, but as a fertility specialist, just doing a semen culture and one prolactin and testosterone will help you in evaluating this premature ejaculation.
So semen culture, prolactin and testosterone. Simple, if somebody says erectile dysfunction, those are the three things you need to focus on. So that answers, you already answered the question. And then husband is advising analysis, Lakshmi Narasimha. Staff informed and the leaflet says, come with an abstinence of 3 to 7 days. We all know sometimes people come with less than 3 days, more than 7 days. So are we okay to do? What effects do you see in the sample if abstinence is less than 3 days?
Most people ask about abstinence when they come for semen analysis. So ideal period of abstinence is 3 to 7 days. It is in WHO it is clearly recommended that men should have 3 to 7 days of abstinence for the semen analysis. So the question is, what effect we see if the abstinence is less than 3 days? So usually with lesser abstinence, men gets low volume of semen. With low volume of semen, total sperms in the ejaculation will decrease. So with the higher abstinence, high volume of semen, men get a high volume of semen. So with the high volume of semen, total sperms in the ejaculation will increase, and progressive motility decreases, vitality decreases. So leukocyte count increases with the higher abstinence.
Okay, so the per ml density will not change.
The concentration will not change.
Okay. Yes. Okay, and with abstinence of more than 7 days, you covered.
Yes. Leukocyte count increases, and with the longer abstinence, semen becomes yellowish.
Okay. So probably learning point for all of us is if you see yellowish discoloration and all, just look at the days of abstinence on the report rather than thinking this person has a problem or more leukocytes. Yeah.
Yes. So there is no significant effect on semen pH and sperm morphology.
So morphology doesn't change.
It won't change with the abstinence. So WHO recommends based on clinical experience, ask men to collect the semen sample after a period of 3 to 7 days. Contribute to the variability and indicate limit between normal and subfertile.
Thank you. And then Chaitra, he is her first cousin. She married her mother's brother's son, which is a little common basically. So they asked me, madam, please advise on the test to make sure we won't have abnormalities.
Probably they should have done it pre-marital, but anyway, they are here now and they're asking the question. So what would you advise?
So the first basic thing is that when it comes to consanguinity, the risk is because of shared genetic material. So on an average, between two people who are not related to each other, the shared percentage is about 1% or a little lesser than that. But when it comes to first cousins, the shared genetic data is about 1/8 of their total genome. So therefore, the chances of them having similar genetic component is high. That may also include some mutations which are not beneficial, which may actually lead to some kind of a defect in the baby. As such, these two should be completely unaffected, since they're just carriers. So we would expect that people who are carriers for the same kind of disorder will have about a 25% risk to their offspring. So the next thing that we need to do is that we need to do carrier screening. So carrier screening is generally done by next generation sequencing. We identify the carrier status for only the recessive disorders that these partners have, and we'll explain to them what is the risk. And once we do identify those, we can either do prenatal diagnosis or we can do pre-implantation genetic testing, depending on the kind of conception that they opt for.
So would you recommend carrier screening for all consanguineous couples?
So when it comes to carrier screening also, there are different kinds. So when we know that there is a family history, it has to be done without fail. It could be something that has happened 3 or 4 generations in the past also. It doesn't have to be their immediate relatives. But when we know that there is something in the family, it has to be done for sure. Let's say that it's not, but still the couple is apprehensive about their offspring. In that case, there is a different kind of carrier screening also that looks at common disorders that are present in the Indian subcontinent, and we can focus just on that if needed.
So this lady, as Prashant sir advised, she had IVF and she conceived in the second embryo transfer. The first time it was not successful, but second time it was. So that ends our first case. I hope most of the questions are something you've heard in your clinic which have been put together in a presentation. The second case again, sir, 28-year-old, different lady, primary infertility, married for 3 years. She comes to this clinic with this HSG film. Most of the patients, if you are not the person who have written HSG, most of the infertility patients come to you with an X-ray film. Most of us, what we do is read the report, file the X-ray film, raise it, and then read it, and sir will tell us how to read it. What is your interpretation, sir?
First and foremost thing is, there is obviously a congenital abnormality, in the sense there is definitely both the cornea are visualized very nicely. There is an inverted triangular defect on the septum which is seen very clearly. It's probably suggestive of a partial septate uterus, and it's not sure whether there is any peritoneal spill because it is all messy around there. So I'm not very sure whether there is a peritoneal spill or not. Basically, when you know that the hysterosalpingogram is a gold standard as far as the cavity is concerned, but as far as the myometrial abnormality is concerned, this is not going to help us. You don't know whether you are dealing with a bicorporeal uterus, or you don't know, you are not sure whether it is a septate uterus. For that, definitely you need to do it for a Mullerian abnormality. 3D is an essential component. Without evaluating, doing a 3D examination, it is definitely difficult to get an answer for this sort of a questions, particularly when you have a kernel. We have all seen before. What is very, very important. If the uterine wall thickness, if there is an internal indentation, obviously it's a septum. If it's an external indentation which is more than 57%, then it is definitely a bicorporeal uterus. The lower one is actually the ASRM classification, which says that its thickness being 1 centimeter and then the angle being obtuse is normal, acute is abnormal. So basically the fundal contour is the one which decides. The fundal contour is the one which you cannot make out on a hysterosalpingogram. That's the reason why you need to do this kernel section of the
uterus, so that you can clearly delineate the fundal contour. And here you have wonderfully demonstrated 3D rendering where you can see a partial separate uterus. You can see the contour being very, very flat, as you can see here, and there is a nice bulge there. And you can see this is the bicorporeal uterus where you have a nice indentation that is more than 50% indentation, internal indentation, which obviously suggests. The most important here, the additional information which I can provide you is to calculate the septal volume. I can tell you what is the volume of the septum. Not only that, I can tell you the vascularity of the septum. The present studies are that when you can demonstrate the vascularity and it can be categorized for objectively given information, if it is a vascular septum, quite often you know that you are dealing with a vascular septum. If it is a avascular septum, you know that you are dealing with a membranous septum. So for example, here in this particular patient who was sent to me, where you can see the thick septum, which I could easily calculate the volume, put the color doppler on, and you can see intense vascular play. You can calculate by taking the vocal into consideration, where I can evaluate the vascularity and tell that it is a muscular septum. Same patient was subjected for surgery, and this is the post-surgical evaluation, which you can see that it was completely resected. So this is the advantage of doing a 3D, and this information can never be obtained by doing the hysterosalpingogram. I think whenever we have a positive hysterosalpingogram, particularly when we are dealing with a abnormal Mullerian abnormality, I think we need to go through this exercise.
So one, look at the HSG film. 2, arrange a 3D scan. So you give a report that there's a partial septum U2A and the septum thickness is 15 millimeters. What options of treatment do you use?
Is she trying to conceive in the sense?
Yeah.
How long has she been?
All the 3 years.
Probably it will be worthwhile excising the septum. I would like to do a diagnostic histolaparoscopy. As I excise the septum, I would even like to look at the patency of the fallopian tubes and if there are any other pathology within the cavity.
So the full workup in one sitting.
Yeah, in one sitting I'll be able to look at all the 3 components, so that I have a good idea about if there is any other associated pathology.
Okay, so she had a septal resection, and after septal resection, until the healing was advised, they tried for pregnancy, and they came back saying they went ahead. This was a phone call by a doctor. They had 2 IUIs in their clinic, and I said, okay madam, do you have a centrifuge, do you have andrology? She said, no. He gave the sample, I loaded, we injected into the cervix. I just took a minute. Obviously I can't say anything, and luckily it was not video phone to see my expressions. So would you prefer loading directly, or is there any process that must be followed before doing an IUI?
Strongly no. I can't use the sample directly to inject to the uterus. We have so many preparation process of the sperm to target the motile sperms. There is a purpose of preparation of the sperms. It's not just like loading and injecting to the sperm. When we are preparing the sperm, we remove all the debris, non-motile sperms, and so many that the volume will be very prompt. Whenever the raw it is more than enough to the cavity, and it is high. What we are once preparation and keep it. Moreover, we are loading with the highly competent media. That media will support the sperms for a long time to survive inside the cavity. So that is the most. We have many advantages. Now we have lot of development to. Definitely, as a reference point of view, we never say direct sample concept.
So this is like not a car moving on a heavily trafficked road. You create a runway for the flight to go and make the egg. What screening or documentation would you like before proceeding with IUI? What screening test do you want, and do you look for any documentation?
Definitely viral screening is must. Whatever the viral HIV and HPV and HCV also we are doing. Apart from the viral screening, we need documentation for witnessing, consent. Of course, without consent, we can't take the sample itself. And after consent, the witnessing is must. When you are preparing a sample, two people should be there. The single person cannot work. And more at the time, we cannot process the two samples also. That's what we are following regularly in our clinics.
So this is a little long-winded. In the clinic, you can just load it directly and inject it. But you are saying you need an equipment, you need a witnessing person, and you need all this. But I think this is all good practice, and have concerns for IUIs. It's something which we must all ensure.
Because of this one, we have new law, ART law.
Yeah, because of a lot of people messing up with what we're doing, more stringent laws are in place now. So that finishes the second case. So this lady came to Genesis, and she conceived with second IUI. So that was her ending. And case number 3, sir, we start with you again. 32-year-old, primary infertility. This is 3D scan image I took from our center. Please interpret the image, and obviously I'm asking you to interpret a static image, and please tell us what else would you assess.
Basically, when we try to evaluate the fibroids, these are the factors which we consider. One is the uterine corpus, myometrial wall, overall echogenicity of the uterine myometrium. Then come to the myometrial lesions. Now, when we take the lesions into consideration, we try to evaluate the size, shape, position, location, in the sense, location in the sense whether it is anterior wall, posterior wall, right atrium, left atrium. More than that, it is the site, that is the submucous, and you have the FICO classification which tells you 0 to 8, which gives you the exact location. If you take the FICO classification and then plot it on a sketch, it gives the very clear idea for the surgeon to plan about it. Not only that, we would like to have additional information which are such as the location of various things like, one of the most problematic situations is to differentiate an adenomyoma and a fibroid. That is one thing which we have to keep in mind. And there are certain set features between adenomyoma and this thing. First and foremost thing, fibroids are well circumscribed, adenomyomas are clearly defined. Second thing is the vascularity, particularly the fibroids will have skirting vessels, whereas the adenomyomas will have intralesional vessels. And usually, as we all know, that the adenomyoma could be a junctional zone disease, so interruption of the endomyometrial junction. These are the factors that we have to consider. Another important factor which I would like to provide is the additional information, particularly the minimal distance of the lesion to the endometrium, minimal distance of the lesion to the serosa. These are two most important things that I would like to tell a new surgeon for him to plan his strategy of approaching these lesions, and then the penetration of lesion. See, doing mapping them and all is very easy, that's not a big deal, but then this information is extremely important for the surgeon to really strategize his approach in managing these patients. I think it's okay, we can see from there.
Yeah.
We can see. Yeah, fine. Go ahead.
So, Dr. Umasinha, this patient comes to you. And a general question as well. Which fibroids a gynecologist should counsel for myometry? Because sometimes they come with the reports and say, go and ask madam. Sometimes if you give a little bit of briefing, it will be very easy for us to take them through the rest of the journey. But otherwise, whatever we say, they go back with the report saying, this is what madam said, did you want us to do? I'm thinking you're being referred for counseling only for an expert advice, but you go back. But general advice to the gynecologist, which should counsel for myometry?
I think we'll start with the statement saying that the minute I see a fibroid on a scan does not require a surgery. So that's the first thing that I need to understand and convey to the patient. And the next question I will ask that, what have you come to me for? With a fibroid, they'll come to me for a few things. One, to just show a scan report, fibroid, somebody diagnosed what to do. Second, they are suffering from infertility, they are not conceiving or they have not yet tried or something of that sort. Or they are coming with symptoms of heavy menstrual bleeding, dysmenorrhea. Or lastly, she is in a perimenopausal age group where fibroids are probably growing in size. And I'm slightly concerned about what those fibroids may be. So these are only 4 or 5 scenarios. There's not much of rocket science here. And then once you understand this, ask the patient, what do you want? If she has been just planning a pregnancy and there is a fundal 5 cm fibroid, I will not do a mammogram. I'll tell her first try. You might just get pregnant. We are at the moment currently managing a patient 26-28 weeks pregnancy. She must be having some 15-16 fibroids all over her uterus. Actually, she had come for myomectomy and I was thinking of doing, but she conceived. And I said, fine, let's follow you. And she says, 26 weeks now. I'm just wondering what will I help my colleagues when they do section. She'll come to us. Anyhow. So there is no hard and fast rule saying this with this myoma patient will conceive or with that they will not conceive. So I think it's fair enough to give them a trial. Unless it's a submucous extension where the patient is also very symptomatic and then she'll be sheep. The other patient where it's a 16-17 centimeter size myoma and she's planning a conception, I feel it might be better to remove them because they're extremely huge myomas and then that can cause a problem for these patients. So these are some situations where we will definitely advise them for. But before I end, I must say, Dr. Praveen's description of myoma is a surgeon's delight. If he gives us all that information, it will be like cakewalk for us.
So definitely remove submucous fibroids?
Yes.
Definitely remove large fibroids?
Yes.
Rest of them treat only if necessary.
Rest intramural fibroids can cause infertility because they cause abnormal activity, uterine activity in the implantation phase. But not all of them. So I think it's fair enough to give them a trial. If they conceive and they progress well, I don't think we should be in a rush to remove all the myomas. That is again one thing you must understand. Just because you have a knife in your hand or a laparoscope in your hand, you should not just jump to any surgery. That clinical judgment has to be acquired, has to be taken time, patience to understand where to operate. Where not to operate is the main question.
So what I learned from you, from both the topics, endometriosis or fibroid, treat the symptoms, treat only when necessary. Don't treat because it's on the paper.
True, and include PCO. How can they come inside of our office saying, I have PCO? I said, don't tell me a problem. I have PCO, I don't know what to do, then tell me a problem.
Yeah.
So they just come with a diagnosis. And actually just a scan, somewhere writing PCO, actually it's not really a PCO, also on the scan.
I know one patient came to me and said that, Doc, do I have PCOS? I never heard this word. I said, what is PCOS? I said, then she got upset. She said, if you don't even know PCOS, please scan on me. I said, really, I don't know. Okay, please explain me. Then she said, polycystic ovarian. Oh my God. I said,
so these are the kind of people who
you can have that information.
One more thing is, many of them, they Google it. And then they see, and then they say, doctor, please come and operate on me. I mean, I've come for research. It might be a very small fiber, say 3 centimeters, 4 centimeters.
And there are people doing it also, so that's why it's important to talk about it.
It's very important to talk about it.
Subserosum 3 centimeter, why do you have to operate?
PCO, please don't operate because she has one. Endometriosis, please don't operate because she has one. Fibroid, please don't operate because she has one. 3 learning points.
Yeah, endometriosis is becoming more of a medical management disease also. We must understand the concept. Surgery is the ultimate, fibrosis and relief, and I understand. But it is, a majority part is medically managed. Majority is a medically managed disease. And I think that is one take-home point today one must everybody take.
And this lady with 16 centimeter fibroid, you've done a myomectomy. How long do you advise her against pregnancy?
6 months.
6 months. And then you definitely, as you noted in your, mentioned in your lecture, you definitely mention if the endometrial cavity was breached or not. So that will give you an idea where the incision was, if there's going to be an accreta or a pancreata, or let's say Dr. Umasin has discharge says it was a fundal incision, and if you see a fundal placenta, one thing you have to remember is be aware about it can be an accreta. Husband attends with this semen analysis report. Myomectomy done, the planning pregnancy, that 6 months period is over. Count is 35 million. All of you must have seen this kind of reports, hundreds of them. Observe, listen very carefully what Mr. Durai has to say. Count is 35 million. Motility is 52%. Morphology is 80%. Have you seen reports like this? Yeah. Please advise on this report and its compliance with WHO.
The report is wrong.
Anybody thought that report is wrong? Say again? Incomplete. Okay. Whatever information you want, I'll give it off the press, puzzles and all. Just focus on this. The report is wrong because
count is right, modality is right, morphology is wrong.
Is that so? I thought 80% is very good.
80% is very good, but no one is.
Even Superman doesn't have 80% morphology.
Even WHO recommend only 4%. Just 4% single digit morphology. But you are giving 80%, is maybe, I don't know, you may deliver the Supermans.
So if you read a report like this, please understand the lab which is giving the report do not know how to read the morphology. Is that right, Dhiren? Okay. So that finishes my third case. Last case. Start with sir again, because the clinical examination, then we go to the
I know, gynec evaluation is nothing but ultrasound.
So
I'm always there.
So this girl was 23 in 2013. She's 33 now, obviously. She came to me with this film and the 2 more films subsequent to this, very similar picture. And people who have the habit of lifting the film and observing, keep thinking what you are thinking of the HSG, and sir will throw more light on that. Please guide us with the report.
Well, see, basically when you do a hysterosalpingogram, even today it is the gold standard as far as the tubal patency is concerned. There are many more investigations that have come up, but then still it holds very, very good. The most important thing is it outlines the cavity. It outlines both the cornu, it outlines the tubes, as well as the peritoneal spill. Of course, it's cutting outside. But anyway, you can see that there is a circular dilatation of the distal part of the tube, which can be seen. And the same patient, when you do an ultrasound examination, this is how you, what do you call it, sausage-shaped incomplete septations with a blind pouch, blind end is the description that is given typically for a hydrosalpinx. It can be a hydro-pio or whatever it is, but then this is the typical appearance which we come across. Now the present thinking is that if you don't want to do a hysterosalpingogram, there is what is called as HICO-C. HICO-C is the one where you use ultrasound contrast, it is microbubbles. You inject into the cavity. You can trace the tubes very nicely, and you can do a 3D overlay, which gives you a beautiful demonstration of it. But then still, it is not as 100% foolproof as a hysterosalpingogram.
So how many of you identified that is the sexual hydrosalpinx before sir said it was hydrosalpinx? No? Not in 10%. So please look at the film, you'll understand more. So this lady comes to you, Professor Prashant. She's referred for IUI. So it's a little tough when the referral comes to us with hydrosalpinx and IUI, because she'll be nicely counseled in the clinic, go there for an IUI. And then we are in soup, because we don't want to upset what you've said to the patient. At the same time, we can't do something which is not right for the patient. What would you do? Is
it a bilateral hydrosalpinx?
Bilateral, sorry.
That's the reason why.
Bilateral. It's a similar picture on the other side as well. And then she comes 2013 onwards to 2022. In 9 years, she has 4 HSG films like this. Going around n number of consultants who can put her on ovulation induction drugs. And she must have had around 36 cycles of ovulation induction. And she comes to me for a natural pregnancy.
How come she did not come to us with an ectopic pregnancy? She should have. It's just 36 hours.
It's high time that she conceives now.
Yeah.
I mean, with 10 years of marriage and 36 ovulation inductions. Now with this bilateral hydrosalpinx, especially with the ampular end blockage, probably I would first like to rule out tuberculosis in our country, because this is quite rampant. And once I have ruled out tuberculosis, probably then I will counsel her for assisted reproductive. It is important because many times, why did this lady have, bilateral tuberculosis? The patient may not have any symptoms, but it is one thing that, especially if you have a distalent block, you have to do tuberculosis. So you do a diagnostic laparoscopy with or without endometriosis. Either you can do a histolaparoscopy and then you will be able to rule out tuberculosis, take a biopsy from the patient if there are any suspicious areas, and then you can ask for a gene expert, because these are all very sensitive for extrapulmonary tuberculosis, especially the tissue diagnosis. Once you are ruled out, then yes, this patient will need assisted reproductive techniques. And also she's 33 years, and as she ages, the AMH is going to drop, and then the success of the fertility is going to depend upon the antral follicular count and the AMH.
Very reasonable. So those people who get 36 ovulation induction should have let go her much sooner to a fertility specialist. So do a hysteroscopy to check the endometrium, take the tissue biopsy for gene expert, see if the endometrium is exposed, and when you do laparoscopy, because you're suspecting tuberculosis, be doubly cautious that there will be a lot of adhesion. Sometimes it can be frozen pelvis, you may damage the uterus. Would you remove the tubes?
Yes, for the simple reason because this can have a flushing effect. If I'm able to remove the tubes, well and good. Otherwise, I would like to delete the tube.
Delete
simple
the
reason,
cornal limb.
Cornal limb, so that when I do an embryo transfer, the flushing effect of these hydrosalpinx is not there.
So now see the knock-on effect.
It has been seen that women who have hydrosalpinx, their implantation rate for the success of ERGOs has come down. So that's the reason why I would like to do this.
Okay. So now see the knock-on effect. This patient is referred for an IUI. IUI barely costs any money. You counsel her. She needs hysteroscopy, gene expert, laparoscopy, salpingectomy, followed by IVF. So where is the difference? It's not money minting. It's not doing what is not necessary. People in general practice having the knowledge that with bilateral hydrosalpinx, IUI should not be recommended. And then sir. So anyway, she agreed from natural, just imagine, not even natural. Doctor refers for IUI, she asked me natural conception, and they speak all about this, and then got an essay done. It revealed azoospermia. So 10 years of going around clinics, not a single semen analysis done. Because for everyone, she was a patient for 4 or 5 months. So in 4 or 5 months, people tried to tag the tablets first, and then she didn't get pregnant, she jumped to a different specialist. Again, she's new. So they get a testicular biopsy elsewhere and attend with the testicular biopsy report. And I request all of you to read the report carefully and try to understand before sir explains it. It shows mature and immature spermatozoa. How do you interpret this report?
First of all, interpreting the report is difficult because really there are sperms are there or not. Most of the HP reports which are done in peripheries, they are controversial. And whether really sperms are found or not, it's difficult for us. And if you think that there are sperms and if you go ahead with ART procedure, on the day of IVF they don't get sperms, then we are in issue. Finally, they say the previous doctor could find some sperms, but why couldn't you sperm? Being a specialist, why couldn't you?
So you need some training.
So sometimes I saw a case where patient says, "Sir, you are not able to find sperms from the testis, but one doctor in my town, he took sperms with the needle and he did IUI." This is happening.
So help us, sir. Why can we not do an IUI from a sample from testis? That's another knowledge point for you. A sample from the testis, testicular aspiration, aspirated sperm, is not suitable for IUI. Please explain, sir.
So they are expecting wonders.
They are expecting wonders. Because the sperm from the testis cannot penetrate the zona pellucida. It has to have acrosome intactness, and then only it can penetrate. TISA sample is suitable only for ICSI. If people are using TISA sample, either he didn't aspirate anything, Or he aspirated nothing and then injected into the uterus.
So coming to this report, basically this is not a proper histopathology report. So in histopathology, what we want is from where the sample has been taken,
Right
from which
testis.
part of which testis, and how many samples they have collected from each testis.
Right testis, 2 samples.
2 samples. So now whether it is a proper case of obstructive azoospermia or hypospermatogenesis or maturation test, that is what important. So in ideal report they should give percentage of cells in that particular tissue, how much percentage of tissue
Mature cells and mature cells.
mature cells.
Can they conceive with their own sperm?
Obviously, if there is a mature spermatozoa, there is chance. But naturally, it's not possible.
Naturally, it's not possible. If that mature spermatozoa report is right, we can do a TISA and do an ICSI with that. So was freezing at the initial TISA sample a good idea? Because we are asking for another TISA now.
This is a controversial question. See, what happens is, what type of TISA was done, that is important. Now, if they are doing a open TISA, where they are doing a surgery and taking out a lot of tissue, then it's worth freezing. Just doing a diagnostic open biopsy is not recommended nowadays. But if they are doing sampling biopsy, generally what we do is with normal TISA, we do with 18 gauge butterfly needle, where we take a lot of tissue. But nowadays we are doing testicular mapping biopsies, where we are using only 24 gauge needle and we take only small aspect of the testis from each part of the testis, and then we send it for histopathology separately. So that will only tell us whether at least one part of the testis is okay for doing some procedure. So why we do this procedure is same patient, if he is having varicocele. Generally, before doing varicocele, we don't want to do varicocele directly in an azoospermic patient without any confirmation. So in those patients, what we do is we do first sampling biopsy. We took very little tissue and we send it for biopsy. If histopathology says hypospermatogenesis or late maturation, that means if they are seeing some spermatids, then it's worth doing varicocele surgery if it is a gross varicocele. So otherwise, if it says only Sertoli cell only, in all those samples where we have aspirated, then there is no point in doing varicocele surgery. So that is the only situation we do diagnostic testicular biopsies. Otherwise, if you are doing open biopsy or regular TISA, it's worth freezing.
So I think I'm blessed to have a panel where they operate only when there is a need for operation. And then the other point I was thinking, when they come with this big sample of a report, ideally if they are done in a center where there is a freezing facility, they'll avoid a repeat procedure. If the person is doing a needle, fine needle and aspiration at 24, but if they're doing 18 gauge or open TISA, then this person is going to lose little more seminiferous tubules at the time of TISA. The last question. Kapila sent to you for counseling. She says her sister had a Down's baby at the age of 28. What advice have you got for her?
When it comes to Down syndrome, the basic thing is that there's the presence of an extra 21st chromosome. So there are several types of conditions where a person may have Down syndrome. So there's addition of one whole chromosome, there could be mosaic trisomy where not all the cells have an extra 21st chromosome, but only a few cells. And the last one is the translocated 21st chromosome. So when it comes to the standard or the mosaic trisomy 21, the recurrence risk is extremely low because it's a sporadic event. It's a chance event that had happened in the patient's sisters. But when it comes to a translocated 21st chromosome, there's a high chance that it could be present in the family. So we need to determine what kind of a genetic component the affected child has. So the first step would be we can go for a karyotyping of the child. And if that's not available, then what we can do is for the patients who are referred to us, for the couple itself, we can do a basic parental karyotype and we'll identify what their chromosome complement is like. On the basis of that, let us say that they do have a translocated 21st chromosome, then a pre-implantation genetic testing would be absolutely necessary to identify if the baby has I mean, if the embryo has Down syndrome or not.
So ideally the affected child, second option, the parental.
Yes, yes.
And they carry 15 to 20% risk. Thank you. Thank you all for your questions. I hope there have been some learning from all the legends in their respective fields, and you all have some take-home points. And I invite all of you to join for lunch. Because we are running late, can I eat into your lunch time and join back at 2:30 please? Or 2:40? Thanks.
40 minutes enough.
Throughout your life. Thank you very much, Narmada.
Thank you so much, ma'am.
ఉండొద్దు అంత పైకి వద్దయ్యో Sedaya.
I call upon Dr. Uday sir and Dr. Lakshmi Narasimhan sir for the felicitation, and I request Dr. Venugopal sir to felicitate. gathered again for the continued session of academic peace. Now I'd like to introduce our next speaker, Dr. Prashant K. Adiga. He is a professor, Department of Reproductive Medicine and Surgery. Sir has done MBBS from Kasturba Medical College, Bangalore, and MD in Obs Gynae from Kasturba Medical College, Bangalore. He has also done Advanced Ultrasound course in Mediscan 2007. Sir has done fellowship in Reproductive Medicine and Surgery from 2018 to 2019 from KMC Manipal. He had been a recipient of Imaging Science Award in the year 2007. He has various publications in the national and international journals. He has contributed to various chapters and various textbooks. Now I request Dr. Prashant Adiga sir to come over the dais and throw some light on management of recurrent pregnancy loss. Please.
Good afternoon. Thank you for those kind words. It's always difficult in the session after lunch for the simple reason that everybody has had a heavy lunch, and secondly is the previous speakers are all heavy speakers. Yes. I come from twin towns. One is Udupi, which is famous for its Krishna temple. Other one is Manipal, which is the university hub. Okay. Now this is our university campus. This is our administrative building, and that is a library there. Okay. I'll try to. My presentation will be under this following heading. Okay. So let us start with what constitutes a recurrent pregnancy loss. Now, when there are loss of 2 or more pregnancies, I would like to concentrate more on recurrent abortions, because that is very common than recurrent late pregnancy losses. Okay, as per the ASRM, when a woman loses 2 or more of her pregnancies, then you call it as a recurrent pregnancy loss. Whereas as per the RCOG, it is 3 or more consecutive losses. Now, this is a etiology. Look at this particular pie chart. Now, in 50% of the case, you won't find any cause. That is very distressing. Okay. This occurs in up to 3% of reproductive age couples. When there are 100 women who are trying to have a child, it is seen in 3% of these patients. And it is unexplained in 50% of the cases, and that has resulted in experimental testing. You keep on testing whether this is a cause, whether that is a cause. And also treatment. When you don't know what is the exact cause, you try to experiment. Okay? That sometimes the doctor puts, sometimes nowadays everybody has, every patient Google searches, and they try to offer that this treatment might be better for me. I'm sure many of you must have faced it, right? So patient is frustrated, not because she doesn't conceive, but she's conceiving, but she's unable to have a child. And she asks us, doctor, why is my pregnancy not going ahead? You don't have an answer. So doctor is also clueless, right? I'm sure we have faced this very commonly. So I try to throw upon some of the causes and in what way can we help. Okay. Now these are the causes, and many causes are controversial, or it is debatable, I would say. Many causes are debatable. Right. Now, if you look at this triangle, now 30% of the patient, 30% of the cases before implantation, that is if you do day 21, HCG, it might be positive. Okay, but the patient will have menstruation. These are called as failure of implantation. Fertilization is occurring, but it is not implanting. In another 30% of the cases, that's so-called biochemical pregnancies, where the patient misses her periods. She does a urine pregnancy test. It shows 2 lines, but by the end of, say, 40 days, she has her periods. These are all preclinical losses. Then you have the miscarriages. Of course, 10 to 15% of them will have miscarriages, and live birth is only 25%. So this is one aspect. This part can explain why many women are infertile. It's not that fertilization does not occur, but there is no implantation. Coming on to the epidemiological factors, you have maternal age and previous reproductive history. Now, I think our elders have said they get married fast, have children fast. That is absolutely right. In the hindsight, if you see that is right. If you look at this, see at the age of 30 to 35, see the rate of pregnancy loss is 25%. And now everybody wants to do it. I mean, you need to have a balance between your career and your family life. Of course, you have other options, not that you don't have options. You have social freezing, but is it really required is a question. So, maternally, as the age increases, we all know that there is increase in the chromosomally abnormal conceptus, so because of which there will be recurrent abortions. Then previous history. Now, the chances after one miscarriage is about 14 to 20%, and as the miscarriages increases, that means the next time she is going to have another miscarriage is about 25%, and after 3 miscarriages as high as 45%. So many times women, they dread becoming pregnant. In fact, I have seen a couple of patients coming and saying, "Doctor, my urine pregnancy test is positive, what next? Am I going to have the same thing?" I'm sure you must also, I mean, this is quite common. And one thing is, it typically occurs at the same gestational or similar gestational age in consecutive pregnancies. If the patient has had, say, missed abortion at 7 weeks, next time also around 7 weeks she will have it. Okay. Then, coming on to the antiphospholipid antibody syndrome. This is one particular condition where if you find the diagnosis, you are happy because you can treat them. Many times, I told you 50% of the times you don't have a diagnosis. You don't know what to treat for. So, you have the 3, the lupus anticoagulant, anti-cardiolipin antibodies, and anti-beta-2 glycoprotein antibodies. A word of caution, you need to have the third one also, that is anti-beta-2 glycoprotein antibodies. Whenever you are asking for Aplapanel, ask for that also. So, you need to have one lab criteria and one clinical criteria. So, the lab criteria being, either you should have the anti-cardiolipin antibodies, IgG, IgM, or the lupus anticoagulant and the anti-beta-2 glycoprotein, IgM or IgG, more than the 95th centile by ELISA. Or if you have any one of the 3 clinical criteria, then it's that is required for the diagnosis of APLA. That is more than 3 consecutive losses beyond 10 weeks. I mean less than 10 weeks. Even if you have a loss more than one or more than one at more than 10 weeks, or if you have severe preeclampsia, early onset preeclampsia, that is before 34 weeks. Okay, preterm delivery before 34 weeks, you have to terminate because of this severity or because of placental insufficiency, then the criteria fits into antiphospholipid antibody syndrome. Okay, we all know that at the end of the day, there is thrombosis. Okay, there is, because of this thrombosis, there is abortion. Early thrombosis will result in abortions, late thrombosis will result in IUGR. Okay. Then coming on to genetic causes, you have valence translocation. I think Dr. Anuradha gave a detailed lecture. Okay. You have the reciprocal and Robertsonian inversions. So these are also responsible for recurrent pregnancy losses. Then anatomical causes. Okay, this is again septate. You have congenital uterine anomalies like septate uterus, bicornuate uterus, then acquired cervical insufficiency. Many times patient has had recurrent dilatation and evacuation, and they can have mid-trimestral losses. Fibroids and Asherman's, especially D&Ds. Nowadays, with the advent of misoprostol, we should minimize the dilatation and evacuation so that this particular complication may be avoided. Then endocrine. I have underlined thyroid and diabetes for the simple reason that thyroid is very common in our society, and I think now it is a practice to screen for hypothyroidism in the antenatal period. And diabetes, we all know that India is the diabetic capital of the world, so it is mandatory that you rule out these conditions. Then of course hyperprolactinemia and polycystic ovarian syndrome. A few words about alloimmune causes. Alloimmune causes, this is something very interesting which I thought I should share with you. Now many times you have unexplained RPL, that is because of the natural killer cell dysfunction. Then there is imbalance between the T helper and helper 1 and T helper 2 immune system, and low concentration of T regulatory cells. Something about the immunology of pregnancy. Between the feto-maternal junction, there is a lot of these cells which play. It is basically immunomodulation. Okay? And one interesting thing is, if the couple have HLA sharing, that means there are no blocking antibodies. We all know that there are some blocking antibodies which block these antigens from the male partner, and the recognition doesn't occur. So what happens when HLA is shared is common. So all these protective antibodies are not there, especially the blocking antibodies, and then idiotypic antibodies and anti-paternal cytotoxic antibodies are not there. Because of which these the male factors, male antigens are exposed, and it is rejected. Okay. So same thing. So there might be dendritic cell function, increased uterine natural killer cells, and then HLA sharing. Then you have the autoimmune causes, that is anti-nuclear antibodies and anti-TPO antibodies. Then of course infections, you have bacterial agents. I have put question mark for the simple reason this is debatable. There are some papers which say that this can cause recurrent pregnancy loss, while some say it doesn't. And chronic endometriosis. Okay, especially if you do a hysteroscopy, especially when we are doing it for for IVF cycles, many times we find that there is chronic endometriosis. You take a biopsy, you see a lot of these plasma cells. Okay, so then, and of course, today I learned a new point from Dr. Anuradha, because all this literature talks about factor V laden prothrombin gene and proteinase deficiency, but she was telling about some of these genes which are unique to Indians. Okay, probably I think with that background we must start investigating, because if you see the guidelines, they say unless there is a family history of thrombosis history and recurrent pregnancy loss, you need to look for. But then I think probably in future we will have to look into evaluating these causes also. Now coming on to evaluation, how do we evaluate? Yeah, how much do we evaluate? That's the question. You have so many things. At the end of the day, the patient spends and then you don't find anything, or you find, if you find something, yes, it is always nice, you can treat that. But if you don't find anything, yeah, then she will say, doctor, I have spent so much money, but still I couldn't get an answer. Okay. So commonly performed, which is going to be helpful, is APLA panel. I told you, insist for this anti-beta-2 glycoprotein 1, because many times we get a report saying that they have done only ACLA and lupus anticoagulant. Then imaging for anatomical factors, I think Dr. Praveen spoke very nicely. 3D ultrasound is a gold standard, and then you will be able to look at the contour, you will be able to look at the septum, yeah, and of course MRI in some cases, hysteroscopy in case the patient has had repeated DNCs, you find that there is thin endometrium even on day 21 of the cycle, and of course to diagnose chronic endometritis. Thyroid function test, T3, T4, TSH, and anti-TPO antibodies have to be asked for. Fasting prolactin if the TSH is very high, and of course oral glucose tolerance test, especially in non-pregnant state, that is fasting. Then the patient takes 75 grams of glucose, and at the end of 2 hours, 2-hour GTT has to be done in the non-pregnant state. Then of course parenteral karyotype, that is, this will be able to pick up balance reciprocal or Robertson translocation. In the non-pregnant state, ask for parental karyotyping. I think that's the message which Dr. Anuradha stressed in the morning. And if you have products of conception, ask for a chromosomal microarray. And especially abnormality appears to be higher when the patient is young and has 2 abortions, or if the patient has 3 or more miscarriages, and if there is a strong family history of miscarriage in a sibling or the parents of either of the partner. Many times patient will say, my mother-in-law had many abortions, I believe. So that is the time when you need to evaluate. Then of course chromosomal microarray does not require cell culture, even if there are dead cells that can be used, and there is a technique where they can separate the maternal cell contamination. Disadvantage is it is expensive and cannot detect balanced translocations. Then less useful, evaluation of ovarian reserve. Now when you do an ultrasound, please make it a practice to look at the antral follicular count. Many times if you find only 2 or 3, because if you look at the recent papers from South India, many women have a low AMH after 30 years. So it would be a good practice. If you find that the AFCs are less, antral follicular count is less, you can always ask for a AMH. And then of course other autoimmune workup like anti-nuclear antibodies. Again, 15% of normal population can have anti-nuclear antibodies. Okay. So what we do in our hospital is we ask for an APLA panel, then thyroid function test, anti-TPO antibodies and anti-nuclear antibodies, and of course 3D ultrasound. And AMH, if we find that the TVS is showing low antral follicular count, and everything has been done, but still patient is not conceiving, then you can ask for a parental karyotype. Now the treatment. Yes. So if you have antiphospholipid antibody syndrome, and if there is a family, if there is a history of arterial or venous thrombosis, then the patient has to be started on therapeutic dose of low molecular weight heparin along with aspirin. Okay. And if the patient has more than 1 fetal loss, that is only obstetric antiphospholipid antibody syndrome, then you have to give prophylactic dose of low molecular weight heparin and aspirin. There is no difference between whether you start on low molecular weight heparin or unfractionated heparin. Both are equally effective, but the only advantage of low molecular weight heparin is you need not monitor for heparin-induced thrombocytopenia. Okay. Then anatomical causes. If you have a uterine septum associated with recurrent pregnancy loss, you do a hysteroscopic septal resection, intrauterine adhesiolysis, and of course submucosal myoma, you can always remove it, and cervical insufficiency, put in an encerclage. Then if there is thyroid dysfunction, treat it, make the patient euthyroid. Many times there is multi-glandular involvement. Patients who are diabetics, they tend to have hypothyroidism. So screen for both of them. If they have that, adequately treated, you can always take the help of endocrine. That is always better because optimal control is helpful. If the patient has antithyroid antibodies, then you have to give them supplements of thyroxine so that it will help, it may reduce the risk of miscarriage and preterm. And these patients have to be monitored because the patient can develop hypothyroidism, which can have an impact on the fetus also. So that is important. And if there is abnormal karyotype, there is, I think this is where, we gynecologists are not very good with this problem. So take the help of our geneticist. So if the couple have a karyotypic abnormality, then they can conceive. If the pregnancy goes beyond that, then you can always ask for a genetic testing like amniocentesis or a chorionic pill sampling to determine the fetal karyotype. And then in vitro fertilization with pre-implantation genetic diagnosis. So what they do is, as a day 5 embryo, that is blastocyst, they take a cell, and that cell will look for whether there is any evidence of aneuploidy. And if it is euploid, it will be transferred. If it is aneuploid, it will be discarded. Last but not least is gamete donation. Surrogacy are the methods of preventing conception of an affected embryo. Now surrogacy is almost out, so probably gamete donation. But again, you need to counsel the patient many times. The couple may not be willing. Then about unexplained recurrent pregnancies. This is the major, I think, majority of our patients have unexplained. So there are many things which have been told. I told you, when you don't know the cause, you try everything and anything. Okay. There is something called as lymphocytic immunotherapy. Okay. What they do is, they take the husband's blood and then they isolate the lymphocytes. Before that, they try to estimate the cytokine markers, those which are pro-inflammatory, those which are anti-inflammatory. That is basically, they are trying to assess the function of T helper 1 and T helper 2 cells. And then they inject the lymphocytes into the wife subcutaneously 0.3 ml. Okay, and then they assess the response whether the markers have reduced. So 2 to 3 times they might have to get injections. Once the cytokine levels have come down, then they can plan for pregnancy. Then you have intravenous immunoglobulin, prednisolone, heparin, progesterone, intralipid. Intralipid is nothing but again emulsion of lipids, okay, which is given over a period of 2 to 3 hours. That is basically immunomodulator. Then of course granulocyte colony stimulating factor, and then endometrial scratching. Now if you look at the guidelines, none of them are useful. Everything is useless. You are trying to experiment. You are shooting in the dark, hoping that one bullet will hit the target. It's as simple as that. What we do in our hospital, this has been very effective. Periconceptionally, we start them on folic acid, and as soon as a patient conceives, we ask her to come at 35 days of pregnancy, get her platelet test done, and start them on low molecular weight heparin and dydrogesterone. You can even give a micronized vaginal progesterone, also no problem. From 35 days till the end of first trimester. It has worked wonderfully well. And of course, if you ask me for evidence, I do not have evidence. Many times it is experience-based than evidence-based. I would say this is experience-based. Okay. Then coming on to some of the guidelines. If you look at the guidelines, you will be confused. Okay. Now, for women with RPL, this is HTA guidelines. They say that you can screen for antiphospholipid antibody syndrome after 2 losses. Also, you should screen for anti-beta-2 glycoprotein, which is a part of APLA syndrome. For women with recurrent pregnancy loss, we suggest not to screen for hereditary thrombophilia unless in the context of research or in women with additional risk factors for the thrombophilia. If there is a family history of thrombosis, yes, you have to ask for. Then thyroid screening, that is TSH and anti-TPO antibodies recommended in women with RPL. Abnormal TSH and anti-TPO antibodies should be followed by T4 testing in women with RPL. There is a very strong evidence. And ovarian reserve testing is not routinely recommended in women with RPL. But I told you, in our settings, we have found quite, at 29-30, because even if you look at the incidence of premature ovarian insufficiency, it is increasing. So these patients will have defective oocytes. So it is always better that we test it. Then all women with RPL should have an assessment of the uterine anatomy, and the preferred technique is a 3D ultrasound, which has a high sensitivity and specificity and can distinguish between septate and bicorporeal uterus with normal cervix. Then HLA determination in women with RPL is not recommended in clinical practice, and further research is needed, including prospective observation studies and randomized controlled trials before screening women for chronic endometriosis can be recommended. Whether hysteroscopic septal resection has beneficial effects, including improving the live birth rates and decreasing miscarriage rates without doing harm, should be evaluated in the context of surgical trials in women with RPL and septate uterus. And women with a history of second trimester pregnancy loss and suspected cervical weakness should be offered serial cervical sonographic surveillance, and these patients, in fact the guideline says that encerclad may or may not be useful. That's why I said there is a lot of contrast between what I talk and what the guidelines say. Thank you.
Any questions?
Any questions, ma'am?
Sir, I have a question. In the recurrent pregnancy, case of recurrent pregnancy loss, if it is a clinical ASA, there is no biochemical marker positive, but there are more than 3 miscarriages, less than 9 weeks gestation. Yeah. In that case, would you recommend giving low molecular weight heparin?
Yeah. So here again it comes under unexplained. So okay, in that case is what we do many times. Such as case scenario has come. I told you we start on well before we start on periconceptual folic acid, and as soon as the patient conceives, we start on heparin, and till 12 weeks. And what we do during the time of NT scan, we look at the uterine artery Doppler. If it is showing high resistance, or along with that, we even do a dual marker. Dual marker, it is going to tell us about whether the patient is at high risk of having aneuploidy, whether the patient is at a high risk of having early and late preeclampsia. Okay, if it is early preeclampsia, we discontinue heparin, but we add aspirin 150 milligrams. Then continue. And these patients need serial monitoring.
Yeah.
Wife and husband has same blood group. Does it cause any?
No. This is a commonly asked question.
Yeah.
No, this is a
not
commonly
consanguineous
asked.
marriage,
No.
but recurrent pregnancy losses.
No. That's what. If there is a consanguineous marriage, I think so. They tend to have a common HLA. HLA sharing will be common. HLA common. If the HLA is similar, it is good for renal transplant, but it is not good for pregnancy. So recurrent pregnancy losses can occur if they have a common HLA.
Not the same blood group.
No.
Thanks.
Thank you very much, sir, for giving us concepts of recurrent pregnancy loss in a nutshell. Now I request Dr. Swapna Kumari ma'am to present a token of memento to sir.
It was nice to see someone from behind the laptop. All of us are matching the level of the laptop.
I will take you through a brief introduction about our next speaker, Dr. G. Rahul Reddy sir. Sir has done MBBS and MS with General Surgery and DNB. He has fellowship in andrology and men's health. He is a consultant microsurgical andrologist and director of Androcare Andrology Institute. He is a faculty in andrology at national and international conferences. He is a recipient of various awards: the Best Junior Surgeon Award 2010-2011 Apollo Group, Vaidya Ratna Award 2015-2017, Best Andrologist Award Achievers Healthcare Awards 2015, Pratibha Puraskar 2016, Rising Star Andrologist in the Twin States of Telangana 2017 Times of India, Hall of Fame Award in Andrology 2019 Economic Times. So as we can see the list of qualifications of sir. So now I would request Dr. Rahul Reddy sir to update us on the current concepts of male infertility. Please.
Thank you, madam, for your kind introduction. In continuation to the previous talk, I think one thing we all have to give importance is whenever you see a couple with recurrent early pregnancy loss, I am not saying pregnancy loss, if the pregnancy loss is in first few weeks, then a male factor role evaluation is also very important. Most of the times DNA fragmentation is on the highest side, that itself is the cause for recurrent pregnancy loss. Good evening, doctors. The main idea of this talk is not to give a lecture, but this is to educate most of the gynecologists in treating male infertility. Because most of the cases of male infertility are seen by gynecologists. 95% of the cases, you don't have to refer these cases to anybody. Most of these cases can be treated in your OPD. Only remaining that 4 to 5% of cases you have to refer to an andrologist or urologist. Because male infertility is very simple compared to female infertility. It is just like mathematics. There are only very few things what you have to take care of. So, why a gynecologist should know about male infertility? These 3 slides, 3 case scenarios will tell you, and it is very important for a gynecologist, practicing gynecologist, who is the first person to a semen analysis report. For her, she has to identify which case needs treatment, which case is not. So, first case scenario, I was telling about this case. 29 years female, she had recurrent early pregnancy loss 3 times, 4 times IUI was done, and then once they did IVF. 2 out of these 3 early pregnancy loss, 1 was natural, 1 was with IUI, and 1 was after exit procedure. So after the failure of IVF, this patient has been referred to us. This patient had so many semen analysis reports which are done in periphery. As madam showed one semen analysis sample in the morning. Most of the semen analysis samples, they were showing morphology as 80%, 70%, and every semen sample was showing pyospermia. So 2 things were neglected. 1, morphology was not done properly. His actual morphology was 1%, and he had pyospermia in all semen analysis reports. So his semen culture was positive. So, and when we did his DNA fragmentation was 56. The only reason for recurrent pregnancy loss in this couple is pyospermia, which is leading to high DNA fragmentation. With simple antibiotic course, the culture has become negative, and DNA fragmentation has come down, and then later couple had natural pregnancy. Second case scenario, 29 years old male patient, semen analysis showed azoospermia. Again, similar case scenario was what madam showed in the panel discussion. Testicular biopsy done elsewhere showed maturation test, and no hormonal evaluation was done before doing a testicular biopsy. Later, this couple came to a fertility center, and where I used to work there, And when we did hormonal evaluation was normal. So we had a doubt and we repeated semen analysis, because his semen analysis was done only once before doing testicular biopsy. And they have been counseled for donor IUI, donor insemination, ICSI with donor, because their HPV report showed maturation rate. To our surprise, his semen analysis was normal. So this is done in a fertility center. Only problem was there was the very high viscosity in the semen and there was delayed liquefaction. So that means the first lab technician who saw this semen analysis report, probably because of very high viscosity, he just took some sample from the periphery, checked for sperms. There were no sperm because he couldn't wait. He wouldn't wait till the sample is liquefied. So he has given a azoospermia report. And second thing which went wrong in this report is histopathology. So since semen analysis is normal, in normal ejaculate, that means the histopathology report is abnormal. And third case scenario, 34 years old male, semen analysis showed oligoasthenoteratoospermia. He had 2 million concentration and 17% motility and 1% morphology. They came for evaluation. FSH was normal, testosterone was normal, his testis was normal. Only thing what we have seen is his epididymis was bulky. So we ordered for a scrotal Doppler. Scrotal Doppler showed typical filarial dance size, which is typical of filarial infection. So we had put him on DEC for 3 weeks. Later he had his improvement in his count. Later we did IUI. So sometimes simple infections, you can wait, you can treat them at your place. You don't have to send all these cases to an andrologist or urologist. I will try to simplify male infertility for you, so that you don't have to, whenever you see a case scenario, at least you can remind of this case scenario. So, most common question most of the gynecologists have is, sir, what is the treatment for oligoasthenoteratoospermia? So, oligoasthenoteratoospermia is not a disease. It's like a phenomenon. It's like fever. Only thing is we have to find out what is the root cause for this oligoasthenoteratoospermia. So only few things, few hormonal investigations, one scrotal Doppler, if necessary one semen culture test. This will give us enough information so that we can come to a proper diagnosis. So nowadays male infertility is rising. If you see the couples which are going for fertility treatment, male factor infertility is in more than 50% of patients. Why it is on rise? That means what are the causes of male infertility? This slide will tell us how to differentiate these male infertility causes. One is pretesticular cause, which is hormonal dysfunction. Second one is testicular cause, and third one is post-testicular cause. So how to differentiate and what are the common factors which are causing male infertility? So out of all these causes, first 3 are very important. One is plastic, usage of plastic. Second one is increased testicular temperature, and third one is infections. So generally what I do is I categorize these male infertility patients into two categories based on their socio-economic lifestyle. So poor patients, they have more of plastic related toxic effects and infections. And people who are into educated group, who are into sitting lifestyle, they have increased total temperature. These are the 3 common causes for male infertility. So you must have never heard of plastic causing infertility, because once we hear about that, it's a major threat for infertility. So nowadays it says it is a silent killer of male fertility. So male reproduction, one of the primary targets of bisphenol. Bisphenol is a component which is seen in plastic. If you see, you must have thought you never used regular plastic, but whatever we use in our daily lifestyle, it includes plastic. So if you see the baby bottles, canned food packages, soda and juice cans, plastic food containers, plastic water bottles, plastic toys for children, plastic utensils, plastic food plates, plastic cups for drinking tea and water. Probably now we are not using plastic cups for tea and coffee, but there was at least 5-6 years time where every hotel, every restaurant used to give coffees. They used to serve coffee and tea in plastic cups. And simple, not that one. Even the simple water bottle what we use. We always buy water bottles from a refrigerator and we use it. But what we are not noticing is where it was manufactured, how it was transported, and how many days it was in sunlight. Once this plastic bottle, if it gets exposed to sunlight, whether it may be cool drink bottle or it is a water bottle, once it is exposed to heat, then bisphenol is released into the container. So that means if a water bottle is manufactured in a plant, it is during the transportation, if it is exposed to sunlight, or if it is kept outside in a godown for so many days, obviously you will see bisphenol in this container. So now, how it damages is it obstructs steroidogenesis and spermatogenesis. And what is more dangerous is it stays in our genes for generations. So that is the danger with the plastic. And this is common. This is commonly seen in most of the IT people or people living in cities, because most of the times, if you see, if you go to a curry point, most of the times they give all these things packed in a very thin plastic. Though now plastic is banned, plastic covers are banned now. All those curries, they used to pack it in a small plastic cover. Even this is enough to expose our body for this thing. Second cause is heat. Anything which causes, which increases scrotal temperature can cause decrease in spermatogenesis. Simple calculation is normally the testicular temperature should be 2 degrees lesser than body temperature. But for people who are continuously sitting for more than 7 to 8 hours in a day, or obese people, or people wearing tight undergarments, their temperature is almost 2 to 4 degrees more than their body temperature. Every single degree rise in temperature will affect 70 to 20% of spermatogenesis. So that means you can imagine if there is 3 to 4 degrees rise in temperature, total temperature, that means that is affecting 70 to 80% of spermatogenesis. So it's not only laptop. Previously we used to think just putting a laptop on the lap will increase the temperature. Even sitting can cause, sitting continuously can cause increase in total temperature. Now there is a saying that sitting is smoking. If somebody is sitting continuously for 7 to 8 years, 8 hours, that means even most of the doctors, they do that. Continuous practice, they sit continuously for 7 to 8 hours. It's almost equivalent to having a pack of cigarettes a day. So obesity, these two causes, obesity and smoking. We all have doubts how this obesity and obesity, smoking, alcohol causes male infertility. Obesity increases total temperature, it decreases sperm count and sperm motility, it increases estrogen level. So there is an abnormal TE ratio, testosterone to estrogen ratio in obese people. And coming to alcohol, so most of the people, they think alcohol may not cause male infertility, but they only think that taking alcohol once in a week or twice in a week may not cause infertility. The main problem with alcohol is whatever antioxidants we give, this stops absorption of antioxidants. That means if a person takes alcohol and then takes antioxidants, then for next 48 hours the absorption of antioxidants is almost nil. So that means we are unnecessarily giving antioxidants for him. Smoking significantly it decreases testosterone levels in the body, and smoking increases ROS levels in the testes. So apart from this, okay, now coming to the main topic, how do you evaluate a male partner when you see a male patient who has come to you with oligoasthenotartrospermia? What are the things you have to do? One is proper history and physical examination. Second one is proper semen analysis. Proper semen analysis in the sense you need a proper technician who can do proper semen analysis along with proper morphology. It's very simple. Even if you have a lab technician, nowadays there are so many training centers who can train lab technicians in semen analysis. You can send your technician for a week's course of training in semen analysis, proper semen analysis. Coming to hormonal evaluation, now I think most of the even small places they have hormonal facilities. Even if they are not done locally, they will send hormone samples to nearby cities and they will give you hormone reports. So you don't have to worry about hormone reports. And we need only few hormones: FSH, LH, prolactin, and testosterone, and thyroid. These can be done in any small town nowadays. So coming to semen analysis, I think there are changes in semen analysis pattern every few years. Now current 6th edition guideline says semen analysis count should be minimum of 16 millions and total sperm number per ejaculate should be 39 millions, and motility again it should be more than 30%. So don't confuse with previous generation semen analysis reports. You don't need 60% or 70% motility. Now what you need is 16 millions is the target. If it is more than 16 millions, then it's easy for us to treat. If it is less than 16 millions, that is where you have to refer these patients or you have to start treatment. Then morphology, according to strict morphology, WHO says 4% morphology is enough. 4 to 9% is ideal. So why I am saying this again is I get most of the referrals for morphology. Most of the times people get confused with morphology report. Sometimes even if a fertility center has given morphology as 5% or 6%, and if a diagnostic center gives as 70%, I still get referrals saying that, sir, his morphology is 5% or 6%. So there, if morphology is 4% or 5%, that means it's normal. We don't have to aggressively treat them. So, and first point in doing semen analysis is proper counseling of the patient for semen analysis report. See, most of the males, they don't know how to masturbate. Most of the times, they just ejaculate few drops and they think that is enough for semen analysis. And sometimes there is spillage. They won't even let you know that there is spillage. The initial jet of the ejaculate has 70% of sperm. So now, normally when a male, when he is giving semen analysis sample, if he misses this first jet of ejaculate, then what you are seeing is only remaining 30% of sperms. But there should be somebody in your clinic or some at least lab technician. They have to explain all these things for these males who are going for semen analysis report. And if they can't collect the sample, some of the males, they have collection issues. They can't collect semen sample in diagnostic center or clinic. So you can encourage them to collect semen sample from house, but you have to tell them how this has to be transported. Because this should not be exposed to heat and they should not be exposed to cold. So they have to, ideally they have to keep it close to their body, and this has to reach laboratory in 45 minutes. And they have to they have to note down the timing of ejaculate on the bottle so that it helps the lab technician to start the procedure evaluation immediately. So coming to semen analysis, normally we see only few semen parameters in the semen analysis sample. One is concentration, second one is count, motility, and third one is morphology. Apart from these three things, there are a couple of things which are in semen analysis report which will tell us what is the problem with this particular patient without even evaluation, without even hormonal evaluation. So now, one is liquefaction. If there is, if in your the semen analysis sample shows there is delayed liquefaction or high viscosity, that means this patient is having some sort of infection in the prostate or seminal vesicle. It can be old infection or it can be present infection. If it is present infection, probably you can find out in culture. If it is old infection, that means if it is an old infection, your culture is showing, culture comes as negative. That means this patient had old history of antioxidants. Generally what they do is they suppress the ROS. We need some amount of ROS for physiology. Generally where we do is, if it is repeated early pregnancy loss, we do a DNA fragmentation test. And advanced male paternal age, if male is more than 45 years, better to, before planning their fertility treatment, do DNA fragmentation test. And in varicocele patients, varicocele, not in all varicocele patients. Sometimes you see gross varicocele, grade 3 varicocele in sputum Doppler report, but you find all semen parameters are normal. Count is normal, motility is normal, and morphology is normal. But the couple is having documented infertility, where female factor is also normal. There, when you are in doubt whether to refer this patient to a varicocele surgery or not, this DNA fragmentation test will help us. If DNA fragmentation is on the higher side, then we can operate this patient. If DNA fragmentation is normal, then we don't have to operate this patient. So now, knowing that DNA fragmentation test will help us, so whether we have to do it as a routine investigation or not, this is a big dilemma, because again this is an expensive test. This will cost a patient around 7,000 to 8,000 rupees, and most of the laboratories, without doing viral screening, they don't do DNA fragmentation. So doing viral screening will add another 1,500 rupees for the patient. So now what has to be done? Routinely, whether to do DNA fragmentation test for every patient who are undergoing fertility treatment? Generally, no, because there are different methods and there are variations in different kinds of reports. So now what has to be done is, so if it is a genetic cause, anyway we can't treat it. So now what, as a clinician, what we look at is whether it is treatable. There are few treatable causes of DNA fragmentation. So if it is a treatable cause of DNA fragmentation, then it is worth, instead of doing a DNA fragmentation test, if semen parameters are abnormal. So generally what I do is, I look for infections, varicocele, any increase in scrotal temperature, recent history of fever, and smoking and tobacco. Even recent history of fever can increase DNA fragmentation. So even COVID infections, after COVID infection who had asymptomatic COVID infections, we have seen rise in DNA parameters, DFI parameter. So if there is fever, anyway we have to ask them not to do semen analysis for a couple of weeks. Even DNA fragmentation test should not be done for few weeks, at least for 6 to 8 weeks after COVID infection. So now, instead of doing a DNA fragmentation test, if you are suspecting infection, just do a culture. Culture test is only 800 to 1,000 rupees. If culture is negative, then one scrotal Doppler. If scrotal Doppler says there is no varicocele, then that means these two are treatable causes of high DNA fragmentation. If these two are negative, then you can do a DNA fragmentation test. And cultures. So 80% of males in our OPD, the primary cause for infertility is infection. So how these infections have come, why these infections come, it's a big, again it's a big topic. Most of these infections, they come from bowel. Because if you see the anatomy, the seminal vesicle is close to the rectum. So now it is between rectum and urinary bladder. So what happens is, if a patient, most of the patients, if they have either hemorrhoids, even simple constipation can cause seminal infections. So most common bacteria what we see in semen is Enterococcus fecalis, and normally Enterococcus fecalis is seen in only large bowel. So the main reason is there is some connection between the large bowel and seminal vesicle, maybe some small fistulas which are causing this. And the major problem with these cultures is antibiotics. So I will tell you what antibiotics has to be given and on how many days you have to take antibiotics. I will tell you. So now cultures, there are two types of cultures. One is a regular manual culture and second one is automated culture. Now I think most of the laboratories, they are doing Vitek 2 automated cultures, including I think Vizia, Lucid. Most of these laboratories, they are doing automated culture. So whenever you are asking for a culture, ask for an automated culture, because manual culture, the yield is very less. Automated cultures, the yield is very good. That means the identification, the positive rate is very high in automated cultures. So now, when you have to ask for semen culture, these are the indications. Persistent pyospermia with impaired motility, and second one is persistent delayed liquefaction, and low volume ejaculate with normal testosterone levels. That means we said there are only two causes for low volume ejaculate. One is low testosterone and second one is infection. If testosterone is normal and if you are having low volume ejaculate, then you can ask for culture. And low fertilization rates or bad quality embryos in IVF, but I suggest all patients undergoing IVF procedure has to undergo one semen culture before doing IVF procedure, so that at least we can avoid patients with high DNA fragmentation. And in couples with repeated abortions and recurrent early pregnancy loss, along with female factor evaluation, ask for a culture semen culture report. You will be surprised to see most of these couples will have positive cultures in semen. So now coming to hormonal evaluation. So what hormone test has to be done? It's very simple. FSH, LH and testosterone. These are the first three tests generally we have to ask along with thyroid test. If testosterone is very low, then you have to ask for prolactin test. Yesterday we had a patient. We asked for these three tests. FSH was 0.69 and LH was 0.09 and testosterone was 0.59. So immediately after, if you see this picture, normally what we see is it's a case of hypogonadotropic hypogonadism, because all things are normal. FSH, LH and testosterone, all three are normal. So immediately we ask for a prolactin test. His prolactin value was more than 2000. So now even I don't know what has to be. I asked him to get an MRI today. So obviously this prolactin test will differentiate between hypogonadotropic hypogonadism and hyperprolactinemia. So if patient is affordable, better get all these hormones in one step. But in obese patients, along with these four hormones, FSH, LH, prolactin and testosterone and thyroid, if obese patient or patient is alcoholic, then do estrogen along with this, because in those patients, testosterone to estrogen ratio is very important. Some people, in spite of having normal testosterone, if their estrogen levels are on the higher side, that itself can impact their spermatogenesis. So that is why all obese patients, we have to look for TE ratio. And even when you put them on clomiphene citrate, sometimes clomiphene citrate after 1 month of usage of clomiphene citrate, when you check their testosterone levels, they may be normal, but estrogen will be abnormally on the higher side. They will have high TE ratios. That is the reason most of the people with clomiphene citrate, when you put them on clomiphene citrate for months, they come with sexual dysfunction to us. Because when there is high TE ratio will, their libido will go down and they will end up with sexual dysfunction. So whenever you are putting on clomiphene citrate, when you ask for testosterone again, along with testosterone, you repeat estrogen. So now this slide is important for azoospermic patients. So now you are doing hormones, you are doing FSH, LH, testosterone, and in azoospermic patients or in low oligospermic patients. So how you have to differentiate is, if FSH is high, LH is high, testosterone is low, then it's a clear-cut case of testicular failure. If FSH, LH and testosterone are normal, then this may be a case of obstructive azoospermia. But even some patients with Sertoli cell only syndrome also, you will see same phenomenon. All hormones will be normal, but when you do biopsy, you find Sertoli cell only syndrome. That is in few percentage of patients. And if all these three hormones are on the lower side, low FSH, low LH, and low testosterone, then it is hypogonadotropic hypogonadism if prolactin is normal. So in this last set, so why this is important is, in first set, in the first scenario, it is a case of normal obstructive azoospermia. So you can send them for biopsy, testicular biopsy. Second scenario, here diagnostic testicular biopsy can be done. But in second scenario, where there is high FSH, high LH, and clinical examination shows small volume testis, there is no need for diagnostic testicular biopsy. So there you have to refer these patients to an ART center where there is freezing facility. And third set, where there is low FSH, low LH, and low testosterone, there is no need for biopsy. They need gonadotropin treatment, hormonal treatment. For most of these patients, they respond well with gonadotropins. Second set of patients, this slide will help you in normal oligospermic patients. So if FSH is less than 5, then there is very high chance that with your treatment, with your antibiotics or anti-inflammatory medications, antioxidants, there is very high chance that this patient will improve. They may not need any procedure. Second set, 5 to 8. See why these levels are important is, when you do FSH, most of the labs, they give upper limit of FSH as 14 or 18. Some labs says 14 or some labs says 18. And most of the people, they think that even with FSH 12 or 13, they think that this patient is normal. It is in the normal range. But actually that is not the case here. The actual cutoff for FSH, clinical cutoff for FSH is 7.9. That means if a patient is having FSH more than 8, that means there is something wrong with the testis. You don't look at the upper limit, you have to take 8 as cutoff. If FSH is, that is why I said 5 to 8, there is a doubtful scenario. That means something is happening in the testis, so you have to be careful. And if it is more than 8, FSH is more than 8, then this patient is unlikely to improve with medications. So they need some treatment. Better, instead of wasting their time, refer them to a fertility center. And FSH is very less than 1 point, then it is hypogonadotropin or hypogonadism. So now, when you are doing FSH, one important point what you have to see is whether this patient has taken clomiphene citrate or not. If the previous doctor already she has put him on clomiphene citrate, obviously FSH will be on the higher side. So when you are doing FSH, just ask the history that whether he has taken any medications or not. And this slide tells us FSH, normal FSH is always inconclusive. That means we have good prognosis, but you can't actually say patient is this is in case of obstructive azoospermic patients. Normal FSH doesn't mean that they have normal spermatogenesis. In at least 20% of patients with Sertoli cell syndrome, they can have normal FSH, but there can be no spermatogenesis in biopsy. So coming to ultrasound evaluation, now that means after hormone evaluation, and there are only 2 ultrasound tests what you can do for this patient. One is scrotal Doppler, second one is transrectal ultrasound. Scrotal Doppler can be done in any diagnostic center, any good radiologist will do scrotal Doppler. What you have to look in scrotal Doppler is ask your radiologist to mention testicular value for in the scrotal Doppler report, because testicular volume, again this is very important. If testicular volume is less than 8 cc, that means this patient is having low volume testis. If testicular volume is more than 8 cc, that means it's a normal volume testis. So coming to transrectal ultrasound, only few radiologists who are trained in this can do this, and not every patient needs transrectal ultrasound. This is little painful test, So only two scenarios you have to ask for total transrectal ultrasound. One, persistent low value ejaculate in spite of normal testosterone levels, or persistent infections in the semen. So to find out the cause, you can do transrectal ultrasound. So coming to treatment, I have only few slides. This is an important slide. This will tell you what hormone to start and what not to start. So now, the first one what we commonly use is clomiphene citrate. For males, 25 milligrams is the ideal dosage, not 50 milligrams and 100 milligrams. Always start with 25 milligrams, and this is not for everybody. Only patients, if FSH is on the lower side, start clomiphene citrate. If FSH is already more than 8, better don't start clomiphene citrate, because this patient is not the ideal candidate for clomiphene citrate. So if FSH is less than 5, is the ideal candidate for clomiphene citrate, they will help. And after giving clomiphene citrate, the olden days what we used to do is we used to give clomiphene citrate for 3 months. But don't do that. Or give it for only 25 days or 20 days or 30 days. Now I have decreased my duration for 20 days. I give clomiphene citrate only for 20 days, and I check their testosterone levels after 1 month. So what you can do is safely, whether 15 days or 20 days, you can give clomiphene citrate, and when patient comes back, you have to check their testosterone and estrogen levels. If estrogen level is on the higher side, next month you have to start either letrozole or anastrozole. So clomiphene citrate, not for everybody. If it is testicular failure, don't give clomiphene citrate. FSH is less, they are ideal patients for clomiphene citrate. If a patient comes with low testosterone, with low FSH, this is the ideal scenario and cheapest drug. And if patient is obese, then always don't start with clomiphene citrate. Either start with anastrozole or letrozole. Anastrozole is 1 milligrams and letrozole is 2.5 milligrams, but they are not daily doses. If it is anastrozole, give once in 2 days. If it is letrozole, once in 3 days. Because in spite of giving once in 3 days, now still I am seeing some patients with decreased libido. Because estrogen levels are important for males also. Sometimes what happens, even if you put them on letrozole, that will totally suppress estrogen levels in males. So low estrogen also can decrease libido in males. So most of the patients again with low libido, low estrogen levels, they come with sexual dysfunction. So low estrogen is also dangerous to men. So now letrozole only 2.5 milligrams once in 3 days, once daily, that will help. And gonadotropins. These are safe drugs, but quite little expensive, but they are safe drugs. So whenever a patient is having low testosterone, high FSH, my ideal way of treating is I will give gonadotropins. Gonadotropins means I give only HCG either 5,000 international units once a week or 2,000 international units thrice a week, but most of the males, their compliance is very less. Even weekly once injection, it's difficult for them to take. So give HCG 5,000, which is easily available in most of the places. So this will increase their testosterone levels. 4 to 6 injections will improve their testosterone levels, and it also helps in spermatogenesis. So varicocele, it's not for everybody. Grade 1 varicoceles, generally there is no need for varicocele surgery, because there are days where the moment we used to see varicocele, we used to operate. Nowadays, grade 1 varicoceles and unilateral grade 2 varicoceles, there is no need to operate, because they don't cause severe damage. If it is only grade 3 varicocele on one side or bilateral grade 2 varicocele, then it's worth operating. Otherwise, grade 1 varicoceles are not to be operated. So how to find out which patient will improve with varicocele surgery? This is an important slide. If patient is having low FSH, grade 3 varicocele or bilateral grade 2 varicocele, there is very good prognosis. That means patient improves well with varicocele surgery. If there is high FSH is more than 8, it is only to improve the quality of sperm and to decrease the DFI. That means if a patient is going for ICSI procedure, already FSH is very high, his DNA fragmentation is on higher side, then we have to. Because legally next generation we have to face issues, because even doing varicocele surgery sometimes it will trouble us. So now in this set of patients, it is only to improve the quality of sperms. We will clearly tell the patients that you don't expect any improvement in concentration part, and don't expect any natural pregnancy after varicocele surgery in this set of patients. And third important one, if you see a patient with gross varicocele and azoospermia, whether to operate or not. So what we do nowadays is we don't do varicocele, we do fine needle aspiration. If fine needle aspiration says hypospermatogenesis or late maturation arrest. Late maturation arrest means you have to see spermatids in the histopathology report. Then only we will go ahead and do varicocele surgery. Otherwise, there is no role. If it is Sertoli-Cell-Only syndrome or germ cell aplasia, there is no role. In spite of having grade 3 varicocele with azoospermia, no need for varicocele surgery. Regarding micronutrients, these are the common micronutrients. You use a combination instead of individual micronutrients. You select the micronutrients which has all-inclusive one, like coenzyme Q10, lycopene, L-carnitine, zinc, astaxanthin. And only thing is you have to look for the budget. If patient is not affordable, then you can put them on vitamin C, vitamin E, astaxanthin and selenium. Nowadays even astaxanthin alone is in the market. 8 milligrams of astaxanthin will help these patients along with vitamin C and vitamin E. So coming to antibiotics. So now when you see a patient with positive semen culture, so my favorite antibiotic is doxycycline. I generally give it for 2 to 3 weeks, because if a patient is having chlamydia infections, because in India, in particularly poor socioeconomic people, STDs are very common. Chlamydia, you can't identify chlamydia in semen culture report, and chlamydial infections can cause urethritis, prostatitis and seminal vasculitis. And doing a PCR test for chlamydia is very expensive. Again, PCR, they have to spend around 2,500 rupees for PCR. So this works for most of the STDs. And I think according to dermatologists, there are only 2 favorite drugs for dermatologists. One is azithromycin and second one is doxycycline. They treat most of the STDs. So when you suspect some infection, even culture is not possible for you, start them on doxycycline. It's a safe antibiotic, 100 milligrams twice daily for 2 to 3 weeks, or azithromycin 250 milligrams for 12 to 18 days. But when it comes to culture positive patients, if culture is positive, most common bacteria what we have identified is Enterococcus faecalis. Simple ampicillin 500 milligrams twice daily for 2 weeks, that is more than enough. But only thing is, most of the times ampicillin, long-term ampicillin will cause antibiotic induced diarrhea. You have to add some probiotic along with ampicillin. And if ampicillin, after ampicillin therapy, still patient comes back with Enterococcus faecalis, then you can start linezolid 600 mg BD for 10 days. And along with that, you have to give some multivitamin. And ciprofloxacin and levofloxacin. Previously, I used to give ciprofloxacin and levofloxacin. Now, most of the patients, they're coming back with long-term levofloxacin. They're coming back with knee pains and leg pains. So that is why now we have giving only OD doses for 2 weeks, either ciprofloxacin or levofloxacin. And most of the patients for long-term ciprofloxacin, they are allergic. So we have to be careful. I think this is my last slide, doctor. So there are certain don'ts in male infertility treatment. One is clomiphene citrate. This is not for everybody, as I said. And there is no role for testosterone injections, because we see many prescriptions where when there is testosterone deficiency, most of the general physicians, general surgeons, are sometimes even gynecologists, they prescribe testosterone injections. So testosterone is totally contraindicated in male infertility. Only in people who have completed their family, they can only for maintenance of testosterone or as a TRT, testosterone replacement therapy, you can give testosterone injections. And there is no role for multiple antioxidants. Ideal dosage of coenzyme Q10 is 200 to 300 milligrams. Make sure that your antioxidant dosage is not more than 200 milligrams. Only in severe varicocele patients and severe infection patients you can give up to 300 milligrams per day. Most of the tablets has 100 milligrams coenzyme Q10 in the tablets. Some brands are coming with 300 mg now. 300 mg it should not be given as twice daily. And varicocele ligation, we generally don't recommend for subclinical varicoceles or grade 1 varicoceles. Thank you, doctors.
The prolactin levels comes high. How much weight?
So generally my cutoff is 50. If it is more than 50, I ask for MRI. Otherwise, less than 50, sometimes lack of sleep, people who are into night shifts, and people who work late at night, stress, it can also increase prolactin. So we have margin of error. We don't generally refer to endocrinologists also. If it is more than 50, then we refer them to endocrinologists. We start with cabergoline. Cabergoline. Cabergoline 0.25 or 0.5. Weekly ones. Weekly ones, only thing is you have to tell them that when they start this medication, they might have some headache. When we start cabergoline, ask them not to worry. And weekly ones, you can give 0.25 milligrams.
How many weeks?
4 weeks. 4 to 6 weeks. Generally what we do is after 4 weeks, we ask them to come back with prolactin levels. Generally we are used to cabergoline.
You didn't mention that HCG injections, only the HCG injections.
Yes. HCG injection generally for regular patients we don't have to use HMG. Only in hypogonadotropic hypogonadism where FSH LH is very on the lower side, there we need HMG injections. HMG injections in case of hypogonadotropic hypogonadism, they will have low secondary sexual characters and low value testes and small penis. So initially you have to prime them with HCG injections or testosterone injections, or once you prime them with HCG, then you have to start HMG. Without priming them with HCG, HMG may not work. So then first their testosterone level should come to normal range. Then you have to add HMG. HMG is 75 international units, weekly twice or thrice.
Thank you.
Thank you very much, sir. It was indeed crystal clear concepts of male infertility, and I hope all our future practice of male infertility is going to change in a very good way. I would request Dr. Sita Lakshmi to hand over the token of momentum to Dr. Rahul Reddy, sir. Thank you, ma'am. Thank you, sir. Please go ahead.
దాన్ని అనుకుంటారు మ్యాగ్
తనని అడగండి.
Now I will take you to a brief introduction of our next speaker, Dr. Narmada Kathakam, ma'am.
అది దానికి సి టైప్ ఉంటుంది అనుకుంటాను కదా దానికి.
Dr. Narmada ma'am is a fertility specialist and minimal access surgeon. Ma'am has graduated and done her post-graduation from Usmania Medical College. She has been working in the UK from 2004 to 2017. She has done MRCOG in 2004, FRCOG in 2017. She had underwent fertility training with British Fertility Society, BFS UK. She has approximately 150 national and international presentations, authored several chapters in international textbooks. She has special interest in adjuvant therapy, and which she has contributed to the chapter as well. Adjuvant treatment and alternative therapies to improve fertility, BFS RCOG book 2019. In the chapter Assessing the Female Infertile Couple, Clinical Reproductive Science, Wiley textbook 2018. She has great passion for teaching, and she has been a trainer and examiner in UK. She is a national trainer for MyoSure hysteroscopic modulator for removal of submucous fibroids, regional trainer in laparoscopy skill course, regional trainer in maternity acute illness management course, also co-authored GM-AIM course manual. She is also a mock OSCE examiner, PLAB question writer. She moved back to India in 2017 and started her passionate Genesis Fertility and Laparoscopy Center in Kottapet, Hyderabad. Presently, she also offers laparoscopy and fertility fellowship courses for the eager young minds. Now I request Dr. Narmada ma'am to have a detailed discussion about the dilemmas in infertility.
I also wonder why I'm in Hyderabad, not in UK. After listening to all that. Yeah. So I'll take you through 4 cases. Where sometimes you think, I wish I could have done that, or you think, oh, this didn't occur to me, or you think, oh, she got pregnant despite of me. So these will be the cases where we all are in the practice and think of these situations, and always learn from them and try to repeat the same thing. But repeat the same thing will not work in the other patient. It worked in her, not in the other person. So 4 cases. I'll quickly go through. Case 1, obviously infertility. This is 2018. That was very first year of my starting Genesis. I was still learning to acclimatize to Indian patients, Indian mentality, Indian products. So this is she was 26 then, with a husband who was 36-year-old, attends with brother and mother. Husband was not in attendance. Primary male, female and couple infertility, married 10 years by then. So this is MT, she was a homemaker, normal BMI, regular periods, Mr. BT financier, no medical surgical concerns. Fertility, quite a long journey. I don't know how many of you know this. DNC is one of the treatments offered to females for fertility, which is not. They might get pregnant for whatever reason, but DNC is not a treatment. Probably the only indication where you do a curettage is where you suspect a tuberculosis. Don't do DNCs, don't scratch the endometrium, don't curate the basal lamina and give them Asherman's. So anyway, 2009, it was proliferative phase. It will not give me any clue because she doesn't remember if it was done in the first 15 days of the cycle or second 15 days. If it was done in the first 15 days, it's matching, it's proliferative phase. But it was done in the second 15 days, she has severe luteal phase deficiency. That was not any use to me. 2010, she had HSG, both tubes were patent, and she had ovulation induction and timed intercourse, 3 cycles. After that, she was fed up and took a break for 2 years. 2 years later, same HSG and 1 more ovulation induction. In 14, she had diagnostic hysteroscopic laparoscopy and everyone's favorite laparoscopic ovarian drilling, and 15 cycles of ovulation induction and 1 cycle of IUI. 15 another cycle of ovulation induction. Looking at the hormonal profile, thank God, despite of the ovarian drilling, AMH was still 3.12. All the hormones are normal. The easiest way to remember prolactin and LH, you want them to be single digit. Ideally less than 8, but at least remember the single digit. Prolactin was normal. TSH 3.55. Any thoughts? on TSH? Naeem, mic dena? I heard a chorus, I heard number 2.5 many times. Did someone say that? Yeah. So, the summary from this, what we see is somebody has multiple attempts to make her pregnant. Somebody has TSH slightly higher. Semen analysis, that was done 4 years ago. Count, motility, morphology was 80, so I'm not going to comment on that, but count and speed is good. Puzzles, ideally less than 1, but don't know. And again, she came with the HSG film. How does it look? Is there a uterus? Arcuate uterus, I have one answer. Anything else? So previously this term arcuate uterus used to exist. It's obsolete now like a dinosaur. It doesn't exist. Okay? So what we see, the fundus is not straight. That much is clear. And on a 2D, we cannot say it's arcuate or septum or bicorporous. We need a 3D. We agree on that? So let's proceed. So that was a dip. So factors in favor, she was still very young age, she had good ovarian reserves and she had patent tubes. Issues of concern, lot of IUIs and ovulation, lot of ovulation induction IUI. A partial septum it was 12 millimeters partial septum. TSH was slightly raised in 10 years of married life. So factors in favor, I'm happy that there's still so many factors in their favor. Issues of concern probably, obviously I have to address. The way we address is ovulation induction, it won't work unless you correct the rest of the issues. So partial septum, I showed the 3D picture on the screen. I was very proud of getting a good 3D image. And then said TSH is only needs slightly improvement. And we also got TPO and anti-thyroglobulin antibodies and husband investigations. They revealed raised antibodies and hypothyroid. So I told, let's correct these hormones, let's remove the septum and then proceed. This is the second visit. Husband pushed the chair back and stood up. We went to so many hospitals. Don't you think they would have identified all this? And you are saying removing this will make my wife pregnant. I said, I cannot say what people didn't see. I can only say what I see. And there are various reasons. Things change, equipment changes, exposure changes. I'm happy to help if you want to take the help. So that was her 2D and that's the 3D. 2D doesn't give any information in infertility unless it's normal, and normal is retrospective. So discussion I had with the couple, explained. So who was behind getting the treatment and is the lady's mother. I don't know, maybe it happens in your practice as well. The first pregnancy, responsibility is parents. So that mother was fed up of taking her to all these hospitals. 18th septum, I asked them to come back with abstinence of 6 weeks and allow the septum to heal. Came in October, did the 3D scan, straight line, well healed. TSH and ATH was also good, normal by then. I said, you can come back for, I don't want to recommend ovulation induction. Higher success rate will be IUI, but you can decide which one you want to choose. Both are good. What changes is the time to get pregnant. If you want to get pregnant quickly, come for IUI or ovulation induction. Guess what?
Natural conception.
Done? IVF 80 was also explained if they don't want. Jan, she came with UPT positive. And then 21, she came with second spontaneous conception. I only 2-3 months ago delivered the second baby. So we only need to look properly. My learning was, not everyone needs IVF even if they have 10 years of infertility. Even if infertility lasts for 10 years, it's a jigsaw puzzle. Put all the pieces together. Only if you can, you know that there are a lot of pieces to put together, you will be successful. Every little helps. ATG, TSH, septum. Maybe if I remove the septum, maybe she would have had a pregnancy and a miscarriage, but not a successful live baby to take home 2 of them. So have a well-rounded picture. Yeah. Case 2. I've taken what is more common, what I see in Genesis. The reasons of infertility in Genesis will be very skewed from what you see in the textbook. Because they all get filtered at your levels and only the filtered come to me, so I won't say it. Those are the most common reasons. But probably septum we see 2 or 3 every week. Most of them will be around 10-12 millimeters. Only few of them will be complete septums. Partial septums are very common and we don't overdiagnose. The second common thing we see is premature ovarian failure. I don't know how many of you are seeing 22 years, 25 years with AMH less than 0.25. And all the plastic information Dr. already gave, probably that's applicable to both sperms and the eggs. So help your next generation, maybe your kids or your sisters not to use those plastics. 22-year-old accompanied by mother. So most of the cases are accompanied by mother, and the problem is with the female. Oligomenorrhea, menarche at the age of 15, spontaneous first cycle, and she barely had 7 to 8 cycles since 1 year of married life. And as you all know, they won't tell they have oligomenorrheic cycles when they get the wedding done, and then they come and tell us, first walk into the room and say, "Athaniki chappakandi regular periods ravali." So that's fine. Basically, they attended for regularization of the periods. They didn't come for infertility actually. Scan showed normal uterus, but very small ovaries. What are your thoughts? Okay, so if you say Turner syndrome, ask me if she was phenotypically normal.
Mosaics can be there.
Mosaics can be there, yeah. So phenotypically she was normal. That was my thought too. Then I was thinking, then uterus can be normal. It can be normal. But most often, if the ovaries are small, if they are hypoestrogenic, if you catch them early and treat them early, like the parents bring them to you at the age of 11 or 10, not probably 11, you start them on estrogen, the uterus also grows. Sometimes parents come very late, obviously hypoestrogenic or hypogonadotrophic, hypogonadism. At that point, if you start, the uterus will not increase in size. Anyway, so my thoughts, ovaries are not living up to the mark. It's not a recent issue. She's having these problems right from the beginning. It could be the cause, or it is the cause behind oligomenorrhea. So I obviously got AMH, FSH, LH, karyotyping, and one thing we all need to not to forget, importance of Fragile X, which is an underdog and quite common reason for premature ovarian failure. Results, what could be the AMH? FSH? LH? Karyotyping? Normal or abnormal or mosaic, okay? Fragile X? Yeah, otherwise I wouldn't present it. Fragile X is an X-linked dominant. So she got it from her mother. Her mother could have children. So if I say you have a problem, your ovaries failed, but you might have got it from your mother, then she'll be thinking, my mother got pregnant, why will I not get pregnant? Anyway, I had to do all my counseling of all changes of whatever counseling you do for the menopause about the bone, skin, hair, sexual activity, and then reproduction. First reaction will be, I only came for irregular periods, what is she talking about? But giving education is my job. When they want to take action is their job. So I have to tell them, the ovarian reserve is low. When are you considering fertility? Be aware that your fertility chances are very low. My dilemma was, obviously I looked for what's Fragile X. Most often they present with learning disabilities, cognitive impairment, it's more common in males, mutations in FMR gene, and associated premature ovarian insufficiency, not failure. She only ticked 2 boxes. It was FMR1 and Fragile X. So I explained everything. When results are low, only few ovaries left, it's like hitting menopause. Donor oocytes is one option to get pregnant if you consider. FSH, LH is raised, your brain is sending signals, but your ovaries are not receiving the acting, that's why the hormone is more in your blood. The genes are normal, and we told everything about the Fragile X. We explained the process and cost about IVF, ET, and fertilization and transfer, success rate, everything. And this was the whole summary is about from 3 consultations, and advised to attend the day 1 of period to start hormone replacement therapy for donor IVF cycle. Guess what? Paru boyindi. She came back pregnant very next month. So what is my learning? Never tell someone you cannot get pregnant naturally. So rephrase it. I'm not saying you cannot get pregnant, but it's little hard. It may take a little longer. So another premature ovarian failure. The reason I kept 2 premature ovarian failures back to back is to say that everybody won't come back pregnant naturally. Please act on it. Do whatever you need to do. 26-year-old female with 28-year-old male, primary male-female couple, never been pregnant, married 2 years by then, 4th degree consanguinity. Mrs. DR, she was homemaker with a BMI 21. Only withdrawal. So she was a case of primary amenorrhea who had only withdrawal. 19, she had hysterolab dye test, which showed normal size uterus, small ovaries, patent tubes. The story is very similar to the other one. Hormones are also very similar. FSH 42, 74, 67. I didn't understand the need for repeating FSH once it is hypergonadotrophic hypogonadism, but I think we have to do something if then they change the clearance. You say I'll repeat and see if it changed. It only changes to be the same. She was hypothyroid. We also identified that she has raised antimicrosomal antibodies. Karyotyping was normal. Did a 3D scan, normal 3D cavity. Uterus is only a tad bit smaller. Ovaries were pretty small, almost non-identifiable. So it's a case of premature ovarian failure with hypergonadotrophic hypogonadism. Same story. Your FSH is raised, your brain is releasing the hormone, your ovaries are not working. Probably you need donor eggs. Coming to the husband, he was hypertensive on calcium channel blockers. Semen sample was normal. DNA fragmentation was slightly raised at 20. Karyotyping was normal. So before she came to me, she had 6 cycles of ovulation induction in the center where she had hysteroscopy and laparoscopy and dye test. Oocytes are barely there, 0.01 AMH. FSH is raised and LH is raised. It's a hypergonadotropic failure. Please do not try ovulation induction in those cases. It's wasting time. All the 6 cycles, ovaries are not even visible. You won't see AFC, you won't see the dominant follicles. Let's say you want to try once, try twice, don't try 6 times. So my dilemma, will she come back pregnant next month? How shall I phrase it? Was ovulation induction the right choice? How should I proceed next? Listen, your uterus is good, it can carry pregnancy. Donor oocytes for ICSI is one option. Explained everything about IVF and embryo transfer. They agreed. Then the story begins. That was only an interval. 2021 August, we took 12 donor oocytes. I won't go into the details. Sperm looked normal, 12 donor good oocytes. I only got 2 poor less than good quality oocytes. And I transferred. Was not expecting anything great, and it was negative. Tough counseling. Because first time you say you need donor eggs, and then now you say donor eggs are from young girls, but they didn't even fertilize. Why did they not fertilize? And if you say maybe the oocytes are not good, then why did you take poor quality oocytes? We trusted you to take them. And how can I know the quality of the oocyte? They appear good. I don't know. And can I say I don't know? I can't say. What next? A lot of cost incurred, a lot of disappointment. I don't know if it was to do with the oocyte. Then I said, let's try 2 different donor oocytes. If one of them was not good, the second one will be good. Maybe we get enough sets so that you don't need another cycle, because I can't promise pregnancy in the first transfer. Even if you need 2 or 3 transfers, you will have enough embryos. I thought they won't come back, because they already spent so much, and I'm saying spend double the money you spent. They came back. I took 24 oocytes, 12 from 2 different young women who already mothered 2 kids, karyotyping normal. Cost was double for those sites. Only 7 fertilized out of 24. And we didn't get a single blastocyst. No embryos to transfer. You would expect a ruckus there, isn't it? I was just lucky. Then it hit to me. Could it be the sperm? Took a long time to think about it. Cost was a bomb. When there was no blastocyst, just imagine my face of my embryologist and myself. What am I going to tell them? Discussion. We have reviewed the speed, count, and DNA fragmentation, but we have never reviewed the genomic analysis. We highly recommend. This is what Anuradha was talking about, gene anthropology. Absolutely. Probably I send around 100 cases a year. Not even once a year I get a normal sample. Again, don't take my word because I get very filtered cases. They have not been managed to get pregnant by a lot of means, and I get very high positive index. And she doesn't give me any commission. Her reports tell what the problem is, what the treatment is, what fertility recommendation is. So it just gives a very good idea. So anyway, I told them, spend on gene andro. If gene andro is normal, I'll do a free cycle because it's my fault. If gene andro is negative, you bear the cost. I thought they won't come back. They came back. Will they turn up? They did. And the gene andro was negative. Catsper 1, and he had 2 FSH receptor gene deficiencies. In those cases, the fertilization will be less. And I've seen that Catsper name, it gives me nightmares. I've not seen a single positive case, even in cases of oats. If Catsper is there, either I don't get fertilization, even if I get fertilization, I don't get a positive test. And I can't say, there's no research and publications, but I've not seen a single case of Catsper. Do you want to proceed with donor sperm? I still tell them, I've not seen it, but it's your choice. So the option of pharmacological guidance was treatment with recombinant FSH for 2 months, which is 100 recombinant FSH twice a week. And usually we advise for 1 sperm cycle, which is 70 days, and then ICSI after 2 months. Couple were sane this time. They went home, thought about, I thought they won't come back. They came back and said, we like your honesty. We want to go ahead. We don't want any more IVF. Just to do a donor embryo transfer. Phew. First said she was pregnant. I just discharged her back to her consultant after NT scan only last week. So all premature ovarian failures are not easy. And my learning was, it's so easy to carry away by the elephant in the room. You think that's the only reason. You forget about looking at other things. At least after 1 failed cycle, I thought I should look again into the male factor. Look beyond semen analysis, even if the ovaries failed. So that was my learning. The last case, it's for A, B, C, D, E because it's all about hypoxia and various referrals we get for hypoxia. These are the cases attending for hypoxia. It's a tubal patency test, ultrasound guided. We use 8 French folies and we inject 100 ml of normal saline with 20 grams of xylocaine jelly. So the xylocaine jelly becomes like water bubbles. Saline is black, bubbles are white. So when they go through the tube, you can see the white and black starry sky appearance when the fluid fills through the fimbrial end. And patency is noted on the scan. First case. I always do a scan before inserting the Foley so that the Foley's bulb will not block if I have to see something. So this is the scan. Anything quite obvious in your face? Could be polyp. So there's a well circumscribed heterogeneous mass noted at the fundus. Oh, I can see something. Let me do a 3D. Yeah? So that was a sessile fundal polyp more towards the left side. Doppler, there was a feeding vessel more suggestive of a polyp. If it's a fibroid, it will be a skirting vessel. So, can I proceed with hycosis? The polyp will still block the implantation. I can proceed with the hycosis for completion's sake because somebody asked me to do, but it's tough to do so. I can't tell anything to the patient because she's referred by the gynecologist. So I just tell the patient, go and show the report to your madam, and I call the consultant and tell her, this is what it is. Ideal thing is hysteroscopy followed by resection, because will this come with a blind DNC? No. You'll get bits of it. You'll get the biopsy as polyp. You'll proudly show the patient the polyp has come out. The polyp didn't come out, a part of the polyp came out. Hysteroscopic guided will be sure shot. So I told the consultant, hysteroscopy, polypectomy, at the same time we can do the tubal insufflation. Send her back. Case 2, 3D scan. We always do a 2D and 3D before for any outside referrals. Our own cases, we already do a 3D in the initial setting. So this is, you've seen so many of these since morning. Yeah? Partial septum. So inform consultant, can proceed with hycosis, but best option is polyp, it has to come out because it's foreign body, it will change the endometrial implantation and everything. Septum, I find it hard to strongly recommend surgery because there are so many people who come as para 1 and have a septum coming for second pregnancy. Septum may cause implantation failure or a miscarriage if the implantation is fundal. If it's on the lateral wall, they're saved. If it's at the corner of the septum, they'll be saved. So I called and said, best option is hysteroscopy, resection of the septum and tubal insufflation, especially if it's long-standing infertility or if there's any history of miscarriages. I see people coming within 1 year asking, just want to check if everything is okay, we want to leave it for 2 years. In those, if I find a small septum, I tell them, remember this is there. If you start planning pregnancy with no contraception and if you don't get pregnant, come back to me. I don't want to operate at the moment because spontaneous pregnancies do happen. Another case, they come with the semen analysis report, count 2 million, motility 0, normal form 0, coming for hypoxia. Should I do or not? And it's hard to say, is sperm barley and they come back pregnant next month. That's all. Whoever thinks fertility disease, it's not. Do I do hypoxia? So one of my colleagues was saying, we can do no madam, next time we can offer donor IUI. I don't want to do a procedure while we offer not own gametes without even discussing about it. If they make up their mind, because if she wishes ICSI with husband's sperm, that sperm can be slightly improved and we can do ICSI. Then I'm doing unnecessary hypoxia, she doesn't need a hypoxia. And who wants a hypoxia? It's damn painful, it's uncomfortable. If we can avoid it, we avoid it. So that was one. Another case, 4D. Previous ectopic, pelvic cox. This is the history. Sent for hypoxia. Will you? Previous ectopic was a result of a tubal damage. Agree? Both tubes lie in the same cavity. Agree? When one tube is damaged with one infection, the same infection will affect the other tube also. Agree? Damage might be different. One tube might be more damaged than the other. Ideally, with previous ectopic, the best thing is laparoscopy, especially to see any hydrosalpinx and tube-ovarian relation. There's no harm in doing hypoxia, but you'll be opening a tube to land an embryo and give another ectopic. Pelvic cox is hypoxia best option. Tube-ovarian relation will be where we don't know where the fimea is and where the ovary is. That's not the best option. So they sent her for in such cases, if you really need to do, and if the consultant insists, just explain to the consultant and the patient. If you get pregnant, get a pregnancy test as soon as you miss the period and get the beta HCG done to check the location of the tube pregnancy. So this is one of the pelvic cox we operated last week. This is the view I have when I put the scope, except the pelvic yellow. Yeah. just a sheet of omentum, and then this is one of the tubes. This is a different case. So the history of previous ectopic and pelvic cords. Can you identify what this is? Huh? It's called something, starts with I, 2 words, second word starts with N, isthmic anodosa. Yeah? So left tube was isthmic anodosa. I was thinking that can't be ectopic, it's not congested at all. Menstrual flow normal ఉంటుంది. There was no hematometra, which means obviously what she's telling is true. She's having complete flow of the menstrual blood. Then where the punctum was, I took an IUA catheter and put it in and saw abdominally where it is leading to. So there was cervix. This is the top end of the, whatever was the blind end. It was leading into that free space. So the menstrual blood is dropping into this free space, and then through this punctum it's coming out. Then what should be the next question? There's a short vagina with a punctum. They don't. Huh? Fistula? No. It's a fistula because it's between two cavities. People don't reveal because they don't know what information is important to reveal. ఏమన్నా ఆపరేషన్స్ అయ్యాయమ్మా? అయింది కదా? ఏం ఆపరేషన్ అయిందమ్మా? She took a book from GMH. They give the discharges in the notebooks, isn't it? So she was a case of primary amenorrhea. She went to GMH. There was a transverse vaginal septum. She got it operated. This information about the post-op checkup also, examination done, resected septum healed well, discharged, patient got 2 periods. She is happy, doctor happy. I would have also been happy if I operated that. Has a short vagina and a punctum. Incomplete resection of the septum. Job is done because she's having periods, and then she slowly tells me, "My bath irthunnadu, sexual satisfaction undatledu." They don't know that it's an important, relevant question to the problem they have. When I saw the short vagina, I asked it because of the problem undunda. I don't have any problem, but he's scolding. Anyway, I planned for resection of the transverse vaginal septum. I wanted to resect, then look into the uterus, and also do laparoscopy and digest. And at laparoscopy, I was expecting endometriosis. I was thinking every time she's menstruating through the tubes into the pelvis, and that is coming into the vagina. But I think endometriosis will happen only in people who have that angiogenicity or whatever it is. In normal people, even if you put a liter of blood, it will get absorbed, I think. So this was the punctum. Opened it, dreaded, thinking, hoping I should not go into bladder or bowel. Ultrasound guided, catheter, thick folds in the bladder. I could find the deep recess. Exteriorized the cervix. Hysteroscopy was normal. Laparoscopy was normal. Dye test was positive. It took around prescribed vaginal dye test because wherever I resected, that will give a band of ring. Full length healed vaginal cavity was achieved within 3 months. Husband happy, wife happy. They're trying for natural conception now. I'm hoping to hear good news soon. Learning free flow normal menstrual cycle does not mean a well calculated vagina. Always take this try. Look carefully. Listen to them. Thank you. That is not the give momentum, but I'm saying it's only my limit.
Thank you very much, ma'am, for sharing your pearls of clinical pearls of wisdom with all of us and making to us the clear about the strategies to look over the entire spectra, not just localizing one particular cause. It's been really helpful. I hope all our audience have had a very huge learning experience and thoroughly enjoyed it. Thank you. Now we would present a token of memento to Dr. Narmada Katakam ma'am. I would request Rahul Reddy sir to please present the memento. Thank you, sir. Thank you, ma'am. Just few more minutes for the vote of thanks.
Just 2-3 minutes for vote of thanks. A massive thank you. Thank you to all my teachers who took time to come and attend and make us feel that we were in 2020, 97 to 2020. Thank you to all the speakers who are so eminent but took so much time on their Sunday and have blocked them not only for the session but the panel, and each one had to spend at least 4 hours here. And without delegates, obviously, there wouldn't be any joy of doing all this hard work. Thank you to all you who took time on a Sunday and spent so many hours. Thank you to the sponsor, Intas. And thank you for the team behind the success. And I want Srinivas, Giri and Venkatesh to come onto the dais. And if someone who is wondering, how do I do my clinical practice, organize a CMA and also give talks and prepare the talks? It's all because of Tirupati, my manager. He's all around there, he helps me in everything and anything. The only thing I tell him is I want this and it is done. And throughout the conference as well, I was constantly texting me to do this, do that. In few minutes, I always get a response. Thank you so much for being with me. Team Genesis, even though you drive me crazy, you're all left. Please come on. Sablu. No. Tandraga. On the count of 3. Nurjahan. Majli ki phone number photo lega.
लाइट है आया रमन सार में
जल्दी
కొందరు కింద ఇక్కడ కూర్చోండి దాని మీద
కూర్చోండి Even though they are not here, my kids are always beside me, ahead of me, and guide me in whatever I'm doing, and nothing goes without them, any joy or happiness. And finally, massive thanks for allowing me to live life to the fullest, my husband, Dr. Venu. Venu, sir, thank you for allowing me to live life to the fullest, please. Thank you so much. Just take a picture.
A table is
బ్యాక్ సైడ్ ఇటు వచ్చేసి జరగండి
బ్యాక్ సైడ్ కొంచెం ఫ్రంట్ రండి
కొంచెం మీరు కూడా ఫ్రంట్ ఏ ఆ చైర్
రెడీ
ఇక్కడ చూడండి అన్న. ఓకే, స్మైల్ స్మైల్.
ఇంకా బ్యాగ్ ఉందా?
యూట్యూబ్ లైవ్ వస్తుంది.
ఓకే, రెడీ మ్యామ్. స్మైల్ స్మైల్.
ఓకే,
ఫోన్ అని తీసుకో. మేడం మేడం
Just one last thing. Samata Akiri. Samata endured working with me for 6 months and completed her fellowship. And I'm honored to give her a completion certificate today. We call it a day. Have some coffee and have some pictures and then you can leave. Thank you.
Back.
Okay, ready. Smile.
Close.
Oh.
బ్యాటరీ ఛార్జింగ్ తీసుకొచ్చినా?
Okay, ready now? Oh. Ah.
Madam, okay, photo. Madam.
Okay, ready, ma'am.
Okay, okay.
Okay, ready, ready.
Okay.
కింద కూర్చో. మీరు పైకి వెళ్ళండి మేడం.
కింద అంటే ఆ టేబుల్ మీద కూర్చోండి. మీరు పైకి వెళ్ళండి. మీరు పైకి వెళ్ళండి.
మీరు పైకి వెళ్ళండి.
మీరు పైకి వెళ్ళండి. వాళ్ళని కిందికి రమ్మనండి. మీరు పైకి వెళ్ళండి. వాళ్ళు కిందికి వస్తారు.
ఓకే.
పైకి తప్పకుండా ఫోన్ అంటే తీసుకో.
మీరందరూ ఇక్కడ కూర్చోండి.
ఫోన్ అంటే తీసుకో. ఈమె
సార్
ఒక లైట్ ఆ లైట్ కొద్దిగా వెనక్కి పెట్టుకో.
వెనక్కి పెట్టు లైట్.
కొంచెం తిప్పు. ఓకే
ఓకే, రెడీ, స్మైల్.
ఆపు. వెనకరా నువ్వు వెనకరా.
వెయిట్